of Wirecast. This is a demonstration 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 of Wirecast.
mother. And when they're done, gently close it, and that should go through about a 3 millimeter distance. Above the shelf, very little room down below, and so it encourages the tongue to be elevated. And these are the tabs to keep the mandible forward. It prevents the mandible from slipping back during sleep and during the day, so they get very efficient mandibular advancement from this. We have a split version. I do not like this appliance very much because it's only worn for about 4 or 5 months. In a child that is mouth breathing, that has a hard time accepting the appliance, this just makes it a little bit easier. It's not worn more than about 5 months. And so then we would switch it to one that is closed in front. Anyway, but it is designed, everything else is designed in exactly the same way. So the normal tongue posture for a child is the tongue is elevated in the roof of the mouth, and it's between the 2 arches in the back. So the tongue being wider than the thumb keeps that wide up on top. That's the position we want the tongue to be in. The tongue should be behind the rugae in front. In other words, it should be a little bit behind. It should not be sticking forward between the teeth. When the teeth are parted, they should have about a 3 to 4 millimeter freeway space. Okay? So they spread the tongue interinclusively. Usually at rest, the tongue is between the teeth, but not by very much. That's normal. And they have nasal breathing, and the lips are closed when they swallow. Now, a child that abnormally swallows, you'll see them, purse their lips. They constrict their orbicularis oris muscle, and they usually tip their head down to try and get that food to go down their throat. It's a struggled swallow. And this is an abnormal swallowing position. So the normal swallow then would be that the tongue is in the roof of the mouth when they swallow. The tongue tip is behind these rugae in front. The teeth occlude slightly protrusive in most cases, and there's passive facial muscles. So, you can watch a child without putting water in their mouth. Watch how they swallow. And while you're examining and writing down things, keep an eye on that child to see what the change is when they swallow. They're going to swallow 2 times a minute. And within a minute, you can see them swallow a couple times. And if you can't see them swallow, that's healthy. Now, if we go to an abnormal tongue posture, the tongue is in the lower arch. The tongue tip forward between the incisors. Many times it's resting forward, but not in the palate. And their lips are parted. And they often mouth breathe during the day. And they have an open bite frequently because of the tongue there. Now, the open bite not be too visible, because it might be open because the lower teeth are not hitting the palate. But looking straight on, they might have a big open bite, but maybe they don't. Okay? The abnormal swallow, the tongue position is in the lower arch. The teeth are parted. The tongue protrudes between the incisors to create a vacuum in the muscles, in the face. Facial muscles active with pursing of lip, and the head tips a little bit downward slightly. Sucking habits. Thumb sucking usually decreases, but I don't care. I want to get that habit out of there because I want them to breathe properly. So you can see the incidence of different. A class 2 division 1 is where there's jaw retrusion and the upper teeth are forward. Obviously, this is the most popular one. Open bite also. If they have an open bite, 91% of the time they have thumb sucking habits. Cross bite in the posterior, also very high. So you see the 3 things that are highest are the protrusion of the upper incisors beyond the lower teeth, open bite, and a cross bite of the posterior where they've had a narrow palate. Other things are less. Class 2 division 2 is where the incisors are tipped in, but they still have a mandibular retrusion. That has the lowest. Not much there. So anyway, this was done on 2,000 children by Rakusi in Germany. "80% of the London population have lip incompetence." How come that is? I don't know. You know, but you see it a lot. 28% of thumbsuckers have open bites. So you can see that the thumb sucking decreases with age, normally. But I wouldn't wait for that. I wouldn't wait for that. If you see a 2-year-old sucking their thumb, get rid of it. They don't have to suck their thumb. And every time they want to put the thumb in, have them put that habit corrective in there instead. This gives you some of the other incidents, so forth. Thumb sucking, as I mentioned before, usually reduces when the child enters school. A nighttime thumb sucker is much easier to correct than one that sucks days and nights. So if the child goes to school and they're ashamed of it, they don't suck during the day, but when they get home they'll suck. Those are very easily corrected. Or if the child only sucks their thumb while they're sleeping, these are relatively easy to correct. But children that suck their thumb even during school, those are much more difficult. I had a girl that was 18. She was ready to go to college, and she still sucked her thumb. And she came in and she said, if you can correct this, because I'm afraid when I'm at school with roommates, I'll be sucking my thumb. So we put a thumb sucking device in. We cement it in. It has prongs on it. There are many types of sucking devices, anti-sucking devices. But she wore this all summer long. We took it out. She went to college. The next summer she said, I'd like to have that put back in again. We put it back in. Every summer we did that till she was a senior, and then she was corrected. So you see how difficult it was even to correct that adult. We had another boy that was captain of the football team in the high school, and he was a senior, and he sucked his thumb at night, and so we had to put a device in like that. So these devices work very well, but they have to be left in about 6 months for full correction. Incidents of open bites. Open bites tend to be reduced with age, but again, open bites teach children how to, they're swallowing improperly, and they're usually mouth breathing, so we would like to get rid of these at an early age. Here's a little boy whose teeth stick out in the front of his mouth, thumb sucker, corrected it, and we corrected it with one of these appliances, and you see him at 16 years of age, very mature boy, but it has stayed very nicely. Once you get them back and you correct the habits, they do stay quite nicely. Here's the same boy with the overjet. You see how nicely it stayed back. The case corrected in just a few months. I'm not sure if this is, I don't know what this is yet. Here's a little girl that sucks her thumb quite frequently. And so we gave her an appliance, but she didn't correct it. And if the upper front teeth start erupting, permanent teeth start erupting, I want that thing correcting. If it isn't, I'm going to put a thumb appliance in there. So we put a thumb appliance in, and you can see here is the progress after 1 month. The teeth have come down very nicely. So, but we had to put this appliance in there, and we put 2 bands or crowns on these teeth, soldered them with some prongs. Now there are some that have a little roller, there's some that have a crib in front. They can be designed. I put this in and they stop sucking within about 4 seconds. I mean, it just discourages them, and if they don't want to have anybody know, I just tell children that you're correcting the swallowing pattern on them. That's what that does. But it does correct it. We can wear the appliance right over that. You can see it here, and we just trim the appliance a little bit. And we want the prongs to hit the thumb. If the thumb's on one side, we put the prongs towards that one side. And they have to wear it. If after a week they say, oh, I'm okay now, take it out, we don't do that. We usually leave that in there for 3 to 6 months, and then they'll be done. Here's a excuse me, girl. And we look at faces, and if we get a profile on a child, we can put it into a template that we have. I analyzed about 100 movie stars, 50 male and 50 female, that had the greatest influence in the world. And excuse me, I started doing this when I saw 2 pictures in a newspaper many years ago, and I don't know if you remember Elizabeth Taylor and Grace Kelly. She became the Princess of Monaco in Europe. But both of them were very famous movie stars years ago, and they had a tremendous influence around the world. Everybody's hairstyle resembled Elizabeth Taylor. She was a beautiful young woman. Perfect, perfect profile. So I noticed that their profiles resembled each other quite well. So I got them according to the same enlargement reduction, put them on top of one another, and they were exact. And so I started studying different people that influence beautiful people, recognize beautiful people in the world. And so we developed a template. I think I might, no, I don't have it here, someplace else, where we have a plus and minus for all the elements of the profile. And we analyzed it and we did it at different ages, all the way down to about 5 years of age. So we could put a child's profile in that, and if that was within the margins of that template, we knew that that child would have perfect proportions by the time she reached maturity. If they had something out of line from that, their nose was too large. Barbara Streisand, for example, falls entirely without that, outside of that template. But she probably never had a rhinoplasty done because it would affect her beautiful voice. So she falls outside of that. If the child has 2 items outside of it, they will still be a very beautiful person, but they'll have an interesting profile. Not perfect, but an interesting one. If they have more than 4 items out, they usually will not be very interesting looking. And so we can determine in a young child. So we know we don't want to move anything outside of that template. If they have something outside, we want to be able to move that jaw or upper jaw or whatever it is within the confines of that template, and we can influence what that profile looks like. Anytime you have a young child and you're going to be doing something to the profile, advancing the mandible, advance the mandible. Have the mother look at the profile and say, that's probably something like what we're going to get. Is that in agreement with you? And she might say, yes, that looks fine. Okay, that's what we're going to do. If she says, no, I don't like that. For example, I had a young girl that had a very gummy smile. And at her age, which was about 11 or 12, I couldn't influence that gummy smile as we can in a younger age. So I asked her mother, I said, if you're okay with that gummy smile, as an adult, I can straighten her teeth in 4 to 6 months at a reduced fee. If you want the gummy smile reduced, I have to do it orthodontically, and it's going to take me 2 years, and the fee will be such and such. She said, I want to get rid of the gummy smile. So we did it, and we'll show you a picture of her at some point here. But so you have to ask the mother sometimes what you're doing so that you understand. This girl, we felt we could advance that mandible, we could open up her face, we could reduce the maxilla, and we could improve her profile. Well, I made a mistake. I put a headgear and I put it against our plant so I could retract the maxilla. We advanced the mandible, but by the time the mandible got advanced, it didn't advance far enough that I thought was acceptable. She had beautiful teeth at the end, and I recommended that we do a genioplast down here where we add a little bit of bone to the front of the chin from underneath the chin, which would improve her profile, but the mother refused. She thought her child was beautiful the way she was. So anyway, here's this girl's lower teeth, and she rolls her lip around this and pushes her upper teeth out. And this is the finished case. But it did take some limited braces, and we fiddled around with this case, but it did give her a beautiful result. Here's another child with initial at rest and going to one side. We've discussed this before. And here's a child with this tongue thrust in the back. So we correct that by putting what we call a lower Hawley retainer in. And we have a shelf coming up here. He only had a tongue thrust on the one side. So we had him wear this to keep that tongue out of there. When he wasn't wearing the appliance, which was the G series for him, I did not want him to wear the appliance all the time, because once he kept the tongue out during the day, then we could get the teeth to erupt the rest of the day, as well as when the appliance was in the mouth. And this is the appliance in the mouth. You see it coming up here. It prevents the tongue from coming up over here and preventing these teeth from erupting properly. Evidently, these teeth erupted on time. These teeth probably didn't, and he developed this tongue thrust. He develops this later on. It's a little different from an anterior tongue thrust, and these cases correct very easily, and they stay corrected. So that's the way we do that. Contraindications for this habit corrector. Usually a skeletal class 3, excuse me, well, it's down here someplace, skeletal open bites. If a child has a very long face, and everything that's connected is forward in the face, the tongue has no place to go but to go between the teeth. The teeth have to erupt over a longer span because the direction of growth is very steep. These develop an open bite, but it has relatively little to do with function. It has a lot to do with the tongue being forward and the genetic lengthening of the face that they have. So these are contraindication. Long anterior face height. This is related to the same thing. Steep mandibular plane angle. We angulate the test the angulation of the mandible to a baseline up on top. And if it's 38 degrees or more, this is an orthodontic term, but if they have a steep mandibular plane, it would not be a good case. Extreme overjet, small mandible with what we call an antagonial notching. I'll show you that. These are genetically a very open bite, and the mandible has a little notching in the back. Open bite after 12 years of age. Again, maybe we're going to change that. So every seminar I learn something. So you're responsible for me learning something today. So I hope I'm going to reciprocate and have you learn a couple things from me too. So. Enlarged tonsils or adenoids. Always check these. This is a very frequent cause of problems. So if they're enlarged, have them out. Tonsils are very easily taken out. They have a capsule around them so they can be taken out completely. Adenoids do not have that. So adenoids have a tendency to return. They don't get all the tissue out. They're a little harder to get out completely. But anyway, if they do a tonsillectomy, they usually almost always do an adenoidectomy. If they have enlarged tonsils, they usually have enlarged adenoids. If they have large adenoids, they do not necessarily have enlarged tonsils. Macroglossia, very large tongue. Some people just have genetically a very large tongue. And so those are problems. And posterior tongue thrust with deep overbite, this has to be corrected along with it. So anyway, here's a boy from Brazil, and we went to Brazil every 3 months for a couple of years, taking kids. I don't know if any of you have heard of the famous soccer player Pelé. Well, Pelé came from the hometown where we went, which is Bauru, Brazil. This boy came down from the hills. He had a huge overjet, mouth breather, and a lot of Brazilians have a very short, prominent upper lip. We recommended that he have a plastic surgery done in Rio de Janeiro, but I don't think the parents could afford to take him over there, so he never got plastic surgery. But he had a nice result. You see the overjet here. We never thought it would work because he had this steep mandibular plane angle. Not a good case, but it did work out. He was a cute little boy. He wore that thing all the time. He wore it all day long. He wanted to correct this problem dramatically, and he would bring me a little present once in a while. He'd bring me underarm deodorant. I don't know if there was a purpose, but that's what he could afford. So the kids were cute, and but we fixed him up, and he was so excited that he was getting his profile. He knew that he didn't have a good profile, so he worked very hard to get it right. This is a very steep mandibular plane angle with antagonial notching. This is very similar to what his cephalometric film looked like. This is a child with a long face. These, and they have a very short face here, so the tongue is overpowering the front and the back of the oral cavity. These are very difficult to do. Class 3s frequently have open bites also. It doesn't make sense. I've never been able to figure it out, but they frequently have. So these are very difficult to correct. Anyway, they swallow about they're told to wear it passively 2 hours per day, okay? And they wear it at night. And so it keeps the tongue above the shelf. Tongue tipped back. They stretch the lips together while they wear it during the day. So they try to lengthen the lips. And they breathe through their nose. They suck their finger, they put the appliance in instead. So this tells you what they do, and we've gone over that before. But normally they swallow about 2 times a minute during the day. So 16 hours during the day, they have about almost 2,000 swallows a day. So if they're swallowing abnormally, this creates a havoc into the front of the arch. And at sleep, they swallow about 1 time a minute. So 8 hours, they have 480. So they have about 2,400 swallows a day. Now, if we use a habit corrector, during the day, 2 hours is 240 swallows. 8 hours at night is 480. So they have almost 720 normal swallows during a day. So this is why they can correct this so nicely. A typical myofunctional therapy, they ask them to do this 200 times a day, which is 28% of what the habit corrector can do. And frequently the children don't do that, and it's a problem. So anyway, these are the children we would like to see corrected with that. So we give them little animal boxes, and this encourages the child to, we had a little boy last night, and he selected the car. He was thrilled to death to get a little sports car that he can hang around his neck and put the appliance in there. And kids ask him, "Oh my goodness, what is that?" He says, "Oh, that's for my appliance," so forth. So we have several different animals, and some of them are pretty cute. We have a monkey that is cross-eyed, and so they like those. Anyway, I'm going to interfere for a second here to put another thing on. Let's see if we can get rid of this thing here. I'm probably doing this the slow way.
No,
This is my right-hand man here.
Oh, that was the wrong one.
Is this the next one?
No.
No. Where did I get that? I'll let you. She's my programmer, so she knows this better than I do today, right?
Yeah. Something like that.
Michelle is a dream for any office. Right, Michelle? I'm going to embarrass Michelle now. She's an unbelievable typist and chart maker and everything. She also bakes cookies quite frequently. Good cook. Keeps my weight overweight here. In the office, we get candy all the time from Staples. You know, Staples, they have them out here, I'm sure. We order things from Staples, and they send us, what do they send us, a half pound of M&Ms or something? So when I'm at the office, I think they're addictive. I start eating them, and pretty soon I've eaten a half pound of them. So, but Michelle's cookies are something else again. Anyway, I'm going to go through the data forms for the next half hour or so and show you exactly what to fill out. It's important that you fill these out completely, because this gives me a complete idea of what this case is about. If you don't do that, I don't know if the child has a sleep problem. I don't know how to handle that or recommend to you how to wear the appliance, when to wear it, how long to wear it, and so forth. And if you don't answer TMJ, for example, I will not know what to recommend to get the TMJ corrected, or whether it will or not correct. So every one of these questions have a specific purpose and been done specifically. So we have several forms that we would like you to send in. Number one is a diagnostic data and information form. Now, I would like the doctor to fill this out. You can be sitting there, and there are several things that you can answer as well, but I would like that filled out completely for us. And so I can look at that within moments. I can see how normal or abnormal. I can see which things are abnormal immediately. And I want you to get in the habit, especially the doctor, of being able to look for things that I would normally be looking at in a child. Analysis of the panoramic film. There's a simple form. We might be improving this form, but it's a way you can see. If everything looks normal, you just mark the yes. And these eventually will all go on computer, so we can analyze them, and you can email them to us or whatever. Observations of the child that mouth breathes. We want the doctor to analyze the tonsils, whether they mouth breathe during the day or night, and if they snore, what position do they snore? You ask the mother, do they snore only when they're on their back? Do they snore when they're on the sides, and so forth? We can tell the severity of the snoring and why the snoring occurs because of that. We want some nice orthodontic intraoral photos. And if somebody can't take the photos in the office, have somebody else do it that can. But I want nice oriented photos like you've seen here, like you see here, and we can tell. Properly exposed. so that we can see if they have a crossbite and a few things like that. And then panoramic X-ray film, clearly legible film. There are some machines that produce beautiful X-ray films for you. And if you're going to get a different machine, we recommend that you get that machine. It's wonderful. It has a 1-second exposure for a head plate, and it is very easy to diagnose. Most of these films that you see here have been taken by one of those machines. We get films, particularly cephalometric films, from people that are overexposed or underexposed, and you can't see a thing, and the patient has his mouth open, or they're in end-to-end occlusion. You should keep the occlusion closed, and every moment you're going back to click the exposure on it. You say, keep your mouth closed, keep your mouth closed, be sure to keep your mouth closed, keep your mouth closed. And if you don't do that, they'll open their mouth, and then the film is not really too accurate from an orthodontic standpoint. Plaster models, and there are other options. I would say within 5 years or 10 years from now, plaster models will be eliminated altogether, and you'll be digitizing the teeth. You can digitize the teeth in the mouth within a minute or a few minutes and get an unbelievable result. It's one-to-one. We can measure for the appliance. We can measure almost anything on there, and so it's a lot easier. If you do have plaster models, we recommend that you put them upside down on a Xerox machine. You take a pink ruler and you turn it upside down so we can see the measurements on that ruler. Now, if that's faxed to us, the fax normally reduces that a certain percentage. If they get it in Illinois and they fax it to me in California, where I am in the wintertime, it'll be reduced again. So I need to know how many times that's been faxed so we can compensate on the size estimation. So sometimes we get things that are 20% enlarged or 20% reduced. A photograph, digital photograph, is not adequate because we don't know what the enlargement or shrinkage is on those films. So anyway, those are easy. If you do send us models, make sure they can be articulated. We have models that have huge pieces of plaster in the back. We have to start trimming all that off and try to figure out where the bite belongs. So the bite, I want you to mark on the models with a line in ballpoint pen exactly where the molars belong, so we know where that adjustment is, so we can actually accurately measure what we want to measure. And then we have a sleep and speech questionnaire that the parent fills out. And Ceph film, if you take Ceph films, and then release forms filled out by a parent. We have sheets that you can fill out for the Ceph telling you which of the items are most important on a Ceph film. You don't have to measure everything that's on that sheet, but they're asterisks, whichever is more important for you. The pictures, they should be well oriented. So we take 3 facial shots. Profile, front, without smiling, and then we take one that's a complete high smile. Now some kids won't give you that, but we do that so we can measure the gummy smile that child has. Okay? Then we want occlusal of the upper and lower without a mirror. A mirror complicates it. I might not know that you're using a mirror on a case, and it reverses everything for us. So we have to know which is left and right and so forth. And then 3 intraorals, and they should be oriented a little bit like they are. This is a little bit off, but you know, I want to be able to see the posterior of these teeth. We recommend a certain camera. Very easy, simple camera. It's relatively cheap. I have a camera that costs $2,000. It takes no better pictures than this little thing. It's unbelievable. And this has a couple settings, one for the intraoral and one for the face. Very easily done. Has a ring strobe on it. It's available from Lester Dine. It's a photographic company that's been in business for a long time. But it weighs very little, and it fits in the palm of your hand. The camera I have is hard to hold up. A small woman would have a harder time holding such a big camera up. Anyway, this tells you some of the other factors about it. So I want the model marked. You don't have to trim models like we do orthodontically. They don't need that, but we do want a marking showing where the occlusion belongs on the thing. If we're sent models, if you want the models back, we would like to be notified and we'll send the models back. Sometimes people will pour the models up twice or keep, except for themselves, they'll send us one. We'll digitize these models anyway. So anyway, this is a digitized dentition from a model, and you can see how accurate it is. Shows the exact occlusion of the teeth, and you know, the upper and lower very nicely, and it's a 1-to-1. We accept almost all types of digital imaging except Sirona. Sirona can't be used. We actually use 3-shape imaging, but it doesn't make any difference what you use. We find that this is a fairly good imaging, but it doesn't make much difference. Another alternative is to take a wax bite the way you take it with impression material, or you can take bubble gum and have them bite into that. We're developing some plastic where they warm it up and bite into it. But these are only done on desperate cases where the child refuses to have models. We don't want these on every case because they're not as complete. We can digitize this and get a model of the teeth from it. But on the other hand, if you're sending them in for every case, they have an open bite, there's no image of the upper teeth or lower teeth. So, you know, we don't prefer those. Only in an emergency would we want those. So when you Xerox the models, turn them upside down and put a ruler so we can see what the image is. If they're too dark and we can't read it, if you can't read it, we can't read it. And so I'm going to be guessing on the size, or we'll call you and tell you I can't read this. We have to have a better image. So, you know, get these images right and look at them before you send them to us to make sure that they're legible, that I can read the numbers on this ruler. If this ruler is shrunk by 20%, I want to be able to read those numbers so that I can estimate what the proper size is, okay? So this form is the form we want filled out. All the normals are in one line. So, you know, we can look at that, put it in a computer, and we can see exactly if that child is all normal. And the ones that are abnormal, we'll see over on this side. So we look through and see what is abnormal for a child. So the first thing we do is to look at the teeth present. Sometimes a pan is not very legible on the front upper. Maybe your photograph is not too legible. I want to make sure what teeth are present, which are deciduous, which are permanent. So just mark. If there are deciduous teeth present, I want to mark them. Or if there's two lower permanents in, mark those and mark the others as deciduous and so forth. So we can tell exactly what teeth are present, which are coming. If the tooth is breaking tissue, mark it as present. In other words, if 26 is just breaking through tissue, mark it as present because I want to know. If there are only 3 teeth down there, I want to know which one is present so we know which one is missing perhaps. Maybe we can't read it on the Panorex film, but this helps us to interpret nicely. Okay? I want to know what the overbite and overjet. You don't have to measure it with a ruler. You can estimate. I don't want percentages. That doesn't tell me anything. 50%, I don't know how big the teeth are and so forth. But if the overbite is about 4 millimeters, mark it. The object of this is, from the digitized models, we can get the exact measurement. But I would like to know, and that tells us how long the treatment's going to take. A 6 millimeter overbite will take 6 to 8 months, very accurately if they wear it the way you desire them to wear it. 4 millimeter overjet will take 4 to 6 months, and so forth. If they have a class 3, I want to know that. And then I want to know what type of class 3 it is. A pseudo class 3 is one where you close down and they first touch almost end to end, and then they shift forward into what we would call a strong looking class 3. But that's a false position. So we call that a pseudo class 3. So I want you to test that in a child. Very important for me to know that, because if we see a child with a class 3 like that and it's a pseudo, it means that we can correct that very simply. But if it's a skeletal, I might not be able to correct that for you. So it's important for me to know that at the time. So that's the thing that you have to look. And then ask them if they have a family history of skeletal class 3s. Because usually a class 3, maybe a grandmother, an uncle, a father, mother, somebody, usually older brother or sister will usually have the same type of an occlusion. So it's extremely genetic. Okay? Class 3. Here's a class 3, and corrected very nicely. But it's a pseudo class 3. If that was a skeletal class 3, we probably wouldn't get that same correction. Okay? Here she is at 7 years, 8 months. This is after attention. She's 11 months, 3 months of age. She's about almost 4 years later. But look how nicely the occlusion comes out. And these pseudo class 3s stay. They stay very well. A skeletal class 3 will increase constantly all the way up until they're about 20 years of age, and the increase later on is even greater than it is earlier. But you can tell those very easily at 4 to 6 years of age if a child is skeletal. If they close and they close directly into that class 3, it's a skeletal problem. So it's important for us to know that. Minor class 3s, skeletal class 3s, we do use what we call a class 3 appliance, which has no margin in front, and they push against the upper front teeth, and it has a little bumper down below that manages the lower so it doesn't want to come forward enough. But a skeletal class 3, we can minimize or reduce the effect of it, but we can't correct it. So by the time they get to be 16 and they need surgery, maybe they can be corrected orthodontically rather than having surgery. So it is a very useful appliance. We're not going to discuss that today, but it's an unbelievable little appliance that can correct class 3s. Class 3s among Caucasians, about 2 to 4%. Among Japanese, it's like 9 or 10%. I was in a practice in Sapporo, Japan, and 65% of their practice were class 3s, because those are the things the parents are interested in. They were horrible cases. I mean, unbelievable cases, because they have mid-face reduction and they have class 3, and the combination between them can sometimes have 8 and 10 millimeters of a class 3, which are almost impossible to correct. Cross bites. I want to know anterior cross bite. We're going to take right and left out. Makes no difference to me. But if it's anterior cross bite, I'd like to know that. Posterior cross, we can usually see this in the photograph. If it's a posterior cross bite, I want to know if it's right or left, or if it's a complete posterior cross bite on both sides. Is the cross bite dental? Do they close directly into that cross bite? Or is it a functional or mandibular displacement where they shift over to one side as we described? I'd like to know that. If it's 1 or 2 teeth cross bite, I'd like to know if there's enough room. Is there enough room for that tooth? The width of that tooth, is the space the same width as the tooth? Can we correct that? That'll correct easily with the appliance. If there's not enough room, that involves something else. Okay? Skeletal class 3, again, if you have one of these, mark it. Tell me if it's skeletal. Functional, we've described this before to you. Posterior upper arch width. I don't expect you to measure the arch width. We can measure the arch width very accurately on the computer in the same way. So I don't care whether you measure the arch width or not. A lot of people will measure that, and I don't even read it. It doesn't make much difference to me. Depends where you measure it and how accurate. So it doesn't make any difference. But I would like to be able to compare the arch width of the upper to the lower arch. The lower arch is usually a normal width arch. Okay? So if the upper is narrow in relation to the lower, and it's 3 millimeters or less, I would like to know, because we can correct that with the habit corrector. Okay? If it's more than 3 millimeters, I would like to know, because then we're going to correct it in a different way. We might use a Schwartz, little different appliance that's put up there to correct it. If the second deciduous molar or second premolar are in crossbite, or first permanent molar in crossbite, I want to know that. If the upper arch is narrowed when compared to the lower bilaterally, I would like to know that as well. So that's the reason for this. We get more questions about this than anything else. Habits. Habits are important. Important, as we talked about earlier, it's important for me to know if they suck their finger or they swallow improperly. I can't look at the film and tell you if they do that or not. I'm depending on you to tell us if they have an anterior tongue thrust. Now, if you don't think they swallow improperly and you've watched them and they don't move their face within a minute, they probably are swallowing normally. You can have them take a little bit of water and swallow, but they'll usually give you some kind of a funny swallow. So that's maybe not as accurate as you think. So we would like to have you do that. Suck their fingers, nights or days and nights. I'd like to know that. If they have swallowing problems, I'd like to know that. And if they're tongue-tied on the lower. And that's become a popular thing recently. And particularly if they have speech problems and their upper arch is narrow, we might recommend that that be snipped if it's severe. And so you have them stick their tongue out or stick their tongue up in the upper arch. If they can't do that very well and they have a big frenum to the tip of the tongue and it pulls the tip of the tongue in, these are what we call ankyloglossia. They're tongue-tied. And this may have an effect on their speech, so we would like to know that. Habits, again. Here's a tongue-tied individual. You see the dipping of the tongue and it's held. And they can't get their tongue up, they can't get it out. It might affect their speech. Very easy. You can anesthetize this and snip it with a scissor. It works very easy. I've never done one. It sounds awful, but they say it's easier than piercing your ears, so I believe them. Anyway, open bites. Anytime they have an open bite, be suspicious that they either are sucking their thumb or have a tongue thrust swallowing pattern. TMJ. TMJ is another confusing situation for the general dentist. And we put our little fingers in the ear, pull it forward slightly, and have the child open and close, and you feel if the joints click. Now maybe one clicks, maybe the other one clicks. Do that initially. It's very important for you to do that. From a legal standpoint, you know what the situation is. If they click when they walk into your office, it's important for you to know that, because if something happens during the appliance, they say, oh, my joints click now. They say, well, they clicked when we started. It's important to know that. If you have no record of beginning, you got a problem maybe. And when we correct the joint, we'll talk to you this afternoon about that a little bit. Usually one joint will correct maybe after 2 or 3 months, then the other joint will click, and then this one corrects and this one clicks. After about 6 months, both joints are free of clicking. We test that by having the patient bite down into an end-to-end occlusion and have them open and close to that position while we're feeling in the ears, and they can feel, oh, the clicking stops, doesn't occur anymore. That case will correct with this appliance. 83% of clicking is like that. Now, if they open their mouth real slowly and they shift in order to get the disc on top of the condyle, we call that deviation of opening. Opening deviation. I want to know that. Not too many children have that, but it is a sign that there's a severe joint problem. The most severe thing is if they have limited opening. This girl can get 3 fingers in that mouth, but if she can only get 2 fingers or less, it means that they have what we call a closed lock. The disc never recaptures itself on top of the condyle, and they're biting and chewing with bone to bone all the time. Very severe cases. We recommend that if you don't have somebody that can treat those in your office, send them out to somebody that's a TMJ expert. But they can be corrected. They can be partially corrected with our appliance, and they can use a split 24 hours a day, and after about 6 months the disc heals itself over the condyle, and then they can use our appliance to straighten the case out. So they are correctable, but I don't it's too involved. I wouldn't get involved with it. I might tell you an interesting story from the New England School of Medicine in Boston, a very well-respected hospital in Boston, associated with Tufts University. And they had 2 children, 2 young boys, that had middle ear infections constantly. So they had put a drain in to the middle ear, let the bacteria and the fluids drain, and they were on antibiotics for a full year, and they didn't correct, and they were frustrated. So they sent them to the dental school. They went up to the Gelb Clinic on the 8th floor, and they put our appliances in both children, and within a couple weeks to a month, I can't remember how long it was, both children were cleared, because the eustachian tube was kind of cinched. It's like a garden hose. If you bend it, the fluids and infection can't get out. So by advancing the mandible, it opened up the eustachian tube. The tubes were taken out. They were taken off antibiotics, and both of them were fine. So, you know, you hear stories like this, and you realize that we're doing a lot of other things other than just straightening teeth with these appliances. So, pain, headaches in the morning. Sometimes they even have back pains due to a joint problem. If they wake up every morning with a headache, they're probably bruxing their teeth all night. These, as you notice, these things are very closely associated with breathing problems as well. So, that's a sign that they might have breathing problems. Anyway, have difficulty chewing. They did an experiment on pigs many years ago, and they took the occlusion down on one side of the pig. And then they sacrificed the pig. He had effects all the way down his vertebral column from that thing. I heard a lecture in France one time about flat feet. And they had the person put their feet down on an ink pad. And they noticed that the person had flat feet. And after their mandibular was advanced, they had an arch. And you think, well, what's the connection between those two? Is it possible? Well, there was a dentist that was publishing a lot years ago by the name of John Witzik. I don't know if you've ever heard that name. But John Witzik popularized the bionator in the United States. He was a general dentist, but a very smart guy. And so I looked at his before and after pictures, and I thought, that son of a gun, he's taking and he's moving the head down like this. Or, no, excuse me. The head is down in his initial shot, and then he's moving it up like this to show that the mandibles come out further forward. I thought he was doing this purposely. And then I started analyzing my own cases, and I felt that almost every child that had a mandibular advancement, their posture was different, and their mandible was up like this. That was their natural posture. We were changing the posture of those children just by advancing the mandible. So sometimes you're doing things that you don't realize all the other side effects that you're affecting. So anyway, it's important for us to know these symptoms, because whether we can correct them or not depends on whether they have one or more of these things present. Sleep disorders. You might think, well, this is a duplication of what we're actually asking the mother. The reason for this is that I want the mother one-to-one with you answering some questions about their child. Now when they go to the sleep questionnaire, they might not answer them the same way. Some parents don't want their child to have any problems at all, so they don't answer anything on the questionnaire. And if they come back with nothing, you might say, are you sure? Why don't you take the phone back home again and observe your child every night for a week and see if they have any of these problems. Once they're aware of these things, they might be more inclined to fill them out once they know what the problem is. Anyway, we ask the mother if they snore 3 to 7 nights a week. Very important for us to know that. If they have interrupted snoring, very important. Mouth breathing, days or nights. Nasal breathing, difficult. Swollen tonsils, speech problems, and venous pooling. So we ask them these questions. Sleep disorders. So we're going to ask the mother to fill out a lot of these questions. So these questions are pretty well documented, that the parent can figure out what these are. If they have questions, you can answer very easily. Gummy smile. I'd like to know what the gummy smile is. Now, we can prevent that gummy smile by adding 4 millimeters to the baby overbite, and that's the amount of gummy smile that we can prevent at this young age. If they have a gummy smile of more than 2 millimeters at this age, they will have a gummy smile as an adult. Now, adults, 25% of adults have gummy smiles. 75% of them are in women, only 25 in men. The reason for that is that our upper lip is a little harder to elevate, and when a man smiles, they frequently show a lot of their lower teeth. That's why when men smile, they don't look nearly as nice as when a woman has a beautiful smile. It is a gorgeous thing to see, because they show all their teeth. And so if they have a gummy smile, the parent would like to know that. Because as they get older, not so much in Houston, but in Chicago, if they breathe through their mouth, that tissue is all red and swollen all winter long. So, and their lips are chapped frequently. Anyway, so we would like to know that. Now, the gummy smile does reduce about 1 millimeter between 8 and 12 years of age, naturally by the recession of the gingival tissue on the clinical crown height. It depends a little bit on the distance, the size of the clinical crown height between baby and adult teeth. We're taking average measurements from years ago, so we know what the average is, so we can estimate what that is. A 3 millimeter gummy smile, if it's just 1 millimeter in the adult, that's not so bad. We can accept that. But if it's more than that, we would like to prevent it. But it only can be prevented at this young age. By the time they're 8, there's not much we can do about it anymore. Okay? Freeway space. Again, I mentioned how you can measure the freeway space. And it's important for us to know it, particularly if it's deep. If it's a very severe freeway space, I'd like to know that. The midlines. To a person, it's important if the midline is off. We'd like to know if the upper is off, left to right, or the lower is off. So take a piece of paper to a copy store, like Kinko's, draw a line down the middle and have them make you a clear piece of thick acetate. You hold that against the front of the face and you can tell which midline is off to the left, right, upper, or lower. I'd like to know that because we can shift that. Our appliance will correct a 1 millimeter midline 70% of the time, but not 100%. 3 millimeter midline will be corrected 33%, but not 100%. But we can make it 100% by shifting it around. We do that with little wires that we put in there. Okay? Inclination of teeth. If a child has lingually inclined upper teeth, I'd like to know that because we'll upright those teeth. And by looking at the pictures, sometimes we can tell, but not always. I'd like to know what the lower inclination is. If the lower teeth are inclined, I'd like to know that because maybe we can labialize those teeth and correct a millimeter or 2 of crowding without any problem, particularly in the adult. So I'd like to know if they're inclined from your appearance, from just looking at the child. It's much more accurate than a cephalometric measurement. Now I'd like you to measure the thickness of the mandible with your thumb and first finger. Just see if it's thick. If you lower the lip on the child, they have an accordion situation where you can see the roots and the bone goes in and out like this, and they have a very thin mandible, long face. We don't want to touch those incisors. We can't move those teeth forward at all. But if they have a thick body of the mandible and you can't see those roots, I'd like to know that because we can correct 2 millimeters of crowding in a case without doing anything else, particularly in an adult. So we'd like to know that. This is fairly self-explanatory. If you see a problem there, gingival tissue that's low and so forth, I'd like you to be able to observe that and make sure that if we're doing something that might lower that, I want you to be aware of that. And then your cephalometric film. Poor eruption path. What do you think about this tooth? You think that tooth's going to come in nicely? No way. Now I have a daughter that had a tooth down here, just like that. And we had the oral surgeon go in with an elevator and just edge it a little bit. He went in twice. Again, he edged it, and then he came in. She was born in 1964, so she's got to be 53. I hate to say that, right? She's my middle daughter. Her tooth is still healthy. It's not mobile. The root is a little shorter, but it's in place. So it is held for her. A lot better than taking the tooth out or exposing it and putting a button or pulling it down. Generally, you don't do that with bicuspids, but that's a solution for a case. This is not very frequent. But the one that we don't like are canine. Inclinations. That canine has a 56-degree inclination to the vertical. That tooth is behind. You can see the outline of that lateral incisor, so it's not resorbing the lateral, it's not resorbing the central, but I've seen them where they resorb all the 4 front teeth. Take the roots halfway off. So if you have a case like that, we tell you to get rid of the case or have somebody that can pull that tooth down orthodontically to treat the case. If you treat cases orthodontically, no problem. That's one of the largest symptoms of failure that we have in orthodontics, trying to bring a canine down. I'll tell you something, if the root is labial and mesial, you're a hero because you can get it in 3, 5, 6 months, you can get that tooth down, it's beautiful. But if that root is lingual and distal, you'll work for the next 4 years trying to get that tooth down and it may never come down. Sometimes you resorb the root off the tooth, sometimes you eliminate the root chamber, but sometimes you get it down halfway and it just simply will not come any further. So they become a problem, so get rid of them. The upper canine usually makes about a 35-degree bend and comes down into the canine slot. So if the inclination is no more than about 40 degrees, usually it's a successful case. But we look at that on your Panorex film, and I give you an orthodontic opinion whether you should treat it or you shouldn't, or you should be concerned about it, okay? Missing teeth. Make sure that you indicate missing teeth. Anytime you look at a patient, count the teeth before you open your mouth. Make sure all the teeth are present. Very difficult thing if you suddenly start opening your mouth and saying, well, we're going to do this and this, and the mother says, what about that missing lower lateral incisor? Oh my gosh, there's a missing tooth there. You've lost that mother. That's the end of it, because she thinks you're not looking at it carefully enough. So always make sure you measure. If there's not a tooth there, where is the tooth? Is the tooth missing? Is it out underneath the gums? Is it inclined where it can't come in? But we want to know that so that we make the case easiest for you so you get success. Unusual shape. Here's a child with a double lower lateral. Peg-shaped laterals. This lateral is very hard to rotate because of the shape of that tooth. You'll find that children that have missing teeth, impacted canines, peg-shaped laterals, misshaped teeth, ankylosed teeth, they're all related. And if you have one child in the family with an impacted canine, you're going to have some other child with something else maybe. And maybe a grandchild or their children will have something. We have some missing teeth present in my family. I know it's my wife's family. It's not mine, you know. She's not here in the room, so I can say that. Otherwise, I'd be in big trouble, right? But her parents actually had perfect teeth. They had no decay for their whole lifetime. But they were raised in mountainous areas where they had natural fluoride. I might make a brag about anybody go to Northwestern here? We have one person that went to Northwestern here, and our first dean was G.V. Black, the father of modern dentistry. I don't know if you've heard of him, but he discovered that fluoride would prevent decay because he was seeing a lot of people from the western states, from mountainous areas. And when I was in the Air Force, when we examined kids, I would see a perfect dentition. I'd say, I bet you're from Colorado, New Mexico, and they'd usually say, yeah, that's where I'm from, because they have fluoride in the natural water system. So, and he discovered that in about I think probably 1900, 1905. Can you imagine that? But the first town to be fluoridated with water was in Michigan. The second town was Evanston, Illinois, where Northwestern was located. And I remember the dentist that started examining these children. After they came in 6 months later, they couldn't believe what they were seeing. No cavities. When I show these slides in Europe, they cannot believe the fact that the teeth are without cavities. Because in Europe, they don't believe in fluoridated water. And in fact, the more sugar you use, the better the business is for the dentist. But in the United States, the dentistry profession is unbelievably ethical in promoting fluoride. It's really an amazing thing. So anyway, double teeth, misshaped teeth, peg-shaped laterals. This tooth is very hard to rotate. So we would recommend that you bond that tooth, build it up where it's normal size. Before you start, you'll get better rotation out of the tooth. Here's a poorly shaped lateral. And then I mentioned this before. We would like to know kind of what the face is. Get in the habit of looking, hey, the mandible is back, the lip structure is protrusive, the lower face is short. We would like to have you begin to look at profiles. It's not good to look at a child after you've seen that child for several months, because you get used to what that child looks like. The first time that child walks in your office, I want you to be looking at that profile, the face, the proportions of the face, and that's your initial impression. And that's really an important impression to have, because after you know the child, it's not so important to you anymore, and you don't seem to see that. Diastemas. African Americans sometimes have very large diastemas, maybe 4, 5, 6 millimeters. Pull the lip up and take a look on the lingual and see if the tissue pulls on the lingual. Chances are you'll have to have a frenectomy done. But you don't want to do that frenectomy unless you have some provision of closing that space. So a minor one, particularly if there's protrusion of teeth like this, there's probably no frenum problem there, because the teeth are forward, they're spaced. Once you get the teeth back and then the frenum or the space wants to open, then you might look into doing a frenectomy. But you have to be very careful how that's done, because if they take too much tissue out, when you get the teeth together, you'll see an opening that you can see right straight through into the oral cavity. You don't want that. Miscellaneous questions. I just want to, the most important one is the sign of maturity. I want to know how mature this girl or boy is. And it's very easily told if you ask the mother privately, if the daughter, if she's 11, 10, 11, 12, 14, if she looks mature, to ask her about the menstrual periods. And if it's on a regular basis, you know that the growth is over with. 98.5% of the growth is done at that point. And the boy, when his voice starts lowering, he has underarm hair under the arms, and he perspires under the arms. These are signs that he's mature. So it's a little harder on the boy than a girl, but it's important for us to know that, because if the child is completely mature, it means that they have less growth left. We have less overjet to do. So anyway, that's about it. The other questionnaire is whether they have tonsillar swelling, how big. Very important to have them laying back kind of in the chair the way you normally do your dental work. And look at the tonsils in that supine position. That's their position when they sleep. Standing up, the tonsils might not look nearly as enlarged to you. And then if they can, if they can breathe through their nose, watch them as they breathe. Most of the people in this room are breathing through their nose normally, so you wouldn't have a nasal problem. And then snoring characteristics and a retrognathing mandible. And then have the tonsils or adenoids been removed? Are they swollen and so forth? Very hard to see the adenoids unless you take a cephalometric film. And then breathing through the nose, as I mentioned before. And excessive retrusive mandible. And then the degree of adenoid swelling. This is from the cephalometric film. If you're not taking a cephalometric film, that's not particularly necessary. I think we'll stop here for, are we ready for lunch?
We are.
We are ready for lunch. So any questions at this point? Yes?
What's the significance of resting their jaw on their hands?
There's a tremendous amount of force. The weight of the head. You can close the bite. It has a reason for increasing the overbite. There was for scoliosis, curvature of the spine, they had a brace that you put on the back called the Milwaukee brace. Dr. Blount in Milwaukee, Wisconsin invented this thing. And it had a bar that fit under the chin. Well, the child, this fits against the hips. So the child will get in the habit of resting their head on that, and it would simply ruin their occlusion. The teeth are almost horizontally positioned, and the mandible would close down. So if they always rest on their chin, it might have an effect on the overbite. Whether it's going to have a serious effect depends on how much they do that. Any other? Yes.
Can we postpone that? We got the train that the food is actually already on the table.
Let's go.
Okay. So hold your question. You get
Let's
the first
go.
question when you get back.
Don't forget it.
Okay. Let me tell you the way that we're going to keep the trains on time. Leslie, we restart at 1?
Yes.
Okay. So be back at 1 so we can be on time, and the live streaming people know to be there and all that good stuff. The lunch is already set on the table, so your order with your name and the bill, by the way. So be sure to start paying during the lunch so we don't all try to do it at once. Okay? It's already set, ready to go. So the restaurant is just right, and you'll see it on the right. And don't dilly-dally because the food's already there.
Maria, do you think we can shut the doors so if people want to leave stuff here, it should be okay?
Let's see, it's 5. That's the next question. Okay, I'll be back for that.
Okay, I'll give you this back.
Yes, sir. It sounded great. Perfect.
Is it possible to type up there, since he took that off, lunch break, back shortly?
Oh, look, this looks like Puerto Rico.
It might be. I'm not sure whether it is or not. What did you want
Is
me to
that,
do?
whose is that? That
It's
laptop?
mine.
Can you type, I was just thinking about putting that as the
She was
note.
actually going to put mine
Does she
on
have it?
with the loop. She just ran to go get
Okay,
that.
I knew she
So
was
give
gone,
me-
and I
yeah.
thought that's what she was doing, but then.
No, she ran to go get the printout of the CE credits. and the survey.
Okay, gotcha.
And she just ran to do that. So she'll be back. She's gonna take my laptop and hook it here so that it does the loop.
Does
I
that
have
deal.
nothing to do here.
Yeah.
Yeah.
Okay.
You're free.
And Dana's only comment is, she said when I was watching it, she goes, the screen goes in and out. So she said sometimes
The
it's hard to.
focus.
Yeah.
Yeah, and I don't know what we could do about that. That's the most expensive camera. I mean, it's like $59. I'm not saying
Yeah.
that it was outrageous, but of
What
the
it-
choices that they had.
Yeah, what it's doing, it sends those webcams send a signal out and it bounces back to them, and if you move too quickly, the bounce back
Is it
throws off the
movement of a
camera.
Of
person?
him?
It can be, it usually is something like that, or something, it could be something else too.
What if we had a podium? Would that keep the movement more?
Well, I've got a spot here. Now, this time I stayed within that spot.
Yeah, it looked
But
really
before
good, actually.
before you were telling me to move back
Yeah.
or this way, so maybe that.
You're saying it looked good.
Yeah,
Yeah,
it
okay.
looked really good from here, and the sound was good.
What I want to do is
Nice.
change this
Good
box.
camera,
Is
isn't
this
Yes,
going to screw
yes.
anything up? If
You know,
I
the
move
first one I
this
had was this big.
Oh,
It weighed
yes.
about 100 pounds.
I know.
Is it going to matter about
Had
the
three
banner in
bulbs.
front of that speaker?
I know. Yes, I remember
Can you believe
those.
that?
Yeah. And now they make them even smaller than that,
I'm
Doctor.
sure.
Sometimes they're you can get them this big.
Like the size of a telephone, maybe. Huh?
Yes.
Yeah, unbelievable.
Yes.
The influence.
Is that okay? It's in front of the speaker.
That's perfect. You won't be able to hear him as good.
All right, then can we move the speaker?
Might
Because
already
this
be
is
there.
a big
Yeah,
gap
yeah,
in the
yeah.
camera, is my thought.
Michelle predicted
Okay,
correctly.
cool.
She predicted
All right,
which
then
one
if the
she
other
wanted.
banner comes,
I know.
then we would put it on the other side,
My wife wanted.
and it would just,
She
Are
goes,
we gonna lock the room?
yes.
Okay. And then, Dr. Gatt, whenever you have a break, not now, but I have 2 cases I need you to look at.
And they wanted to know, you wanted some.
I'm gonna go get you another banner, so I'll be
well,
back. in a little
get your
while.
lunch first and then go.
I'll get
Especially
something.
since it's hot.
I'll get something on the way. I didn't order anything, 'cause I
We're
knew I was
going
going
to
back the
lunch
office,
now.
so.
There's only one person that says they're watching, and it's probably Dana. Doesn't matter, because we're still recording, number one.
While I was doing it, but I'll look for you.
Okay, so if you wanna go,
I'm gonna go to the washroom.
Oh, okay.
Hello?
So say the spot.
Okay, well, they already have it on the table.
Okay.
Okay, Michelle, can you find it?
Right.
Oh, she's on the phone. Okay, will do.
Okay, bye.
Well, great job. I
She's
mean,
just saying that all the sound is still going.
Yeah, it is.
So everything here is being streamed.
Oh.
Just FYI.
Mhm. This is where it'd be great to have a little music, and
I don't think we have music on this one.
it's okay.
One of them we do,
Oh,
but.
Oh, good.
You see it? Mm-hmm. Yes. I'm just. Good. Oh, that's stitched. That's my best. Here, Lauren. Hold on a second. Okay, let me do that. Oh.
If not, we'll have to find somebody with a key. Okay, I'm going over to the building. Do you need anything, Kathie? I'm gonna bring another banner. So it looks nicer. Anything else you think we might need?
I think we're good. No, it's not perfect, but it tells the story. Good enough.
Yeah, looks good. Okay. I'll be back. Okay. I'll be back.
Hey, how we doing?
Good, thank you.
Good, I gotta get a camera.
I make one receipt for the room. You want to receipt today or give it tomorrow?
Yeah, give it to me tomorrow.
Okay, no problem.
Okay.
Thank you.
Thank you.
snores, and there are times where I'll hear her and she won't be breathing.
You should bring her to the clinic on Saturday.
Her cousin Brianna is having a quinceanera out from her dad's side of the family, and she's in it. She's like going to be holding a pillow, so they've got to rehearse all weekend and all that stuff. So I won't be able to take her.
Well, that's good. Now we're having another doctor. Somebody brings him in at 7 in the morning.
Where?
At North Louisville.
What day?
Saturday. So I don't know. But we're starting. We normally start late.
Okay.
Well, we see patients at 7 on Saturday anyway, but this healthy start is starting to
Okay.
But I think it's Dr. Levy, I think it's bringing somebody at 7 for the same reason. She'll have to be somewhere else later today. So if that would help you, I want to make sure you know that.
Okay, well, thank you.
Yeah.
She'll be with her dad all weekend.
Oh, well, that's
I'm guessing there aren't one for there isn't one for everyone, is there?
Yes. Yeah.
I didn't get one.
Oh, okay. Well, let's find you one.
And I noticed that not everyone has one, so I just thought maybe there was a couple for each table.
Well, I didn't think so, but let's see. Oh, you know what? They've got 2 days worth. Maybe that's what they're dealing with. But let's just steal you one.
There's just so many different appliances, and I'm trying to like keep up with all these for different reasons. You know, it's just there's so much.
Well, if oh, that's right. She's number 3. She's not well, obviously, Dr. Dude, insanity diagnosis.
For the same price still.
Well, we would do it. Yeah, I mean, I'll have to make a note to the team because it's you and of course. And you know. So, and people saw, they said, well, what the hell are you talking about?
Well, thank you for the candor.
Yeah, well, you bet.
So do you find like you're trying to get a lot of patients from having these like sessions outside of the office, huh?
Yeah, absolutely.
What are you advertising?
Well, the first time we had radio ads,
Yeah.
and they came to a family house.
Yeah, how'd that work? Did your clinic do it or did Healthy Start do it?
Yeah, well, it was perfect.
Oh yeah.
They did it perfectly.
I know, like,
It worked very well. Yeah, they did it for us.
Yeah.
So,
Wow.
it was great.
And now what are you doing?
Well, we're not doing the radio ads, currently, but we do health fairs.
You used to go to health fairs?
Well, not specifically for this. We're the largest provider for the city.
Oh, so you go to
So we
health
go to
fairs
health
for the
fairs.
dental in general.
Because we're the largest provider. And then, then Kathie is at the health fairs. And she gets people interested in just their name and information. And she sent them a video. So that was last night's family meeting. That's what we had.
Yeah.
And one of those patients is coming in Monday. They couldn't make Saturday.
Oh, that really good.
Yeah, right. You know, that was very little result from the standpoint of people showing up. Of course, we didn't do a rehearse anyway. Rehearse.
Right.
And then we'll see. With the next time we'll do e-bites. There's an RSVP. You know, we have 120 kids do this in all of these schools.
Yeah.
But you know, unless you have a call to action, it's hard.
Right. Huh. Well, Kurt must have done something right with that.
Well, the radio ads was perfect because those people called in and said, hey, I'm interested.
Yeah, that's true. Oh.
So that
well, I just am curious because I'm from there.
Yeah.
And it's part of it. Like, those sessions are great because you need time.
Yeah, right.
And it's just so time consuming to do it online.
Well, it's hard to do it online. So we're trying to figure it out.
Right.
We sure don't have the answer yet. We're working on it.
Yeah. I
bits and pieces of the
those
answer.
are ideal for you, I would guess for your business to have those sessions. Because obviously you're trying to turn over patients, but to have something like Kurt has set up, is probably. It took a lot of time too.
All it's time and effort. We're gonna continue, we'll do individual, each office, we have 7 offices here now. Each office will do little family nights. Inviting people we've talked to. And we'll see how that goes. And then, we'll do, we do oral exams, oral screenings. And so when that, like we have a family picnic for the Texas Police Officers Association, in 2000, they bring children. So we want to start getting screening. So, but we don't know the answer yet.
Right
We're
now,
just sitting here.
I'm the same way, because I've been talking to a lot of providers, but seeing if these students, like, there's so many questions to ask.
Yeah. Hey, Bob. Oh, you must have gone back to the office. Did you get something to eat? No. Oh, so let's get you a plate. What do you want? A burger or something?
Yeah, I think I will. Let me get this set up.
Just bring that done.
Yeah, that'd be great. Yeah, cheeseburger, fries, cheeseburger fries would be great.
You got it.
Well, no, I have one, but I wouldn't been using it for fun. I've been using it.
Hey.
Oh, I actually wear one because I call it my. You smoke?
Bob, I just ordered it from room service.
Oh, great.
It'll be sent down here. Cheeseburger and fries. We got drinks.
Yes, we got drinks.
Yeah.
Thank you.
Okay. I know that people have that. So, I might put it, I still in it. You know what, I'm a dentist, so I see my teeth. I just, it's always perfect, you know, I have the blinds on. So what I do, use this,
Well, no, I'm not. They, we buy things like coming but I'm really excited about stuff. I remember when they came to our office, there was a lady from the lab she's getting the problem. I told her about it, just like that little stuff that we got from them when they came. I said, this that? I have a grandson, this that, I was giving her the information they gave me. I said, but you just go. She got so excited too about it. I got excited because the little information I got, I gave her. She got excited. She told me to tell my daughter, we go down everything, and we saw and everything. No, this Saturday. Oh, this Saturday. Yeah. Oh, this Saturday.
Well, I probably should have left. I didn't think about that.
Well, you wouldn't have.
I'm gonna take care of that.
Yes. but I will pay it forward. Yes, but I have to go for the car, so it'll say.
Okay.
Way later, it'll be in 30 or 40 hours.
Right, you gotta get to this.
I gotta get to do this.
That's
right. That's right.
That's right.
I'm sorry.
Oh, yeah, I saw her, I don't know. Oh, she's on a video. Yeah, I just saw that last night.
Check.
How long has she been taking care of?
It's crazy, right? Okay. Oh, yes.
That looks like the right one. She reorganized these. I can't find them on there anymore.
You're in new territory.
Yeah, right, that's for sure. Are we on?
We are on.
How come it's not? Oh, it's coming.
It takes a little while to
Get heated up.
heat it up.
There we go. That's pretty good. Do you want to, can I turn these overhead lights? Would that bother your camera?
To turn them on?
No, just this group.
Do whatever you want to do. And I'll tell you what it looks like.
But anyway, so course evaluation
Okay,
form,
so
you'll turn
I
those
want
in
to.
at the
Okay,
end.
let me see what happens.
And then I'll give you the CE
Okay, let me
credit
see what
form.
you look like
Fill out your
over
name
there.
on it, and then you're good.
If you want it on.
But you're wearing a white shirt.
Change.
Oh.
So we need everyone to fill it out. And then I'll grab your name. So.
All right, you're totally black.
Okay,
Hold
we'll
on,
turn.
but
Let's
she's
No,
turn
no,
the
no,
light
wait,
on.
no, I'm going to put this light on you and see what happens.
The spotlight.
Does that bother you on your
Yeah,
face?
that's pretty bright. I think we'll just turn the light on. That seemed to work okay, didn't you?
Yeah, I mean, I was.
Otherwise, it might change it, and that's not so good for you.
I want to do what the doctor did.
I'm turning it back.
Break on the breakup.
Hey, that's the one which
How's
one.
that?
Well, it's fine with me. Let me just have you look again and see. Is that bothering you, that amount of light? If it is, tell me and I'll dim it.
That's bright.
Did you see it go down?
That's okay. Does that give enough light?
It's not perfect, but it's okay.
Well, make it
No, it
perfect.
really is. I'm wearing a dark color. Go take a look at me. Of course, yeah, we both have light hair.
It looks fine.
All right.
I don't know, it's up to you. You're the judge.
All right, then I say we're good.
Okay.
Yeah.
That light helps, huh?
I've got fresh ones in case
A
you
little
start
bit.
fading, but I don't.
That's what you got.
Thank you.
That's what you do.
Okay, we're ready to go.
Okay, we're ready to go. We're missing a doctor here.
Okay.
She didn't pay attention to keeping her trains on.
How's that? Okay.
You gonna stay warm now? Okay.
Hey, I do that too.
All right, a couple more announcements. We always have announcements and administrative work to do. That was a great lunch. Thanks for everybody joining us for lunch and being around the table. It's great to learn more, and we got April's question asked and answered. So we want to remind everybody of the opportunity for your children, your friends' children, your ex-spouse's children, whatever it is.
Grandkids.
Grandkids. Oh yes, Kathie, I'm sure has told the story. If she hasn't, she will, about her grandchildren, both of which are in this program. So we want to remind you of that. Also, Leslie and the team have been very accommodating. We have a doctor that's going to be here tomorrow who's bringing somebody to the Saturday clinic at 7 a.m. because they can't be there the full day. So whatever it takes, we'll be glad to accommodate. April has a situation that Dr. Sandu is going to be working with, and you guys will figure that out. So we got all kinds of opportunities. And remember, that opportunity includes a $2,000 discount for your families and family members Saturday. You don't call 2 weeks from now and say, hey, oh yeah, we're talking about Saturday. We're going to make an exception in a few cases here because they can't be there Saturday, but they'll be in the office Monday, Tuesday, Wednesday, whatever. Okay? All right. I think that's and we're going to start, I don't know when the next break is, but it'll be the proper time for potty breaks. So they will continue to refresh the coffee and the water and the Cokes. And take it away. We're ready to go.
Okay.
Okay. Here we go. Thank
Rock
you.
and roll.
Are we ready?
You are on, sir.
Okay. You'll be amazed at how many children tomorrow will be candidates. Almost every child has some problem, and whether it's sleep or orthodontic. Anyway, I'm going to talk about a subject that really is close to me, and I love to talk about the Night Guide C-Series, Healthy Start Kids, we call it. But this is an appliance, if I were to predict all orthodontics within the next 20 years is going to be done this way, one way or another. Whether it's from what I do or somebody else does, I don't know. But it is so easy and simple, and teeth move so fast. It's almost like running a hot knife through butter. The teeth move that quickly. Anyway, we call it the Night Guide. I call it the C-Series for children. It is used usually in the 5 to 7-year-old child. Now, this morning I was talking about the habit corrector. And we would use the habit corrector maybe for a month, maybe 3 months. Maybe we'd want to use it for a long time, depending on what the severity and what the symptoms are. If they're mouth breathing, I would have them wear that continuously at night until the mouth breathing corrects. Then we can switch and use this appliance. Now, if we want to use the two at the same time, we can do that. We can wear the habit corrector at night and have this appliance worn maybe an hour passively, maybe 2 hours at the most during the daytime, and you can wear both until the mouth breathing is corrected. Then we would have this appliance only used at night. This is used while the child sleeps. And that's why it's so simple, because you don't have to get a child to wear it 2 hours a day, which is the biggest problem during the mixed dentition. So anyway, we're going to talk about this appliance. And the real purpose of my developing this appliance was that, number one, it could be used so easily. We could straighten teeth only while the child sleeps. And number two, we could eliminate almost all relapse from occurring, particularly in crowding. This is a major problem in the orthodontics today, is that crowding relapses long term. Anyway, let's get started. We would start with a habit corrector, traditionally, in almost every child. If they're before the first tooth breaks tissue, we would not use it until the first incisor breaks tissue. It's usually a lower central. When that breaks tissue, that's the time when we would start this procedure. So we either go to this appliance or we go to this appliance. They're both soft appliances. This one opens in the front primarily because if a child's a mouth breather and they only have second deciduous molars, no first permanent molars in the mouth, we would use this system. It's called the C-Series. It looks like a C, it's for the child. Now that appliance is not used for very long. It might be only used for 5 months. And then we would convert to what we call an interim G appliance, which is an occlusive guide or G-Series, but a softer material. Because the child's not going to bite into this appliance, they're just going to wear it passively at night. Now, if the first permanent molars are already in, let's say 6 years or 6.5 years of age, we would start out with this appliance. This is called an interim G. It's a soft G-Series occlusive guide appliance. And that would be used while the centrals erupt. Now when the laterals start erupting, we would put a bigger one in, which is this appliance. And this appliance then would be big enough to accommodate the teeth when they're perfectly straight. And that appliance would also be used as a retaining device at the end of treatment and be used all the way up to about 12 years of age. Then the patient is dismissed at that point. Okay? So that's kind of a review of what it is. How does it work? Well, if a mother takes a look at her child at this point, they think, oh, the teeth look beautiful. The more perfect the teeth look in the baby dentition, the deciduous dentition, the worse they're going to look in the mixed dentition. Because the teeth are close together. 80 to 90% of the children that have teeth look like that are going to have crowded teeth. Okay? We're going to start when this tooth first breaks tissue. And I don't care where that tooth is. It might be really lingual, but the margins of that appliance will cover over that tooth. And as the tooth erupts, its own eruption force is going to move that into this template where the perfect incisor socket belongs. So that tooth is going to be moved forward into this spot. Now the spot isn't big enough for that tooth, so it's going to push these teeth on either side, widen them, and open that arch up. That central incisor will open the arch up 1.5 millimeters. You know, we're not talking about very much space. They call orthodontics the 3 millimeter specialty because we're dealing with 3 millimeters here and there. You know, and it's they're not very much, but 3 millimeters makes a big difference in the lower dentition because it will crowd these teeth. So that tooth's going to come in. Now the other central is going to come in, and that enlarges the arch another 1.5 millimeters. So you're going to get 3 millimeters when those two teeth come in. Now you never want to extract a tooth adjacent to a tooth that's coming in. You can extract a tooth above it, but it's usually not necessary. But don't ever extract. For example, people see that the lower teeth are going to be crowded, so they take out both deciduous canines. That's the worst thing you can do, because that's going to convert that child into an extraction orthodontic case with the extraction of 4 bicuspids. So don't do that. You're overlooking the fact that the arch is going to expand. This is a dynamic arch. This is not a static arch. When you look at an 8-year-old child, it's a static arch. That's the end of it. There's not much more changes coming. This arch is changing. So you've got to anticipate the changes that are coming. And that's why this Conrad Voorhees was important with the research, because he showed what happened in cases that were straight. Okay? Now when the lateral comes in, that's going to open up that arch another 0.5 millimeter. When the other lateral comes in, that opens up another 0.5 millimeter. When you add that all up, 3 millimeters for the 2 centrals and 1 millimeter for the 2 laterals, that's 4 millimeters. That's the average expansion that we get from using this appliance. Now there are times that maybe I need a lot more than that. I've gotten all the way up to 8 millimeters of crowding compensation. That's the width of 1 upper lateral incisor. Now when all 4 teeth are in, no more expansion is going to take place. That's the end of it. That's the end of the lower arch. That's it. This is the same case, by the way. So it started. You can see the crowding here. You can see crowding here. There's hardly any room for the lateral, and this is the case at the end. 7 years, 11 months. She started out actually when she was 5 years, 7 months. So that's about 2 years. The average is about 2 years. Sometimes 2.5, sometimes 1.5, sometimes longer, but usually about 2 years. Okay? And all that child did was wear an appliance at night while she went to bed at night. That's the only thing that was ever done. Nothing else. So it's very simple. And the child has to wear it every night. So it's easy to get a child at this age to wear it every night. They think, oh boy, I'm a big child now. I'm straightening my own teeth. I got my own appliance and all that business. And if their older sister had braces or something, she thinks, oh, this is wonderful. I'm getting my teeth straightened at 5 years of age, 6 years of age. Now when they go to school, they have straight teeth. So the principle is that the tooth is going to squeeze, but it has to come in straight to squeeze those teeth. Not many teeth come in straight. They come in rotated. And you can look at an intraoral x-ray film, and you can see rotations in the front teeth. When you see those, and there are broken contacts, 3 or more, there's going to be an 80% risk of crowding of that child. So we're looking for children that have tight contacts, up to 4 millimeters, even 5 millimeters. 5 millimeters of space between the teeth, there's a 50% chance of crowding. For them not to have crowding 100% of the time, there has to be 6 millimeters of space between these teeth. Not very often, and that's why most children have crowding. So crowding is a huge problem in orthodontics. So we're looking for guiding these teeth in, and we're going to force it to come in between these 2 teeth. Now this one, there's not going to be much expansion from that tooth, but you can show the mother what that tooth looks like. And that's why the mother doesn't understand this procedure very much before that first tooth comes in, but when they see how big that tooth is, and you say there's 3 more teeth coming that are big as that, and even the side ones are bigger than that front one, they suddenly realize, hey, things aren't going to look so good for my child. And you have to stress to the parent, and it's usually the mother, it's prevention. This is 100% prevention. We're not talking about orthodontic straightening. We're talking about preventing teeth from getting crooked to begin with. We're going to prevent overbite from developing. We're going to prevent overjet. We're going to prevent the joint problems from becoming TMJ, and we're going to prevent crowding and rotations. It's a prevention. It's the only prevention appliance available that I know of. So we're talking about prevention for children, and mothers do understand that. All the fathers interested in usually, and I shouldn't really say this maybe, but they're interested in the fee. How much is it going to cost? But the mother's the responsible one. And we tell the mother, you're responsible for your child to wear this appliance as we direct. So you throw the burden of success on that mother's shoulders. The mother is responsible for the success. You don't have it, the mother has it. And if the child's not going to straighten their teeth, if they don't wear the appliance and they're not doing it, you quit in 3 months. That's it. And the reason for that is that you only have successful patients walking out in the street. And every successful patient will send in 4 to 10 other cases to you. So suddenly you're the only one around that's doing this, and the word spreads. I mentioned Dan O'Brien's name to you once before. He's from Renton, Washington. It's a suburb of Seattle. I invited him to I was given a seminar in an orthodontic office, and there were about 10 orthodontists there, and I asked the one whose office it was, I said, would you mind if I brought a pediatric dentist to the seminar? They're all orthodontists. He said, no, that's wonderful. So he came. Now, he had been using our appliance, the G series, for several years to straighten teeth after 8 years of age. And when he saw this, he said, I don't think the mothers are going to be interested in this. I have my doubts whether this will be successful with my practice. He came back a year later and he talked to my wife at one of the meetings. He says, I got the golden chance of Seattle. He said, I'm getting every child from Seattle. I says, I can't believe all the mothers that are interested in doing something for their child before 12 years of age. So what happens usually? The child goes into the orthodontist. Does the orthodontist know how to handle that? He has no idea what to do with that. That's to your advantage. And besides that, the child is 6 years of age. They're not interested in 6 years of age here. They are in Italy, they are in Finland, but they're in Brazil, but they're not interested here. They're interested in 8-year-olds. I've been told as much. They don't want to be bothered with these younger kids. And so the field is open. And if you're the only one seeing 6-year-olds, believe me, you can see a lot of kids. 93% of the children you look at are candidates for this procedure. When you combine that with sleep problems, almost 100% of the kids have some problem that you can rectify for that child. Okay? So this is kind of an outline of what it is. So the average, the mean amount of correction that we get on these cases is about 4 millimeters. However, we get a total of 7 millimeters. We can get a total of 9 millimeters in the upper. I've had cases as much as 9 millimeters. That's the width of an upper central incisor, gaining room. We can gain that room in several different ways. But mostly this is from stripping of deciduous second molars and the enlargement of 4 to 5 millimeters. We get an enlargement of 5 millimeters on the average in the upper and 4 in the lower. So when you add that up with stripping of 4 millimeters, you can get 3 millimeters of it. That's how we get up to 7 millimeters. Now, if you want further correction, you go back earlier. If you see that the permanent teeth are very, very large, they're usually 5 millimeters larger than the baby teeth on average on the lower. 7 millimeters, 6 or 7, I think it's 7 on the upper. But if you see an unusually large tooth, you might want to bond up the deciduous spaces at 4 years of age. Just put some composite on the first or second deciduous molar on the mesial or distal there and bond up that space. Now when the molars are up, they're going to erupt, they'll be held more distally rather than closing that space. When the first molars erupt on the lower, it closes all those spaces. And it closes very quickly at around 6 years of age. So you want to get in early. The other thing I mentioned to you, you can put composite on the distal of the second deciduous molars. Okay? So here's a child. 2 centrals coming in lingual. Chances are the tongue can push those forward. As they come in, the tongue affects that. But when the laterals come in, they're rotated. Broken contact here, broken contact there, broken there, broken. There's 3 broken contacts here. That case has about an 80% chance of having crowding. Worth a bet to try? Oh yeah, sure. Only a 20% chance that nothing, they'll come in straight. Chances are they'll come in crooked. So here they are, and here's the girl as the 2 centrals has been moved forward. There's even a space between the 2 centrals now. And now the laterals are coming in, but make sure you see how rotated those are and short of space they are. When we take a look, here they are coming in. Let's see where, this is B. This is another 4 months. Total 25 months here. It's almost 2 years, and the teeth are pretty straight. And here it is after the child is 9 years, 8 months of age. And they're perfectly straight. Now the fibers are forming around these teeth all the way down to the root end. And those fibers stabilize. That's the reason for fibers. They stabilize the teeth. I don't know if you've ever extracted an erupting tooth, but you can get that tooth out very easily. You have to be very careful when you extract a tooth next to an erupting tooth that you don't extrude and remove the baby tooth or the tooth that's next to it. So these fibers form, but it takes about a year and a half for all those fibers to form. Carl Reiten, he was a Norwegian researcher on histology of tooth movement many years ago. He published about 5 articles in the English language, 3 of which said this. He said if the orthodontist was wise, he would straighten the teeth before the roots were completely formed and the fibers were all formed on those teeth. We could eliminate relapse. And I thought, I have this thing right in front of me. And all of a sudden I realized, hey, I can do that. So we tried it on a case, and it was very successful that we could guide teeth in and enlarge the arch. So anyway.
Did you have to use cleats on that?
Pardon?
Did you use cleats on that specific appointment?
Did I use what?
The cleats at all?
No.
That was just the appointment.
Very rarely do you ever use cleats on these young kids because it'll rotate. I'll show you a tooth that was almost 90 degrees rotated, and it rotated all the way around. If you question what I'm talking about, and you do orthodontics, I mentioned to an orthodontist, if they question what I'm saying, I'll give them this reasoning. You take 2 bicuspids, one bicuspid that's been in the mouth for 6 months and one that's erupting, and they both have the same rotations. You put brackets on those and straighten them out. You keep track of how much force and how long it takes to rotate the tooth that's been in 6 months, and how much force and length of time it takes to rotate the one that's just erupting. And then when they're straight, you take the force off, and you watch what happens to the tooth that's been in 6 months. It'll snap right back to its original position. The other tooth will stay straight, won't rotate, won't relapse at all. So the principle of this is, once the teeth are straightened, if we make a tooth crooked, it would snap back straight and relapse. It's the opposite of orthodontics. So we can get stability here, and that's what we're interested in. University of Washington, for example, in Seattle, they recommend that you retain the case lifetime. Further retain it the rest of your life when you have teeth straightened. I mean, that's not a solution in orthodontics. You can wear a tooth out, moving it back and forth for the next 40 years. Any of you have tooth straightening here when you were young? Raise your hand. Anybody else? Nobody had their teeth straightened? There's one. Oh, now he gets more. Or are you just yawning? All right. Do any of you have straight teeth today?
My sleep's on the ortho team.
That doesn't count. She's still retaining them. If you didn't wear it, I bet your teeth would.
Although it didn't happen until I was in my 40s that I started getting rotation, and I did end my ortho with a position control, and I had a really good ortho.
Well, my wife is a lot older than you are, and I've straightened her teeth 3 times. I'm ready to straighten her teeth again. They don't stay. If I had straightened her at 5 years of age, she would have had a problem. And this is the problem. 90% of orthodontic cases relapse. Maybe not 100%, but they do relapse.
Why doesn't your wife wear one after you've straightened them so that they don't relapse?
We had a bonded wire down below that held them straight, and that came off. And she's not very interested in having me do them again. She's got other problems that she's worried about. My wife unfortunately broke her hip about 2 years ago, and it became infected, and she had to be in a wheelchair for 6 or 8 months. And then they put a second hip in, and then the third one. So she had 3 hips on one side, and they said she'd probably never walk perfectly again. She was an active woman 2 years ago, but you know, I have to be very careful of her today. But don't ever break your hip if you can avoid it. But it was a disaster for her. Most hips don't become infected, but if they do, it's a terrible situation. So, and she had antibiotics, and she almost died from the antibiotic because she was allergic. She doesn't have any antibiotics left, so I'm very cautious about anything she does. She broke her other hip, you know, wouldn't be able to fix it maybe. Anyway, this is a high-powered microscopic view, electron microscopic view of collagenous fibers. These are around the periosteal bone. Around the teeth, they're all in the same direction. And so they stabilize the teeth. You can see how resistant they are to changes. When you start straightening teeth, you're stretching those fibers. And when you let go, they want to come back again. So we're doing this before these fibers ever form. There are little fibrils around when a tooth is erupting, and when it becomes under occlusal contact with the opposite arch, collagenous fibers form, and this is what links the teeth to the bone, to each other, and to the soft tissues.
Didn't they have a period in orthodontics where they practiced what they call stripping to get rid of that memory? That they'd strip those fibers? And
well, it's called circumferential fibrotomy, and supracrestal has to be added in there as well, so it's a big long word. There was an experiment done in 1929 where somebody cut fibers on the teeth and they seemed to stay straight. There was another fellow by the name of John Edwards, not the same one that ran for president that got into some trouble. This is a John Edwards. He's also from North Carolina. But he did an experiment on about, I can't remember how many teeth, maybe about 25 teeth. Oh, excuse me, 16 teeth. And he straightened 8 of them, and 8 of them he let go and didn't do anything. The other 8, he cut the fibers down to the interproximal bone. And those of the 8, 7 stayed straight. Now long term, there are more that slip a little bit. But, and then he put tattoos on the tissue. And when he straightened them, you could see the tattoos move. And when he did a fibrotomy, you could see the tattoos snap back into place. So it is a procedure that's done. And it usually works quite well with 2 teeth. If you have more than that, it's not too good. But they are somewhat successful. So we use that on adult teeth that we're straightening where the fibers are. But in this procedure, you wouldn't have to do that. So here's a girl, the severe gummy smile. Of course, she's got this crazy smile for you. But you can see that she's got quite a gummy smile. So we prevented the teeth from erupting down into the mouth. So when you look at the child, have her face right straight and have her smile real wide and kind of create an imaginary line from one posterior occlusion to the other, and you will find that the incisors are super erupted. Now when the permanent incisors come in, they will erupt 2 millimeters deeper than these baby teeth. So they would even increase that overbite by 2 more millimeters. But if we can prevent those teeth from ever erupting beyond this line here, and then the crown recedes to expose the clinical crown height, you eliminate the gummy smile. Now, frequently, orthodontists will recommend a Lafort 1 surgical procedure where they cut the maxilla across and impact the whole maxilla up. Well, they take the chance of devitalizing teeth because they can cut nerves and so forth. So it is a severe procedure. If you do it orthodontically, we can do it orthodontically, but you have to depress teeth. That's very, very difficult to do, but it is doable. So any child that has a deciduous overbite and a gummy smile, if you add 4 millimeters to the baby overbite, that's the amount of gummy smile that we can correct in that child. So if they have a 3 millimeter baby overbite, they can correct 7 millimeters of a gummy smile. So that's why we like you to tell us approximately how big that gummy smile is. Now, some kids don't smile very well, so it's hard to tell. When we're in Brazil, you ask a child to smile, oh, they give you the biggest, widest smile in the world. In Finland, people don't smile. Very serious people. I don't know what it is up there. It must be the weather. But the women would tickle them and everything else, and they would real solemn. So anyway, but on the other hand, the Finnish kids wear the appliances. They're very successful doing it. Brazil, you know, Mardi Gras comes along, that's a holiday, let me tell you. They celebrate a week before and a week after, and they don't wear their appliances during holidays. So it's a little harder to get kids to be serious in Brazil, but they're happy-go-lucky kids. You know, they're all good kids. But anyway, this girl's dentition was corrected, but you see the amount of changes, what an ideal dentition she has at this point, and midline's in line and everything else. So why is the lower arch so important? Every time if you ask me to look at some models, I'll probably look at the lower arch first because that's the controlling arch. There's less that we can do in the lower arch than the upper. I've always said we can take the upper and we can jam the upper teeth halfway down the throat and they'll probably stay that way. So it's handy for orthodontics because the upper teeth generally don't relapse. So those are the teeth the mother sees. They don't see the lower teeth. The lower teeth crowd all up, and they don't watch that so well. But because they have a heavy cortical plate of bone that goes around the mandible, and you can't exceed that. You start widening that arch, and it won't stay. The teeth will come back, or you'll resorb the bone off the labial surfaces or the buccal surfaces of those teeth. So the lower arch is very restrictive. Also, the lower molars erupt in a mesial direction. The upper molars erupt in a distal direction. So it allows you to distalize. The upper arch has mostly cortical spongy bone. The lower arch has this heavy cortical plate. So this is why the mandible is the controlling arch in the dentition. It doesn't change as much as the upper arch also. The upper arch can be forward because of thumb sucking. The lower arch is not affected very much. Anyway, that's why we are interested in the lower arch. So here's this is a child with crowded lower teeth, but the upper teeth are fairly straight. And that's normally how it happens. And most of you who have had relapse probably have had relapse of the lower teeth, not the upper front teeth. So this is the principle of the appliance. Actually, the mandible grows a lot faster than the maxilla, and more growth occurs in the back than in the front. But you can see if we had an overbite and an overjet here, if we simply manipulated this growth, if we could stop the maxilla from growing for a certain period of time and allow the mandible to grow at its normal speed, we could correct an overjet. Let's say if we have a 6 millimeter overjet on a young person, and we're going to treat this orthodontically, and we're going to start moving teeth. We'd move the upper teeth back 3 millimeters and the lower teeth forward 3 millimeters with rubber bands, elastics, and so forth, and we could correct the 6 millimeter overjet. However, we've moved teeth almost 100% to get our correction. What if we could put an appliance in that would stop membranous growth from taking place in the maxilla? Where that appliance, it would stop that growth, and we could allow the mandible to grow forward. The mandible in a actively growing male, for example, can grow 6 millimeters in 1 year. We could correct a 6 millimeter overjet without moving the teeth at all. We've manipulated growth to correct the problem. And this is why functional appliances are so successful. Now, when I was younger, the Europeans used functional appliances a lot. And they were talking about correcting 10 millimeter overjet successfully in young children. Now I thought that's impossible, because the child doesn't grow that much. They can't get that much growth in the mandible in a year. Until I tried it myself. I tried one and I thought, oh my gosh, this thing works. And that's what got me interested in trying to manipulate growth in a child. So, in fact, the first man that invented the bionator, which is the precursor of all these other functional appliances, really, in 1930s, early 30s, he would take a young child and he would grind off the occlusion. He would make it like a slide, like a slit, without the cusps. And he found that the mandible would come forward in those children better than if he didn't do that. And so in 1936, he developed a rubber appliance called the monoblock. And that advanced the mandible, held it forward, and allowed the mandible to grow forward. Well, there's not much difference between that and a lot of the things that I'm doing here. So it's similar, and the activator was developed after that. So that was the beginning of most of these functional appliances, and they all kind of work the same, except this young appliance works a little differently because we're preventing teeth from erupting and doing things. So in essence, the appliance has a lot of material in front that encourages teeth to be depressed, and it has very little material in back, so it encourages the back teeth to erupt. So it opens the bite by doing that. However, in this C-series for kids, we're going to stop the upper teeth from erupting. Say if we started back here, we'd prevent that tooth from erupting, so we'd have an overbite that would be at this level because that's the level of this tooth, and that would be able to correct the overbite. So here is spacing. How does it work for spacing? Well, it's simply going to bring the teeth together. However, there's larger teeth erupting here. But if we have multiple spaces that are present, it would simply be a slightly smaller appliance, and we can close those spaces. And in the lower arch, it's the same thing, but you don't have massive spaces in the lower arch. Now, sometimes we have very small permanent teeth. And if they're very small permanent teeth, maybe we can only bring them together so far, and then you'd have to put composite to make the teeth bigger. But these are things that would have to be done even if you treated it orthodontically. Okay? Maybe a lingual wire. Sometimes we put little wires in it. If you see right here, this is a 20 thousandths wire that we put in here, and it's to move the front teeth together. So if the child has multiple spaces, we put these wires to bring the teeth together, and then we'd bond the lateral of the canine slightly bigger to hold that space together at the end. So this would be the same as if you were to put brackets on the teeth and move the teeth together one at a time. We're doing the same thing with this appliance. Unequal spacing. Here's a child that has a lot of space on the left side, but not much space on the right side. You see the midline is way off here. So we would like to decrease this space and open up space for the canine on the other side. Well, if you did it orthodontically, you'd have to put brackets on all these teeth and move them over one at a time. That might take you a year and a half to monkey around with that. Instead, we put two little wires. We put a little wire over here that's a little bit short of that tooth, and it's going to move that tooth over this way. And then we put a balancing wire over here that doesn't move, but it just allows it to stay in place. So now the child wears that appliance, and they're going to simply shift these teeth over, and we're going to close the space over here and open the space up gradually. So you see it closing over, and here now the midlines are in line, and you have enough room for the canine and just enough room for this canine over here that was crowded before. So there are a lot of things that you can do, but you see the teeth gradually moving over here. The teeth are closed together. They were spaced up here. We're moving the teeth over a little. Now this space is going to be closed, and you can see it here. So we've just moved the teeth over. So you can do a lot of things. With these little wires, you can open up the canine space. You can distalize the bicuspids. You can do all sorts of things with these little wires. And you see the space here. You see all the space over here, but now there's just enough space for the canine just to slide down into position. And the socket that's in there will allow that tooth to slide down into position. And the wires, we simply take what we call a bird beak appliance. We put it in the mouth. We push that wire in. We don't heat the wire. We put it in about 1 millimeter short of the distal surface as gingerly as possible. We push it through the lingual, and then we turn this over and we pull it back in so this grabs into the appliance. We leave about 1 millimeter of plastic above the wire. And then we snip the label off and turn this in, and then we try it in. So the patient has to be very careful when they put this in because they have to put the wire around the tooth, and they can stretch that appliance about 3 millimeters to get the other side in. If they carelessly bite down, they'll bend that wire, and then it won't be effective at all. So this is a very easy way to shift teeth. So if your midline is off, I would like to know if it's off on the upper or lower, because we might want to adjust that. If it's off on the lower, we'll adjust the lower so it's in line. Now maybe the parent wouldn't notice that, but you know, if the teeth are off center, well, they usually can notice that. It's not a nice thing to have. Here's the wire in place. Here's the appliance in place with both wires. Once this wire's in, then we put the other wire in the same way. We can close the diastema. We can close a 4 millimeter diastema in front by doing that. And if it has to be closed one way or the other, we can put one wire with more pressure and the other wire with less pressure. It's a very painful movement, so you don't want to put the wire more than 1 millimeter in from the distal surface. And you put it as gingerly as possible, because then you can get more bodily movement. You see, this wire's been put way up here. This one's down here. So it gets good bodily movement. So how about the speed of correction? We can predict the speed of correction very easily. When we're talking about teeth coming in, we're dependent on the speed of eruption of teeth, so that's not so easily predicted. But overbite and overjet in particular is very easily predicted. It occurs 0.8 of a millimeter per month if the child wears the appliance as you direct. And it's about 6 to 7 tenths of a millimeter for overbite. Teeth depend on how fast they erupt. So here's 2 teeth that are erupting, and here they're in. Now that the lateral is lingual, it'll move that tooth forward, and here she is. At 8 years, 3 months of age, the teeth are perfectly straight. How about overbite? Overbite, as I mentioned, corrects at about 0.8 millimeter per month, and this is very accurate. In fact, if they have a 6 millimeter overbite, we know that that's going to take 6 to 8 months to correct. And so this is why we want the overbite and overjet measured, so that we can tell approximately how much. If we can't see the picture too firmly, or if the picture's been taken at an angle, we can't tell what that overbite is. But we can tell you how long this is going to take. You can tell the parent, if they wear the appliance the way you direct, it'll take 6 to 8 months to get the correction. Now you bring the patient in. Usually we have somebody call the patient the first night. And if, I don't know if I can adjust this thing, but it's making a funny noise every time I say a certain word here. But anyway, the first day, somebody might call that child and say, "Are you wearing the appliance?" Now, if you have somebody in your office that's a very attractive young woman, she might be the best one to motivate these kids. And you already see what's coming, right? When they bend over an 8-year-old boy and they say, "Jimmy, you got to wear this appliance," believe me, his heart is pounding so hard you wouldn't believe it. And if she calls him the first night and she says, "Jimmy, did you wear your appliance?" He said, "No." "How can I love you, Jimmy?" And his heart starts pounding again. So, you know, she can get those children. If you have somebody in your office that can't motivate the children, find somebody that can. So there's always somebody in the office that's good at motivating. They have to be motivated too. You know, wherever I go in the world, there's always a group of people that have sold more things than anybody else, and they get a free trip to Switzerland, or they get a free day off, or whatever it is. So I bought a Chrysler one time, kind of a cute story. And I don't know if you're familiar with Lee Iacocca, but he became president, CEO of Chrysler, and he brought it out from underneath and made it a profitable company. Well, I bought a Chrysler many years ago, and his autobiography book was on the dashboard. So it was free with the car. You know, that was my discount for the car, I guess. So I read the book. And he was the best salesman for furniture polish of anybody in this big company. And they never could figure out how he sold so much furniture polish. He was such a tremendous salesman. So he got an award every year. And he told in the book what he did. Every time a mother would pass him in the grocery store, she wasn't looking, he'd throw a furniture polish thing in her little shopping cart. And she'd go through the checkout, and they would be checked and charged to her, and by the time it was done, she'd just leave it in there. So he sold hundreds of these every day, and they couldn't figure out how he was doing it, but he was just one more clever guy than the next guy. That's how he did it. So anyway, the children are the same way, and so you have to motivate the children. And there are several ways of doing that. We have an orthodontist in Ann Arbor, Michigan, that has a 10-speed or 15-speed bike in his office. And every child once a month wins a bicycle. Every time they do something properly, they fill out their name and put the thing in a big bowl, and they pick out one child. Every month a child gets a bicycle. So he's known as the orthodontist that gives these bikes away. Every kid in town wants to go to him. So he only gives one bike a month. That might cost him $200 a month, but he gets every child to compete for that. Another person has a booklet with 6 slots. They put $10 in each slot, and they open this in front of a 7-year-old child, and they say, if you wear your appliance and you get a millimeter a month, you get a $10 bill. And there's $60, $80 there for the child. And so the first month the child comes in and they lay this down, and you look at the case and he hasn't corrected anything, you slowly close it up and say, well, maybe next month you'll respond. But to this month you can't get your $10. We had a pediatric dentist in Pittsburgh, Pennsylvania, that had a whole room full of toys. She had a key that goes in that room. Now she would schedule a successful patient and a kid that wasn't wearing the appliance properly. She'd appoint them at the same time. She'd bring the successful one in first. And she said, you know, you've done so well. Here's the key. Go in my secret room and you select anything out there that you want. She goes, you're running out with a doll or something. And the next kid comes in, and he's there maybe 30 seconds. He says, you know, that last kid got this prize. How can I get something? She says, well, you got to wear your appliance. Otherwise, you can't get into my secret gift room in there. But you've got to wear your appliance. So it doesn't take him long to realize that, you know, if he works, he'll get something in there. I had a dentist in San Diego, California, that a fisherman, there are a lot of fishermen in San Diego, and he called on a Sunday, and he said, I've got a problem. He said, come on in. We'll take care of it, no problem. And so when he was in there, he said, you know, any of your buddies that are fishing out there, and if they have a problem on Sundays, have them call me, I'll fix them up. He had every fisherman in San Diego come into his office. So one of the children was wearing one of our appliances, and he brought a tape recorder out and said, this is going to be yours if you do what I ask you to do. He said, you're going to have to wear this appliance such and such, and it'll be yours. It should be 8 months. And the child thought, that's wonderful. So after about halfway done, about 4 months, he gives the thing to the kid. He says, you know, it's only half yours, but it's half mine. I have to still keep it. But you've earned half of this. You got to keep going. And they would work like crazy to get that tape recorder. So, you know, there are all different ways of motivating kids, but the adult that's in your practice has to be motivated as well. So sometimes it's nice to be able to motivate if they have so many successful patients. Maybe they get a day off or something like that. Maybe I'm speaking out of turn, but that sounds pretty good, doesn't it?
Yeah.
Anyway, here's a little female, 4 years, 10 months of age, and here she is at 6 months, 5 months. Now you see we've eliminated her overbite. Now her permanent teeth are coming in, but they stop at a certain level with the posterior occlusion. And well, this is the baby teeth. I don't care about so much, but it's when the permanent teeth come in that I'm really interested. Here's another one with overjet. See, quite a severe overjet, and you can see it partially correcting. And when we're done, we have a nice overjet. Here's a girl with a gummy smile, and every time this mother came in, she said, I want 5 booklets. I want 10 booklets. I said, what are you doing with all these booklets? She said, I'm sending this to every friend I know. And when she went, her daughter went to a daycare center. She got the woman that runs the daycare center to send a letter to every child's mother in that daycare center that we were doing this, that would prevent a gummy smile and so forth. When she went to a parochial grammar school, she had the nun that was in charge write a letter to every kindergarten and first grader in that school to make sure they had this procedure done. That's how committed some people can be. And sometimes a mother can be your best agent for getting patients into your office. It's wonderful how they can do it. So anyway, she was able to correct her. She had a very deep baby overbite here and was able to correct it pretty nicely. Here's spacing. Lower spacing is not too bad because these teeth are going to be bigger. And there's 1, 2.5, 3, 4. There's about 4 to 5 millimeters of space. There's about a 60% chance of having crowding here, and the teeth have straightened out pretty nicely. Here's a tooth that's almost 90 degrees rotated, and you see how the appliance passively at night rotated the tooth in. And the tooth doesn't stay crooked. We did not have to retain that tooth afterwards. Here's an open bite. Now, if the child is able to substitute the appliance for the thumb at night or during the day and correct the thumb habit, it's wonderful. Keep going at it. But if they don't, they're going to put an appliance in that will stop that. This girl just wore the appliance to correct the thumb sucking. She substituted and got this correction. So indications for the Healthy Start appliance for kids is that there's crowding. No deciduous tooth spaces. Maximum 1 to 2 millimeters of deciduous crowding. If there's too much baby crowding, it becomes very difficult without extra help. Now you might have to strip teeth and so forth, but I mean usually 1 or 2 millimeters of baby crowding is about all we can do. Even with 4 millimeters of space, we recommend correcting it. Overbite, 1.25 millimeters or more. Since they're going to increase 2 millimeters, any overbite over 3 millimeters would be a correctable case. Any overjet over 3 millimeters or more is correctable. Any spaces, any amount is correctable. Open bites, result of thumb sucking, we can correct with this appliance. Or we would prefer to put in a habit corrector with such a device. Deciduous gummy smiles over 2 millimeters with baby overbite present is a symptom. TMJ, most symptoms, if the disc can be recaptured over the condyle. And I might just describe to you, if a child has had clicking, the clicking represents either the disc coming up over the condyle or snapping back off of the condyle. So as they open, the faster that disc can snap up over the condyle means that they will function with a disc over the condyle when they chew. Now when they close, the disc might slowly come out of there and not have any closing click. But when they close, the sooner that goes over the condyle means that they will function more. So those are minor cases. If the disc never can snap over with limited opening, that means that they're functioning bone to bone in every dimension, and they get tremendous pain because as they open, it squeezes the disc and the blood vessels and everything and the nerves. That's why they get more pain. So they can't open very far. Those are called closed lock, and we don't recommend that be treated. So anyway, TMJ, we find that there's about a 540% reduction in TMJ in young children. So you test it from an end-to-end opening. We've mentioned that before. And of course, sleep disordered breathing issues. And both orthodontics and the sleep issues should be talked about to a patient. What to look for at your first exam? I want to look at, see what the teeth look like. Are they close together? That's a case. Is the tooth that's coming in pretty big? If it's rotated, that tooth will never be straightened out by the tongue. It's not going to straighten out, and so they'll have crowding. This tooth is very crowded here, so is this one. And they have to have another central come in here and 2 laterals. This is a very, very difficult case. So we want to start as the first tooth starts erupting. That's very important for us. So, Class 3 corrector, we haven't talked about that yet, but it is an appliance that can correct Class 3, pseudo-Class 3 cases. No spaces up to 4 millimeters of spacing. So these are 2 cases that we would correct. So we take a look at the lower arch, and if they represent that, they are correctable. Those are good cases. And it should be explained to the mother. If she looks at this, she doesn't appreciate what that case is going to look like. But when the first tooth comes in, she thinks, oh boy, she can see it right away. And so that is the time when you can get the mother to listen to you, and they become very excited. And if you stress prevention, they like that. Overbite. This is a deep baby overbite. It's going to be 2 millimeters deeper. So almost the entire lower crowns will be covered. Be a deep overbite. Doesn't look like it now. But here's the case at the end. Overjet, 3 millimeters or more. We'll correct. Gummy smile again, same type of thing. The gummy smile corrects very nicely. Facial problems, class 2s, where they have a facial disfiguration a little bit. We can improve that. We can straighten up the profile very nicely on children. Make them look really nice again. Open bites. No skeletal open bites, but as long as it's from thumb sucking, we can correct those very easily. Pseudo class 3s. When they bite down, and the first teeth to touch are the incisors. That's the real position of their teeth. And it's a slight class 3 maybe, but it's not as severe as a full-blown class 3. But then when she closes all the way down, she slides forward, or he rather, and goes into what we call a pseudo class 3. These are very easily corrected. You can wear this class 3 appliance, and it moves those upper teeth forward, maybe a millimeter or two, and then it's corrected. Might take a week, might take a month, couple months. Very quick, very easy. So when we take a look at class 3 cases, this is a study done by Reyes, published not too long ago, and he compared children that had class 3 skeletal to children that had class 1 malocclusions with normal growth. And you can see the class 3 even is observable back at 6 years of age. And it becomes greater and greater and greater the older they get. This growth spurt occurs a little bit later in these children from his research. So we would like to get a hold of a child back here and try to limit the effect. And maybe we can create a limit where we might cut the class 3 maybe in half even by the time they reach 15 years. Most of these cases are treated after the growth is finished, maybe 17, 18 years of age. And if it can be corrected without surgery, how much nicer that is for the child. Sometimes we can just extract the lower incisor and close the teeth together. Sometimes we can put in what we call a reverse havior and pull the upper arch forward so we can adjust the occlusion if the maxilla is a little bit recessive. So anyway, this is the story of class 3s. Here's a cross bite of the upper teeth and was corrected out. Here it's at 7 years, 8 months of age, even a cross bite of the posterior teeth and fully corrected. Here's a child with lingually inclined upper incisors. You see how lingually they are? And now as an adult dentition, they're quite upright. So about 75% of lingually inclined incisors end up with lingually inclined permanent incisors. This is due usually to the force of the lips. So in Finland, when we would take photos of children, we would indicate how much force it would take to pull cheek retractors apart. And the ones that had lingually inclined incisors had very taut lips. You could hardly pull them apart. So that's what was probably causing it. Why? We can change it at this age, but later after the permanent teeth come in, we cannot change the torque of those teeth. Sometimes we can put little metal cleats behind those teeth and push them forward a little bit. Makes them look like we've changed the angulation, we're just tipping the teeth forward. But that can help in many cases. 3 fingers should be able to go in there, and we check in the condyle, pull in forward, and then we check in front. Very rarely does a child have crepitus or kind of crackling sound, but about 5% of them might have clicking sounds. And we want to know if it's regular, day and night, every day, or if it's just sporadic, periodically. They might chew something hard candy, and maybe disturb the joint, or they might sleep wrong at night and the joint might be affected. That may be the day that they're coming in to see you and they have a click. The next time they come in, you check them, they don't have a click. So we recommend you check the joint every time they come into the office. What shouldn't be treated? Are there cases? Oh yeah, there are cases that we shouldn't attempt. Severely crowded baby teeth like this, there's going to be a high risk, 100% risk of crowding. And what do we do? What can we do in this case? Well, we might be able to put a bumper in and distalize these teeth 2 or 3 millimeters and get enough room. But with the appliance alone, not possible. So we would tell you that. Here's bonding. We would put some bonding on the distal. So we force this molar to erupt more distally. If the lower molars are distally inclined, those cases have less future crowding than if they come up upright or forward. And Sandin and Severa found that years ago. If we can bond deciduous molars, we can bond this space, which has been done here. Added some bonded material so we can pick up maybe a couple millimeters at about 4 years of age, because he has very big incisors coming in. We've bonded that space up. So now when the molar comes forward, it's not going to close that space. So this space very quickly closes from about 4 to 6 years of age. When the 6-year molar is in, those spaces are all closed. We call these, well, these are interproximal spaces, but when the baby teeth are lost also, the forceful eruption of the second molar closes all that, and that's called the leeway space. And we would like to get started in a child before that all closes. That's why we would like to get in while the first molars or even before are present. 2 fingers is a sign that they have limited opening. So it shouldn't be treated. Cleft palate children. Takes a lot of individual orthodontics to treat a cleft palate child. So we don't recommend you do that. Severe psychological problems. The child might suck their thumb all the time and they have other problems that, you know, if you try and correct the thumb, it's not going to correct perhaps. Maybe they need to get under psychiatric treatment. Closed lock TMJ rather. Skeletal class 3s that are long face, open bites, tongues forward. These are difficult to correct. We call those skeletal open bites. Multiple missing teeth. I would say over 4 missing teeth are very difficult to deal with. So we don't recommend you do that. Deciduous crowding over 2 millimeters. Unless you use a bumper or other preventive procedures, very difficult for the appliance to do that on its own. 93% of 5 to 7-year-old children are candidates, and this has been shown by a couple of other studies, and highly angulated canines that will result in impaction. So these are all contraindications. You don't see these things very often, but they do pop up, and so we'd like to be interested in that. How to convince a parent. Stress prevention. Mothers love prevention, and if you can prevent a malocclusion, and you might say that we might prevent extraction of teeth later on, nothing disappoints a mother more than if they go to an orthodontist and the orthodontist doesn't know what to do with the child at this age, and they put them on every 6 months recall visit. And they watch the child, and the mother's watching these teeth, and she sees the teeth getting more and more crowded and more problems. And then by about 11 years of age, he says, well, we're all set to start. We're going to take out 4 bicuspids. And the mother goes through the ceiling. And she wonders, why didn't you do something when he was 6 or 7? Why didn't you do something before it became this severe? And she's very irritated. So this is one of the typical problems that happens in a lot of orthodontic offices. Orthodontists are programmed to do orthodontics at 11 or 12 when all the permanent teeth are in. Early treatment in the United States means 8 years of age. That's not early treatment. Early treatment is 5 and 6 years of age. So the American orthodontist is not positioned to do that. They don't get the cases, but the American Society of Orthodontists have reduced the age periodically over the years. Used to be 9 or 10, now it's 8, and then sometimes it's 6. So it varies. In the U.S., it's early treatment is 8, and that's really not early treatment compared to other countries. So we would like to change that, but it's not going to change very fast, which is an advantage to the dentist and pediatric dentists because they can get to these children early. The Finn study showed that there are cases are 95% at least correctable. Very few cases ever needed orthodontics. In fact, she stated out of 167 cases, there wasn't one case that really needed full orthodontics at the end. We use the forces of erupting teeth. I don't know if you're aware, but the force of erupting teeth is quite substantial. It's very easy to stop a tooth from erupting, but it has considerable force. A canine can erupt over here and it can move teeth all the way over on the right side or the left side, several teeth away. First molar can erupt and it can close spaces around a canine way up in front. So it can push several teeth by coming in. So we see that. And they only wear it while they sleep at night. And it's so easy. I mean, they go to bed at night and they sleep. If the mother or the child doesn't want to put it in, we tell the mother, go in after they're asleep and pop it in their mouth, and if it stays in there an hour, they'll straighten their teeth. It doesn't have to even be in all night long. The only exception is that they have an overjet of about 5 millimeters. We need all night wear. They get an ideal occlusion. When they start school, they have perfect teeth. They're not going to be teased by an overjet or teeth that stick out, so forth. And eliminates teasing and so forth. And there's no pain or discomfort. If they come in and they say, I have pain every time I put this appliance in, they're not wearing it regularly. This is particularly true in the appliance that Dr. Menderes is going to be talking about. Lower fee. It's generally about a lower fee. I can't determine fees for you, but on the average, the fee is about half of what an orthodontic fee would cost, somewhere in that vicinity. And there are fewer appointments. And the insurance covers the treatment if they have ortho insurance. So there are several advantages, and the mother should be aware of that. Now, how to convince the child? The child has to be convinced because there's no braces later on. They're not going to have to go through all this stuff later on. And there's shorter treatment time, probably no extractions later. And they have nice looking teeth in school, and no pain or discomfort. Every time we put a heavy wire into a case in orthodontics, they feel pain. And I practiced with a very clever orthodontist, and a patient would call, or a mother would call and say, my child has got this terrible pain, what do I do? And he said, we don't usually allow bubble gum, but you put about 5 wads of bubble gum in your mouth and chew it for 5 minutes, and the pain will go away. And it worked every time. How come that is? Well, when you chew, you increase the blood circulation around the teeth, and the blood circulation is what carries the byproducts of tooth movement away, and the byproducts are what causes pain around the teeth. So it's very simple. Now, when you wear one of these appliances, particularly the G series that you're going to learn about next, they're biting that appliance. Biting, holding, releasing. The blood goes out and then it comes back in. Goes out, comes back in. And we find if we do orthodontics afterwards, it goes so fast it's not even funny because we've increased that blood circulation. It increases the speed of treatment. So now somebody's come out with a device that vibrates the teeth and they can speed up treatment. It's the same principle. But frequently we would wear an appliance before orthodontic treatment, have them bite and release, and we could straighten the case in half the time that it would normally take us otherwise. So anyway, the child can be convinced with that. And we saw a little boy last night, and he wasn't paying much attention until we brought out a little toy, a little box that he could put the appliance in. Then he became so interested. He was ready for the treatment. So that's what convinced him. So we have several little boxes that are probably outside here, they can see, but they're little animal boxes, and he selected a car. He probably wants a car like that when he gets to be 18, right? Maybe we've set up a bad situation for him. Required records, we've gone through this before, but we would like those records complete. And it means that your diagnosis will be more complete as a result. And so your child must keep it away from the dog at night. The dogs love appliances. They've even buried them in the backyard. And what happens is that the saliva in the child's mouth has embedded a little bit in that plastic. And the dog can smell that, and they love that, so keep it away. It's too bad we can't straighten dogs' teeth. We could probably, but dogs don't need their teeth straightened. However, there was an orthodontist near me that would buy dogs that had pedigrees, but they had crooked teeth, and he'd straighten the teeth with braces, if you can imagine that. He'd get the teeth straight and take the brackets off, and he'd sell the dog. Of course, after 6 months, the teeth were back crooked again, but by that time, he got the money and put it in the bank. But I mean, sometimes things happen like this. Anyway, what do we look at during the insertion of one of these appliances? We look to make sure if there's potential crowding coming, we want to make sure that that appliance is a bit bigger than the teeth themselves. Okay? The object is that the appliance should fit the teeth after they're perfectly straight, almost ideally. So while you're straightening them, the appliance always has to be a bit bigger to anticipate that correction. So we take a look at the interproximal. If you notice here, the interproximal between the teeth is right there, and the interproximal in the appliance is right there. So that's not going to allow any expansion. It's going to restrict expansion. It's coming. So that appliance, if the child is going to have crowding, is too small. So we put an appliance in that's bigger. Each half size on the lower is 0.8 millimeter bigger than the previous one. It's 1.2 millimeters bigger than the upper one, from mesial of canine to mesial of canine. So if you have a millimeter coming, I would put an increase of a half size. If you're using a 4, I'd put a 4.5 in. If you have 2.5 millimeters of crowding potential, I'd put, instead of a 4, I'd put a number 5 in. That will allow for 1.6 millimeters of expansion and so forth. If you needed 3 millimeters, that would mean you'd go up 6 half sizes. Well, once the child is used to wearing the appliance, you can skip several sizes going up the line and make it work with just 2 appliances. So when you put the appliance in, then now the interproximal is here between the teeth, but the interproximal of the appliance is back here. So you'll have allowed to expansion there, and same here. The appliance interproximal is here, the tooth interproximal is back here. So, you know, it increases. Now, it's not the arch that's increasing it. It's just allowing the teeth to increase. So it's the forceful eruption of the teeth into these sockets that encourages the enlargement to come. Okay? If you put a larger appliance in a 3-year-old, it won't enlarge the arch. It's not going to work. Only when the teeth come in do we get that enlargement. So what to do at every appointment? As the incisors are up, they should be making room for themselves. So you should see that things are improving. Even after a month, you can see improvement. I can straighten teeth in 3 days, as I told you about that one boy. They can straighten very quickly, the rotations. So within a month, if those rotations aren't corrected, he's simply not wearing that appliance. Okay? Check to see if crowding rotations are corrected. If the canine to canine distance should increase. Check about every 3-4 months. You take a little divider, you can buy it in an art store, and you check the width. Compare it to the width of the first model, whatever you have. You can compare it to the appliance to make sure the appliance is big enough for you. Check to see that the overbite and overjet is correcting. Should be correcting every month. Should correct at minimum of 0.5 millimeter per month. If that overjet is not correcting at 0.5 millimeter per month, I'll start warning that parent after 2 months, and I'll say, you know, your child is not wearing this appliance correctly, and we're going to give you 1 more month, and if you don't correct it, we reserve the right to get out of this case. And you want to have that, make sure that's in the papers that you give that parent, that they sign, that they understand that. You're not abandoning the patient. You're just going to refuse treatment after that point. Why waste your time? And the fee would be stopped at that point in most offices. After the 3rd month, if they're not doing it, they're dismissed. Very important. Now, what happens a lot of time, if the mother's a friend of yours, she'll say, oh, I know he'll wear it next month. He'll wear it. Just give him a little chance. He'll do it. Then the next month he comes in. Oh, he's going to wear it. We're just getting busy. We've had a hard time this last month. Pretty soon, 10 months has gone by and nothing's happened. And they paid the full fee. That doesn't make a parent very happy. So this is a much better way. Not only that, but that kid is liable to go out and he'll tell his friends, oh, that appliance doesn't work. Don't go to him. It's not going to work. So you want every patient that walks out of that office to have a completed case with good correction. And that's what you'll get if you're strict about that. Check the TMJ. We check this at every appointment. The appointment might last 15 minutes. And it's so easy to check the overbite and overjet. Take a look at the crowding. You might take a picture if it's had good improvement. And check the temporomandibular joints and encourage the child to continue doing the same thing. And it's done. That can be done by an assistant. It doesn't have to be the dentist every time. So the dentist might come in every 4th or 5th appointment just to make sure everything's going right. And TMJ, clicking, take about 6 months for the average correction. Check if other symptoms are improving. If no in progress in 2 months, especially overjet, check if they're wearing it. Encourage him or quit. 3 months, I give the patients. You have to be very strict about that. If you're strict, you'll have a lot better results with it. And you see that the patient is wearing every night. Now, we're anticipating that when we can digitize teeth, you can digitize the teeth after 3 months, send them in and see if the progress is being made. We can measure that overbite and overjet and tell you if the child's wearing it or isn't wearing it. Depends on what he's corrected. If he hasn't corrected anything, chances are he's not wearing it. Don't ever ask the mother in front of the patient. Always ask the mother in the waiting room. Because every child's a genius. I don't know if you're aware of that. And by the time they're 20, I don't know what happened to all the geniuses, but they're not all geniuses. But the mother doesn't want to tell that her child is not wearing it. If you go in the waiting room, she'll tell you right off, that idiot, he's never wearing it, he's on the telephone all the time, he's not wearing it. So you can get an honest opinion. We also look at that little chart that they keep track of to make sure that they fill it out very accurately. And that's another way. And then the coloration of the appliance is another one. So here we're measuring the distance here. And we can compare it to the appliance. And I've said good expansion. You can see what we have. What to expect at various appointments. So must see gradual improvement at every appointment. You see improvement, particularly in the crowding to begin with, but this depends on kind of the eruption of teeth. If the teeth are slow in erupting, you're not going to see as rapid a change as you do when they're wearing it actively later on. And 5% or less might not cooperate properly with you. So the improper wear is very rare in a night guide situation here. They're usually very cooperative kids, and they respond very well. And the parents' responsibility to make sure that success is proper. So, crowding, not improving. Patient not wearing the appliance. This patient was not wearing the appliance. You see these teeth are becoming more crowded than here. Something's not working. Kid is not wearing the appliance. It's a little girl. She was not good. They'd show up every second or third appointment. They were just very careless. I told the mother, I said, we're not going to get this taste corrected unless you bring the child in every time and that child wears the appliance. I said, it's not that hard to wear it every night. So if the child wears it every night, we're going to get a correction. But the rate you're going, we're going to put braces on this kid. And maybe he'll have 4 bicuspids extracted, and you probably wouldn't like that, would you? So she got busy. So here she is. Now she's wearing it. You see the improvement. Let's go back. See, the improvement from here to here, to here is due to the wear every night. And now she gets a pretty good correction. Now, in this case, I might put a little cleat there, but we didn't do anything to these cases. These cases are without any other adjustment, just from nighttime wear. Here's an overbite, fairly deep overbite, and you can see progress. The baby teeth I'm not so interested in, but I'm interested in the lower incisors being held to their eruptive state about level with the posterior occlusion. Here it is, now the upper front teeth are in, now there's about a 2 millimeter overbite there. And you see them, now the laterals, now this lateral is inclined. Why is that? Because the canine is angulated against the root. Now that angulation is about 35 degrees and the tooth will usually turn and come down. So as that canine turns, this tooth will straighten out. They call this the ugly duckling stage. Broadbent termed this thing years ago. Only about 30% of the kids have that kind of a situation. But when you see it, you realize, now if you were going to put braces on, you'd start torquing that tooth and moving the root over, you could resorb the root off because you'd run it into the canine. You don't have to worry about that with this appliance because that tooth will be guided in properly, and as the canine comes down, it'll make the turn. If it's not if it's angulated like this, we would tell you not to treat the case. Okay? Now you see the canine is beginning to straighten out. The other one was the same way. Now they're pretty well in line. Overjet. Here's a severe overjet, 4 millimeter deciduous overjet present, and you'll see it gradually improve. This is after 2 months. We've seen the child. Usually we see them about every 3 months. Is the overjet changing nicely? Again, the same type of ugly duckling thing because of the canines. And now the overjet is pretty well corrected. The lateral is kind of small in size. We might recommend some little bonding to make it aesthetically a little bit better. Upper teeth, upper crowding. We don't watch the upper very much until the upper laterals start coming in. Centrals come in okay. You can see them nicely together. The space closes. Now the baby teeth, there is very little space for the laterals, but you notice now the laterals are coming severely rotated. This one probably will be rotated as well. See them coming down. Now they're derotating. Finally, they have a nice arch. This is 13 years. So the advantages to the doctor or to the practice is that there are significant fees. There's very low overhead, a high referral rate. Assistant can do maybe even 75% of the work, whereas the dentist might be only involved in about 25% of the time. And only successful cases result. They're terminated and dismissed after 3 months if they're not successful, and over 95% are successful at the end. Contraindications, severe crowding, 8 millimeters. Very difficult unless you start putting in bumpers and things like that. Closed lock TV, skeletal class 3, skeletal open bites and cleft lip. We've talked about that. You're okay at 3 o'clock, right? For an hour and a half.
Yep.
Oh, I'll continue here a little bit longer, then I'll finish, then we'll have a break, okay? So some of the research. There's been studies done. This is a study by Heckman and 82 longitudinal cases. You see the crowding increases from 6 to 8 years of age, but then very little occurs thereafter. How come that is? It's due to the eruption of teeth. And several other research projects agree with this. So the mean is about a I don't know what we got here. The mean, out of 238 cases, the mean was about a 69% increase in crowding between 6 and 8 years of age. So the majority of crowding comes during this period of time, and very little comes thereafter. So, doesn't it make sense if we could do something to prevent that from happening? What if we could prevent it from this point on and they could go straight across here? They'd have almost a perfect dentition by the time they were 12, just by preventing it alone without correcting anything. So that's why it's such an important thing. This green line is the overbite. And you can see from 6 to 12, that overbite increases 2 millimeters. And it increases probably because the overjet just increases a little bit. Because the upper teeth erupt labial to the upper baby teeth, and the lowers erupt a little lingual to the baby lower incisors. So that overjet increases a little bit, and that allows the teeth to increase vertically into a little bit deeper overbite. However, the overjet comes back so that the statistical difference before and after is about the same. But the overbite has increased. So we would like to prevent this overbite from increasing by simply putting an appliance in that's like a plastic shelf that prevents those teeth from over-erupting in the first place. Now in our study in Finland, which was a very interesting, it was one of the larger studies in a longitudinal orthodontic study that ever was done, the control sample, we took 4 towns in Finland, and 1 town was a control sample, which is this group here, and the other 3 towns were the treatment sample. All were treated with this night-guide procedure, passively only at night. And the maxillary crowding was the same between the 2 at the beginning, but the control sample increased. The treated sample decreased to almost 0. Mandibular crowding decreased almost to 0, while this is the control sample. So the control sample is not improving nearly to the same extent that the other is. How about overbite? Overbite decreased. We have an ideal of 2 millimeters at this age, and they decreased to 2 millimeters, while the overbite increased in the control sample. We see the same thing in overjet. So she saw a tremendous change in these children. And at the end of it, she said that there was not one case in the group that would warrant really any orthodontic treatment at the end. So this was a significant study. What was particularly interesting was the growth of the mandible. When we compared the growth of the mandible on the control sample to the treated sample had 54% more growth than the control sample, probably because of the oxygen intake and the increase in the pharyngeal diameter. So the pharynx allowed more oxygen, and perhaps that's what increased this growth. This is the second time we've had an experiment that proved this, and the other one was in Brazil. So this is a very important finding, because it means that if we can increase the mandible in its forward position, increase its growth, we can stop a sleep problem permanently for that child for the rest of their life, because we've opened up the airway. So the research conclusions: 95% of the overbite was corrected, over 100% of the overjet was corrected, no interference with inherent growth pattern. The children grew the same both ways, no increase in face height, does not tip lower incisors labially. 93% of the kids wore the appliance as directed, which is interesting. 72.5% of the kids kept the appliance in all night after 3 weeks. So if they don't keep it in all night, you can have the mother pop it in, but most of them will keep it in. And then the improvement in the TMJ sounds as well. Any additional information? There are many other scientific studies on our website. There are clinical and scientific studies available that if you want to look at, you can. You're welcome to do it. And there are 80 monographs in every aspect of this treatment. You can read all about different things that we feel are important. And the Healthy Start Kids are easier than fixed appliances. The Healthy Start Kids case takes about 3 hours, whereas an orthodontic case for me in my practice would take me 11 hours of chair time. So it's about 1/3 of the time. And earlier treatment uses eruption of permanent teeth and jaw growth to give little or no relapse. So anyway, I'm ending. Maybe we could take a break. Are we ready for a break, do you think? Any questions? Let me answer questions if you have any. No questions, I failed.
I have one.
Thank goodness.
Oh, I'm so glad you're happy to hear from me. You were talking about a number of these cases taking up to 2 years, and it seems to me that I had seen up to 12 months. So obviously there's got to be a distinction between which ones would be concluded inside of a year and which ones take longer?
It depends. For example, if they just have overjet, they can be treated in a very much shorter time. But the average, if they have crowding incisors, it usually takes about 2 years for the teeth to erupt. Now, the next lecture you're going to hear, we'll talk about the occlusal guide, which is a much faster, shorter period of time. It can take 4 months to 10 months to correct, which is about 5 times faster than braces. But this is a little slower. It goes slower, but the completion and the ideal cases are much greater. It's really an ideal way because you get almost all successful cases.
I would hope that the occlusal guide being defined and compared to the other will be clear to the average mom, grandma. Okay.
Question. When you complete the treatment, they keep their last appliance as sort of a retainer appliance.
That's right.
How frequently do you encourage them to wear it after they complete the treatment?
I'm sorry, I didn't say that. I should have. Usually we leave them wear it every night for about 6 months after the laterals come down. And this allows the laterals to have more complete fiber formation, and then we have them wear it 1 night a week until the canines or bicuspids start coming in the lower arch. Then they wear it every night during the exchange of those teeth. And so we keep it in there until the 12-year molars are completely in and all the other teeth are in occlusion. And that usually is at about 12 years of age. Then they're dismissed. And then it might not be a bad idea to watch them after, maybe have them come in when they're about 17 or 18, just to check the third motors.
But ideally, and what you routinely see is they come in at 17, 18, and that appliance fits just like it did when they were 12.
Oh, yeah. And they can wear it. I mean, some of the kids will continue wearing it. Make sure they save the appliance. If anything goes bad, they can put the appliance back in, it'll straighten it back up again.
Good
And
job.
I might compare it. She was asking for the comparison between the two. The night guide will give you a better result consistently, almost better result. The Cluzel guide, the G series, is a very fast appliance. It is the workhorse because there are so many kids between 8 and 12 rather than between 6 and 8 or 5 to 7. And so, but the problem with the night guide is you have to get in at the right time. The window of getting in is very limited. The Cluzel guide, you can get anywhere from 8, 9, 10, 11. You can get in at any time. It's better if you get in earlier, but you can get in at any time. The time that it takes for a G series is usually about 1 to 2 hours of chair time, whereas this takes about 3 hours, maybe a little bit more, but depending on what you do. So it's going to take a little more time, a little more observation, but it's much easier. The kids are more consistent in wearing it. So the results really are better with the night guide than they are with the G series. However, you can get very dramatic changes with the G series. The more they wear it, but now the problem with the G series is that once the foreign sizes are in, to straighten that crowding, you do need active wear. That's the biggest problem with that appliance because you have to get the child to wear it 2 hours or more actively every day by biting. This, you don't have to worry about that. If the child misses 2 or 3 appointments, they're not wearing it, you can get back and it'll restore it like you saw in that one case. So does that answer your?
Actually, what I'd like to do, and I don't know if this would make sense, is if you could have the display out there to line up and to be able to say each one of them and their best application, the ones that are on the entry table.
You can do that.
Is that?
At the end,
a
we'll
visual.
do that. Because after that, you've heard about the G series, which is the next one after our break. We're going to hear about that.
When you said that the contraindication, one of the contraindications was severe overlap in the vestibular dentition for more than 2 millimeters.
What was that? If the overlapping crowding is more than 2 millimeters.
Yeah, and so...
Yeah, that is a case that for natural eruption, that wearing only the appliance, that's a contraindication. However, you could put a bumper in and distalize those teeth and get that change. It'll correct. There are ways of getting around it, but for the appliance alone, that is a contraindication.
So is it not like, because in my understanding, I was thinking it can also create some arch expansion on the way of when they wear it at an earlier age. So will it not do that?
That's right, but we're including that, because a 2 millimeter crowded case is going to be extremely crowded. And it probably will exceed the 4 millimeters that you can get from either the expansion or the stripping. But a case like that, you could get the expansion and then you could strip and you could get it up to about 7 millimeters. But for the appliance alone, very difficult. And you have to be prepared maybe to go in with a bumper if you don't quite make it, particularly if the teeth are a bit bigger. So, okay. I see a lot of soft drinks. Very good for your teeth back there.
Maybe I'll say one thing. After at 3 o'clock when we start, I think I don't have my watch on, we thought we would take a lot of the staff with us at that point and kind of go through what we expect for the diagnostic and kind of the conversation you might have with the patient. And then Dr. Vandanis will speak to the occlusal guide and the G series and the routine with the doctors. So hopefully that will work out. Okay? So go get something to drink, boost up your energy, and we'll keep it on.
It's a good time for you to show me. I'm going to show you the couple things I wanted to show you.
Yeah, I'll take a look.
Thank you so much.
I'm going to close this off here a second.
No problem.
Yeah, I think that would be good.
very helpful for you. Oh, perfect. So, of course, at the later part of the day, I didn't realize you didn't have one. Oh, no, that's great. So,
And I suppose with your touch ability, would you put your capacity with the occupants also operating session, right?
Yeah. Oh, absolutely. Yeah, yeah. That would absolutely be great. Okay, so let me grab one of these for you.
Thank you.
I'm gonna change your battery, doctor.
Okay. This will be your battery.
Yeah, that's it. All right, sir. Thank you.
We'll make life a little bit easier for you.
Yeah.
Sorry. Thank you.
It's a good review.
Oh, yes, no, that's terrific.
Sure.
Check, check, check. Check, 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 check.
No, that's good.
Well, there's sometimes you're not sure what you're taking. So no, I just yeah, you double check it, and then let me ask him what he wants to do. I would hate for you to switch to and then all of a sudden you send them and now we're
Check,
all
check, 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 check,
So let me
check,
just
check, check, check,
just to be
check.
and that's a good question.
Do you guys prefer to have models sent to you or just like scanned photos? Well, it's 6 is perfect. 11 is when you actually see it. Kind of hang it on. Give you the entire PowerPoint. And you everything you need, so you don't have to do it. But it's a scan. It's just not. It's just not. You might get better at it. No, it's just not. The more we can visualize and then on the mechanics of the yeah, yeah, right. And we'll ask you the same thing. We're gonna have some changes, full things of what you need to do. But we're gonna get to through it. My son has a scan by that time. 2 miles will have it. Barely moves. You take it out. I'm like, oh, I don't have it. Don't you need what you need to do? Each need you should do these numbers with the numbers come in. If you need a fee, one minute. Let's do it. Let's try to find serious. This is really I told him I was or sometimes we might but I want you to understand their values. Oh, he was freaking out.
What's he gonna do?
When they come in, it's not a half hour.
Sure.
It's a whole foggy. Right, if you see it, and if you see a change, sometimes you do cartwheels, you do one bump, you come in and say, oh my gosh, it's the biggest crush you've ever seen. I did the same thing, you know, can we take a picture? First time I have to, so the kid is like, yes. And the mom is like, yes. Probably 4 years ago. It's a great motivation. So we drive up this flight, so we think about it, and then in our
There's a better way of doing something.
Is
If
mine?
the same result, you get an idea of what's. Thomas Edison once said, invention is
I have it too on my USB.
10% inspiration and 90% perspiration.
How do I work this thing too? I guess I should. I just like it. Very thick though. Keys? If you want to stop it. Did he shut it down? I think he did. I like the forms. I need to. Where do I get the forms? Huh? Okay. I think actually you sent them to me. Yeah. No. I did have them. Yeah. No. I have them actually. I just need to. I was like, I don't know who I sent it to. Okay, so yours is 6, right? Just let's double check, just to make sure it has the size. I feel like I'm gonna have to keep it.
Okay. Yeah, I want to make sure I understand
Yeah. What's yours? Right from the start. Yeah. Okay. Perfect. Okay. So wait, let me just try to control it. Yeah, let me start it. Okay. Let it go. Yep. Okay. That's it. Got it.
No, we'll do that. So, I was just showing you real fast, that this one is she tell you. Oh, it doesn't show data? That's very I don't know. That's what I think this is. Is Dana watching?
She's had it on also.
Okay, has she sent anything or?
Maybe not. She did it through she's been texting us like she said cockeyed.
Oh, when they finalize their copy brain?
No, but even it's been between look at it. It cuts off the top. See?
That's because we don't have it on, but this is, the problem is it's tight, and I was thinking about if he were on a podium, then it would be even. Yeah. So on my camera, I'm moving the camera to get more, but he's not on, and I was thinking about this, hold on.
Maybe should we lower it?
If we did that, I think it'd be better,
Yes.
but I'm not the one who set this up. So if you're okay with it, let's just, whoa. Let's do it.
That was their comment was because there's been before and after pictures. They said it's hard to see the before because before his head's been chopped off.
Okay, so now we've got this. Well, his head was chopped off because he stepped forward.
Yeah.
Yeah.
No, not his.
The
like
people
on the
and
screen.
okay, cool. All right, so now this is better, and he's not staying inside of his thing. He's stepping to the left. But I don't want to adjust him when he's talking. I just, he's like,
So now Davis is coming. Oh wait.
oh, that's what
So then,
Let's sit down. Where are you?
We just made one adjustment. We moved this up to lower that.
Is that right?
No. It's because they were saying that from him that it was the same thing. Okay. And honestly, if you want to see where you are,
my own child, so
you'll see it right here. And that's the little box.
what I got back, and I just want to make sure because we transitioned. I have to stand here.
No, if you don't, you'll step out of frame and they won't see you.
I want to see.
Let me just bring this closer to me so I don't have to turn around all the time. So you can see it. Now let me also see if that's, is that getting in your face too much, this light?
A little bit.
The reason that light is because you can see how dark you are.
Good occlusion.
Because there's so much light on this.
We put primer on the buildings to try to help them get vertical.
Don't. It's not necessary.
Okay.
That'll take about 6 to 8 weeks, I would say. The laterals are,
I don't know. I'm fine.
Is that
pretty much
okay?
space here. Can we enlarge this?
Yes, I think you just go like this. And then you can
tooth looks kind of small compared to this one. Does it?
And not so much clinically, not as bad.
Leslie?
And I actually, what I got back was this is my son, so I got back the assessment, so I just gave
Okay,
you
look at the framing on this. Okay, if you want, yeah, sorry. Let's jump to it.
No, it's okay.
Well, I would check the lower.
Okay, you see, even lower down?
No.
Yeah.
But the
Okay, that's
overbite
why
could change
if there's
about 5 to 8 millimeter per month.
podium to stand, or not a podium, but some platform to
maybe
stand on.
tomorrow we can.
This
Yeah, I'll
tooth
bet you
is a little
they,
short of
I can
space,
check and
so,
see if they've got some
I
kind of
would-
a,
Did I recommend stripping?
Or like a podium you can stand up
So,
on,
yeah,
rest on
okay.
the
I would
podium,
strip
maybe
2
that would be.
millimeters from the
What do you
knee
want,
to
too
the
short?
sinus.
well, it's not you, it's the, it has to be high enough for the over the table height to see this. So that's why this is raised. But then you're not raised, and so you can see that it's cutting that off. And unless we could make the picture smaller, and I don't know how to adjust that on the projector so that you can see Healthy Start.
Can we just put something under the projector?
Well, we've already done one thing over there. Let me see. I don't know if they have that one.
There's a little crowding.
try this height.
Second decision.
No, you're raising it up. We want to keep it
Oh, we
down.
want it
We want
lower.
the picture smaller
Oh.
so that it fits in there, or the projector to go back so that it's. No, we did that on purpose.
Okay.
So it needs
Yeah.
to be, but I can't see when I'm doing it. But now what do we just do? Did it disconnect?
No, oh,
How old is she? She's a little younger?
Yeah, she's 8.
what did happen?
He's 10.
All right.
And she,
Let me
I
just
want
make
to tell
sure
you
this
something
is
really
up
cool.
to-
This is when we started.
Almost identical.
Yeah, of course. And then already we had
I don't, what in the world happened?
There's a lot.
Oh, I know. This camera just got knocked, that's why.
I'm like, what?
Yeah.
It won't do it completely, but it's important that she wear. She has no habits. Wear it a month, and then go to the other one.
I just gave her her active times and show you. I just make sure that
Now, if we do that, we can see more of the room, but we see less.
of the slide. Slides warped. This is what they looked like just before I left. I just quickly.
You know what? Everything got smaller.
How we doing, gang?
What happened that it got smaller?
This?
I don't know what would have
We
happened.
move this.
Oh, hello.
Maybe it went backwards.
And then these teeth are gonna.
Should I move
make
this
them distally.
forward?
And
Towards you?
No.
That
Hold on,
case
let me.
will take about
That's the same.
8 months for the overbite, not for the crowding. The crowding will go very quickly. Within a month, you'll see good correction with the appliance. Now, the appliance
That's good
has a
right
socket
there.
that's just the same size.
Well, you definitely see the whole slide,
So it goes through everybody's.
As long as she doesn't have habits, I would just wear it a month.
but this is now
Oh,
cockeyed.
wait.
This is.
We're in
I'm gonna show you why we put that there. When we take this out,
I want you to wear that. indefinitely.
see how high it goes? And then they can't see the Healthy Start on the top.
Good now,
They're both nasal breathers.
because it got smaller. Now it's there.
They don't.
Is the top of it, because what they were saying was.
It's at an
that
angle.
I'm not sure.
Well, now it's
Their
kind of
cases-
warped.
and
Wait,
initially,
hold on.
they were the same
Let's just see it
size,
close.
and then when we asked to resend it, they changed the size of the appliance.
But then it's going to make it
They were
warped
both
The other direction for our
4.5
audience.
6.5
here.
or something like that. They
Well,
changed the size
This
of
is
the
not
appliance,
on,
which I'm fine
is
with. I don't care.
Yeah, but nobody's watching it, well, except for, this and Dana back in the office.
Why did I say?
Tomorrow's the day.
Yeah, but we'll be down here real
Not to
early.
not to
tinkering.
give you any extra pressure
No
here.
sleep problems at all? No habits?
I like our high-tech devices.
Yeah.
It's very official stuff, isn't it?
It's just weird how.
Because it's different, it almost makes me want to adjust that and see what
I think
happens.
it's this, though. It's got to be the camera angle. Maybe if it was more straight in the middle here.
I was also thinking maybe we need a little tripod or something for that.
Well,
A little bit of a.
Now
Oh,
the
now
top
it's
cut off
now
again.
it's
So
Yeah.
that's what the
Straighter.
appliance should look like. Yeah, like you don't see anything.
There. That's
They're
better.
perfect.
No, it should be all right. You see
better.
this? These teeth fit in really
Yeah, I
nicely.
think it is better.
So,
At least
I-
you can see the whole
upward
slide.
they don't fit right now.
I think it was just this all along.
get you just a tiny bit closer with that.
And we don't want to fuss you with it.
It used to be sticking out on our lip.
Just want to have it correctly.
No, that's fine. Okay.
Right. Just for
It
to have it
won't
correctly.
correct it completely.
But
You can
easy
change
just
it
from a
over
habit,
just- Oh, yeah.
just from that.
Okay.
Because that tooth is erupted.
And you've got the clicker?
I got it.
Okay.
Thank you. So just, so you.
Yeah, so I would not do this.
Well, and I didn't strip your teeth shadows.
Yeah.
You gotta
Want me to
strip
stay
them.
here?
Because he didn't strip anything.
I couldn't go
I wait, don't strip anything.
No, I'm fine.
You said this?
Got some morale.
No,
And we
no,
took
no.
a perfect.
Does that bother you?
No,
And
no,
I
I don't.
never used cleats, I never stripped, and I
No,
got great
no, I
results.
know. Well,
But you don't agree with that, you think
stripping
strip.
allows the crowding to correct and it won't come back again. And you've got a perfect opportunity, especially if they're short, if they're not short spaced.
You can do whatever you want, but if you step out of the way, you see you're stepping out. You
I
can
had trouble
see
with Margaret.
how far you've got, and if you step over, it'll project on your
Not mine,
face.
you know,
Okay,
so-
no, okay.
Yeah, you feel like you're responsible for, I'm sure.
Well, you'll find little differences. That's the way he
Alright.
does it. Sometimes people do things differently than I do.
Well,
Maybe
he would
results.
still love the results, so.
But he might motivate kids more than other people. You know, who knows?
I want, yeah, see, because.
I know he doesn't use cleats, and I think
Okay, I've got a
sometimes
question.
are very important.
Yeah.
This is
This is the same case with, this is 3,000. But yeah, this is what her report was. I mean, this was really tipped out.
Oh, yeah.
And just for that.
See that appliance
And
caught
her
that
midlines
too.
look pretty good. It did. It caught it more.
Yeah, her midlines.
No. So you just do stripping and have
Don't worry, it's confusing.
I think sometimes I tend to try to make it more difficult than it is. Like, it's not, I mean, it's rocket science, but not really.
It's so easy. It's really easy.
I mean, are you dreading $8,000 getting
Yeah.
So you know what? It's so
These are very hard now.
I have to say,
No,
my
no,
we were
he's
in
in
Utah,
Texas.
so
And
mentioned.
he's
Oh,
the-
you're in
he's-
Utah.
He's the best orthodontist, but he's out of the and we're just known about the
So
surgery. She
it
will probably
is.
do it.
She
It is,
really
it is.
She's
She's
only
tried
12,
to take
and she's
it.
not gonna have to
There is a lot of
Oh, well, she has
responsibility
no
from the
intention.
doctor as well.
Well, she
I
has
don't
a
think
good
the
left.
parent
One
needs
of
to
her
really
MCs
know.
in there.
But I can just take care of that. But I bet you if I could have got her on these appliances, she would.
Maybe.
She just had
Follow it. If you were to turn around and have to do it on your own, you could. But you were.
But even that, but
really.
we're
Some
looking
people
at
have
it
a nice
$16,000
Oh,
for my younger kids.
Oh, seven different
I should get my dentist to strip. I don't think it's not gonna matter if they already have the appliances. I just think they strip, just regular strip.
Take a diamond fishing, run it through there. Take 2 millimeters off both sides.
It's
each
fine
side.
enough to say.
Only the measly,
Just
not
for
the
the models for different stages.
We used to
Do it a second, just to do a small
we used to sequentially strip that. It just saves
No,
it.
he just wanted it well. Well, if there's 7, but I'll tell you, it's not the habit corrector.
orthodontic group. That's where you got the idea from.
Because I started,
He's a big advocate of primary molar buildup. So I did the primary molar buildup. He did fusion.
but I see it
together.
as a role.
Oh, I see.
He did
Oh,
those
that was
things.
it.
So,
Yeah, that's good.
I'd
He
say
didn't do it on my daughter at all.
that,
Well, that's a good way.
yeah, if there's.
Will it matter
Only
that
in severe cases.
if he still has some of his primary molar built up, and he can just maximum points on those?
Then you build them up to 2
And the
Well-
teeth just over-corrected to make up for that.
Well, it will, but then if
So one
it's
little
really
girl said, "Well, we're gonna
something,
clear it and then everything and the
so
purple," and I'm like,
we have our
why
parts
did you
filled
go to
up
all
front.
those different?
So we're depressing.
She probably started with a habit corrector.
At the back,
Don't
you
know,
always
but the others
have
can't
like,
go.
I just wonder if it's gonna hurt his therapy.
Yeah, yeah.
I've got
Well, I have to say, one of their issues, they're
no, probably
is
speed up
with
the eruption of the tooth. If you speed it up, that build it up.
simplifying it. I think that's one of
We
the
did that on
problems.
European and round classes. Build up the baby.
It really, like, and so when I started doing this. I mean, it's true. It is, it's not really that simple. No. It really isn't.
As long as they wear it.
I shaped their mouth, they're gonna do it.
Right, you know, it's kind of like
That's
saying
the
you're
big
gonna
secret.
graduate from high school.
I took a film of a child one time from beginning to end, but I did it because of
Well,
her
you
mother.
see, you start with math,
I remember
then you
when
go to
Melissa-
algebra,
Right.
and then you go to geometry, and then you go to.
You know what, it is kind of simple, but to get through, like,
We took a film of her.
they were an hour before the dentist. They're like, you know what, we're just gonna tell them. That's why they're doing it.
That's what they're
say it. I didn't talk about the appliances.
Yeah, we will.
That appliance is in child.
So that.
You really should charge, check them every month for about 5 months. Because you have to make sure that they're running. You don't need to do that because you've got control. You can tell a child if they're running right. Oldest children are better than that.
So really, the only active appliance probably the
well, the adult appliance also. Anytime you have glasses,
well, I worry about that too. Because you just kind of develop your own style.
Yeah.
First say, promise that this thing is going to work, and then he has to go to the dentist, that if you look on later in life, you can't use it.
Right.
If they have pre-appliance, they never get to have, just like I was talking about.
Well, they actually do achieve.
Yes.
But it's not. I'm sure it was. It's easy. Now most of these. Well, that one's
yeah, it just. I would say
this
on
one
the
has
website,
deciduous laterals. All four permanent lowers are in. So he wore a T-series.
not like in 12 months, because it depends on it depends on how compliant.
Oh, those are the
Yeah, what are they starting with? How old are they?
So I would really even on not starting until they're 8 and 10 by getting them really active with their children so that it could result.
Oh, yeah. Perfect. But you'll find, as a German rule, the earlier ones.
You don't want to, like,
Oh, it's painful. I mean, I think I've been doing it long enough to be.
Or for 6 problems.
I mean, I'm still not good at it. It's just.
Mic up, girl.
This will help. I didn't have this book until just now. You're not to get it. So I'm guessing this is every question I have in it already.
Well, it goes through everything.
Should I put this?
Last one, it was a stick. We put them on both pages.
Yeah, smart. That's really smart.
We didn't have a double. Now we got them putting on both sides. I think Kim goes to that. Nice job.
No. I would do it myself.
Kathie's she's been in media.
I think it's fine.
Oh, I know.
I want to see what's going on.
You hear it?
And if I can't do it anymore, we got other people on it.
Do you know why you like science so much?
What's your name?
Is it one where I'll be instructor?
Nice to meet you, doctor.
He lost his eyesight his entire life. He's still having to look at him if I have cases. He wants me to have
You interested in looking at cases? How old is he?
She's just one of them. That probably needs to see his but he's still sharp as that. Just a sight. Yeah. Thank you so much.
I'm going to go to the back.
Yes, I'm so sorry. I bet she is. She's gone all week.
Say hello, doctor, so we can see.
Hello? Hello? Okay.
One more time.
Hello?
Yeah.
Is that good?
Yeah.
Okay.
Can we hear the doctor? Good. That's good. We want to hear the doctor.
Should we get started?
Yes.
Okay. Well, good afternoon, everyone. This is going to be a little bit kind of real life. My name is Dr. Mandanis. I'm a dentist from Anchorage, Alaska, and I've been using the appliances for about 4.5, 5 years now. So I'm just going to kind of
Can you interrupt 1 second?
Yes?
The doctor's gonna stay with you.
Okay.
And Ms. Hygienist doctor. And the staff is coming up here. Okay, so we've got a little meeting, enclave out in the center here. So, we got 2 doctors, hygienist doctor, we're gonna stay here.
Okay.
Okay?
Cool.
I'd like to point out that I'm only a hygienist doctor because I took this presentation and did the breakout session already. So I want to see what my doctor missed. Is all.
Okay.
I'm not really that hygienist.
Yeah. So the rest of y'all, now you need to grab, we got how many chairs out there? 2 or 3 chairs?
We probably have 4 chairs, so maybe.
Oh, Bob and I'll grab the chairs. Just go on the floor.
Come here and
Yeah, you might want to actually come. They're going to show you how to do everything they can do already. Yeah, it really bugs me.
George, you want to take one of these chairs?
And we'll,
He's teasing. Yeah, I'm just a hygienist. Yeah, no. Oh, yeah, we have this new thing now. No. Just kidding.
So you are a doctor?
No,
You're a
I'm
hygienist?
Yeah.
Oh, you're so into it. It's awesome. Hygienist, doctor, right? All right, well, so I practice in Anchorage, and I've been using the appliance for 4.5 years. And you guys know about the appliance. It straightens teeth without braces. It's a family of a bunch of different appliances. Have either of you, anyone used it? No? No one's used it yet. Okay, and it straightens teeth in children as young as 5 and now even as young as 2. And really, it allows the patient to enjoy everyday activities without the discomfort of wires and bands.
Can I ask a quick question?
Yeah.
How did you become introduced to it?
Yeah, I'm going to explain that in a little bit. No, that's fine. So I'm going to talk today about the Occlusa Guide, or the G series, or the preteen habit corrector. So it's been given the Healthy Start preteen is these 2 appliances. And here's the appliances in the mouth. And there's about 13 different sizes for every series. So just to give you my journey with the whole appliance, is I was a dentist for 15 years. I went to Northwestern class of 2000, and my first job out of dental school was in Nome, Alaska. So Nome, Alaska is the middle of nowhere. It's about 1,000 miles, maybe 800 miles as the crow flies from Anchorage. And being so rural, I did a lot of ortho. And so there was an orthodontist, Dr. Michael Beck from New Mexico, and he'd come up 3 times a year and make sure we were on the right track with our patients. So do any of you do any ortho at all? Yeah, so you do a lot of band and brackets?
I do more clear corrects and Invisalign.
Oh, okay. So I did all band and bracket. I didn't even know what I was doing. I talk about that in a minute. But I have a small practice in Anchorage now, and I do a lot of sleep dentistry for adults. And I was doing the orthotain, and I started both about the same time. And what happened to me is, all along I thought there's just some kind of connection. I know that there's a connection here. I'm not sure what it is, but I'd have adult patients with really crooked teeth, and then I'd see their little children, and I'm like, gosh, I know I can prevent some of this stuff from happening. So just to give you a gauge, I went to Northwestern, which is right here in Chicago, and here's Nome, like right there. And Anchorage is right about here. And so here's Anchorage, and then there's Nome. So you can't even drive to Nome. You have to pretty much fly or take a dog sled or snow.
Can you see Russia from Nome?
You can see, not from Nome, but I actually went to St. Lawrence Island, and there's a little island here, Diomede, that's about 3 miles from Big Diomede, and Little Diomede's U.S. and Big Diomede's Russia. So, and a lot of we went to a lot of rural. I just put this up for fun because I'm in Texas. It's in, and this is it's a right. Anyway, and this is just one of our village trips. We take small planes out to small villages. That was my team. And these are what the villages look like, maybe 300, 400 people in villages. Our biggest village is like 500 people. If you ever get a chance to do anything, it's super fun. And we bring our equipment. But anyway, so I want to talk about orthodontic education in general. We didn't get much. It's just very, very minimal. And a lot of dentists, because of Invisalign and 6-month smiles, are doing orthodontics now, which I think is good. And short-term ortho is definitely the trend, and I think orthotain, this whole perfect healthy start just really belongs in the armamentarium of stuff that we can do. I really believe it's changed my life and how I view dentistry. So I would say orthodontic education was pretty ugly. We didn't do anything. That was me being ugly and 12 years old. And I think, in dental school, I don't remember learning any ortho. Is that pretty accurate? Yeah. I don't remember changing any bands. I think I went to 2 rotations where I watched the resident do her ortho, and I just remember the only way we passed our classes was by having old tests. I didn't learn anything except class 1, class 2, class 3. That was ortho, and I think this has just been pretty amazing learning all about Healthy Start. and there's plenty of room for more than band and brackets and orthodontics, and this has just been a huge deal. We've been talking all weekend about orthodontics and just what we learned and what orthodontists learned, and you just have to keep an open mind, and there's a lot of different stuff that's happening that's not wires. So this was my own son and my first go with orthotane. I had actually learned about orthotane from the orthodontist that comes up to Nome, Dr. Beck, but it didn't really work because none of our patients were that compliant, and there definitely has to be some compliance. We wouldn't really see them very often, maybe once a year, so we never really got to follow up on a lot of the patients. So this was my son when he was 7, and obviously he's in crossbite, and I don't know if you guys have children, but I looked in his mouth and I was like, wow, what's going on here? You can't have this. So I got the appliance for him, and that's him with the appliance in, and it did not take, it was really not a week of him sleeping in it and wearing it a little bit before he got out of crossbite. So I just knew, even in Nome, we would tell people to use tongue depressors to move their incisors forward, and that worked, so I knew this appliance was going to work. So that's my boy, and these are just a few of my patients. This is Melissa. She was already 11 at this point, so she had all her permanent teeth in. I think she was in the N appliance, but this was December and this was June, and this is 7-month comparison. I wasn't taking great pictures at the time. And this is her brother Max, who this was December, and then this was June. And both the families, they're an interesting family because we were talking about what we tell families and parents, because definitely his father, their parents came in and were like, we went to orthodontist, it's going to cost us, $8,000 for ortho, and they think that the orthodontist is trying to rip them off, and you never want to say, no, they just don't know about the appliance. So they're the perfect case that neither of these children really should be in 8. Oops.
It might be the base of it.
Is it?
It seems like,
How about this?
I think that might have something to do with Bob. The connection in her pocket, she's twisting.
Okay. Well, well, I just don't think that children like these two kids should be in $8,000 orthodontics. I mean, we could completely avoid that. Really simple. So that's them. They actually ended up on my brochure for my office, both of these kids. So in general, as a general dentist, we just say things because that's what we've learned. And we don't really know why we say them anymore. We've just been saying them year after year. And and we just tell them to our patients who we really care about. And I just think it's just kind of really interesting psychology, because we believe it because our professor or somebody said it, but we don't really know where we get our knowledge. So what we've always said is your child will probably need braces, but we can't tell until his or her permanent teeth come in. Or we say, let's wait until all the teeth come in, or she might grow out of it when we're referring to a crossbite, we can't tell. And so let's just wait. And this is my new conversation. The earlier the better. Let's get her started as soon as possible. This is unlikely to improve without intervention. When referring to crossbites, overbite, and overjet, and we can prevent further problems, and let's do it now. Like, what are we waiting for? Let's just do it now. And why has my conversation changed? Well, the more you look at it, and the more I've even researched it, crossbites don't correct on their own, and we can treat a crossbite on a 3-year-old. Deep bites, overbites are the cause of or related TMJ problems, and 70% of TMJ problems have excessive overbite. And over 75% of 14-year-olds have overbites greater than 3 millimeters, and almost 70% have overjets greater than 3 millimeters. And research has shown that there is very little change anterior posteriorly in the relationship with teeth once they erupt into the mouth. And in fact, 76% of class 2 relations formed once teeth erupt into the mouth either stay the same or get worse as the child grows into adulthood. And overbite also doesn't change from 7 to 18 years of age. And I got all of this information from Dr. Bergerson, your videos, that I might be the only person that's watched them like 2 or 3 times. So But it's really interesting because I think, when did you originally make those videos? In the 70s or 80s?
Long time ago.
Yeah, you know, it's what I think is really interesting as a dentist, as a provider, is so I started doing research, and Dr. Ferguson's information was at least from the 80s, if not the 70s, 60s. So I just started going through the internet, combing for more things, and there's just all kinds of articles. One in 97, they took 25 untreated class 2 subjects and monitored them. They stayed the same. Class 2s aren't changing. In 2004, 17 subjects, class 2s aren't changing. It seems like we keep repeating research that's already been done, and research just keeps getting buried somewhere, and we just have to make sure that Dr. Ferguson was right 30 years ago. But this information just gets lost. And here there was a 5-year longitudinal study in Brazil, and children with previous malocclusion presented a greater risk of developing malocclusion in the early mixed dentition, and individuals with posterior crossbite and greater overjet in the primary dentition are more prone to maintain the same characteristics in the early mixed dentition. So it was even further observed that the prevalence of posterior crossbite increased in the transition from primary to mixed dentition. So there's just articles all over that are being repeated, and people are doing studies, and I think they've just been around for 40, 50 years already, but we just keep having to prove. I'm not sure why. And so the moral of the story is just, what are we waiting for? Let's just not wait anymore. And it's really exciting because you get parents that they've gone to the orthodontist, and then they finally find you, and they're like, I knew it. I mean, I know we can do something. I knew it. Like, I don't want my kid to look like this. And so why are we waiting? You know, I think we're waiting. I also scoured the internet for orthodontic websites and what they say, like what time. It's super controversial. I don't know why it's super controversial, but there's even NPR, you know, shows on why is there early intervention, is that necessary? And it's just really interesting that there's just so much controversy about this. But I think that we're waiting because Prophet, who wrote all our books, said we could wait. Our professor said we could wait. Our orthodontist friends that we're friends with, they say to wait. So we just believe all that. And we're also waiting because of costs. So there's like phase 1, phase 2 orthodontics, sometimes phase 3. And orthodontists say, let's just wait because we don't want you to have that first phase to go through that. And I think that's nice and fair of them, for them to want to save their patients money, but really Healthy Start, it's just a game changer. You might not need a second and third phase if you start young. So, and orthodontic prevention, I mean, I just think as a profession, it's just crazy. This is something that we should be taught, like from day one of orthodontics, that we could do this. And I'm really here today because I'm kind of really obsessed with the orthotain appliance. So I want to put every kid in it. I mean, imagine I went through 3 years of ortho, and I would have definitely worn this thing. And I was like the 11, 12-year-old that never brushed her teeth. So I was just gross. It was just, you know, when you see patients like that, the population I worked with in rural Alaska, I was actually extracting teeth on kids that had ortho because it would just get that bad. I mean, to not have, 12-year-olds, 13-year-olds in wires, they're not all good. So, and I am just going to predict that if the 3 of you have not used the appliance, that you will, and you're going to change some kid's life. You're going to straighten out their teeth after this with no wires. I mean, it's pretty amazing. Prevention, a new way of treating malocclusion with Healthy Start. We guide teeth in as they erupt, and this is straight from Dr. Ferguson. There's 2 ways of doing it. Wait until the teeth come out of the gum tissue, go into malocclusion, and then let the fibers form, and then we straighten them. And then earlier intervention and straighten the teeth as they erupt, and the fibers become our friends. So I'm just going to talk about the PDL for a little bit. Its functions are supportive, remodeling, sensory, and nutritive, and the support is what we're really going to focus on. I mean, these fibers are everywhere, and they don't want to be displaced. And they're not going to fully form until the teeth are actually functioning. So as they come out, these aren't going to set until they're being used. So we can guide them in the appliance, and that's just incredible. So orthodontic relapse, if you look, just like you said that, I think at University of Washington says we're just being in retention the whole time. And a lot of my patients, I do 6-month smiles, I do short-term ortho, and a lot of my patients are retreats. I have a woman now, she's in her 40s, 3 times in ortho, and then she found the orthotane, and she's just so excited. And it's just like, she's like, I'm never going into ortho again, and she just wears it all the time. So it's just really interesting, I think, as a profession to look at the controversies with orthodontic relapse. And there's a lot of issues, and there's no one can agree on anything. So there's the tongue versus your lips and cheek, moving things, moving your teeth after ortho's done, third molar eruptions, moving the teeth mesially, post-treatment skeletal growth, PDL fibers twisting back to their original position. There's literally articles where they just kind of say, well, what's the cause? And we're trying to figure this out, and how do we prevent this? And just more facts about the PDL, it's 3 to 4 times thicker in function than a non-functioning teeth. I have taken out a lot of teeth, and even with third molars, I just love taking out undeveloped third molars because they're so easy. And once again, the fibers are only completely formed once they're under occlusal forces. So it's just a lot easier to take them out when the fibers are formed. So I'm just not making you read this, but this is just some more controversy about what causes relapse. And there's another article about retention is a difficult challenge. Everything's like retention's hard. My whole point is I don't really care why it's hard and why things relapse if we can prevent them from happening. I don't care if it's the collagenous fibers, the elastic fibers, or the bone. If we can prevent them from coming in crooked to begin with, then let's just do that. And who cares what the real reason for relapse is? And we were talking about this, you mentioned this earlier. I used to do this all the time in Nome, usually like with 1 or 2 teeth. But if we can ever prevent from someone having the periosteal fibrotomy, it's really easy to do, but do you want your child to go through this? No parent wants their child to have to go through this. And no child wants to go through this. So, and retainers are forever. That's what we're saying now. Especially, it's just the rest of your life. And that's for sure with adult short-term orthodontics. It's forever. And you really want this retainer there for 30, 40 years. I don't know how many patients I have that are like in their 40s now, and they're like, can I take this out? And I'm like, I don't know. If I take it out, it might relapse, and then they're just all nervous to take it out. And that's a really big issue. If we can prevent adults from having this for the rest of their life. So anyway, this is the occlusal guide, or the healthy start for preteens, and it's part activator, part positioner, and combined biting force. So 3 appliances in one. And so how does it work? It guides teeth in, because teeth are prearranged in ideal position. There's 1 appliance for the upper and lower jaw. Has anyone had a chance to look at the appliances? Pretty good. And then the patient actively bites into it or functions on it because it's rubbery, so it's not a passive appliance. And the patient exercises with all his biting force, 40 to 60 pounds of biting force. And it can correct crowding. This is actually not the preteen appliance, this was an adult appliance. This woman is my patient, she's in her 40s, and this is orthodontic relapse once again. And this was honestly 2 months later. She was just crazy biting into it. She's like, I want this straight. And then what was happening is everybody goes camping in Alaska, and they go to their camp or they go to their cabin. And then she didn't have it for a while, and it relapsed. And really, she goes, well, what do I do now? It like went back, and I said, you really just wear it for forever. And you just kind of, I can make you a retainer if you want, but you can either care or not care. Like, let's just say you want your teeth straight, then you put the appliance back in. And if you don't wear it for a while and then your daughter's getting married, then put it back in. Or I can make you a retainer. So it's just really whatever they want. But they have control over that, and I think that's just really cool. They don't have to go back. I said, if you lose it, I have your size in the chart, and just call me and we'll get you a new one. I mean, how amazing is that? No wires. 2 months. It's just incredible. So how it works with overbite. Okay, so with overbite, this was a 12-year-old 9 months later, and then 18 months later. And so how it works with overbite is you're only biting on the front teeth. So it actually stops eruption of those front teeth. And it, since there's no teeth on the back, it kind of allows for the super eruption of the posterior teeth, which just opens up the front of your teeth here. It discludes the posterior teeth so that they super erupt. So it stops the eruption of the incisors and encourages the eruption of the posteriors. So this is my patient Bradley, and like Dr. Bergerson's grandson, my children also play hockey, so a lot of my patients are hockey players, which is great. So Bradley, his whole family's like this. His dad's like, we all look like that when we were little. This is what we all look like. So you can see, you can't see his bottom incisors on the picture up there. And that was October, and this was May. He just wore it to hockey practice, and he wore it to bed. And, you know, a couple, maybe 2 hours a day, maybe not even. So, and there's just a side-by-side comparison. And it's really interesting because I started using this appliance 4.5 years ago before I thought of any other health issues, and it was all just orthodontic issues for me. And when I go back and look at pictures, or I talk to families about kids' behavior or their growth, a lot of the pictures, even though it's 7 months, like the kids just look more mature to me, more than they may have looked. I mean, that's the problem with prevention. You don't know what they were going to look like if you didn't prevent it. But when I look back at a lot of my patients, the maturity level from just after 6 months, they just look like completely different kids. And so for overjet, how it works is it advances the mandible, and it restricts the growth of the maxilla again. So the appliance, if you have 12 millimeter overjet, it's going to bring your lower jaw forward. And when your kid, if you get them at the right growth, their whole jaw is just going to grow to that position. It's very amazing. So the appliance restricts maxillary growth by the biting force, and then it just brings the mandible forward, erupting teeth into a good class 1 position. And we just hold it there while they're sleeping, and they just grow. If you catch them with a growth spurt, then their jaw just catches up to where you've artificially put their lower jaw. It's amazing. So, you know, this is the one question, Dr. Bergerson, that I get from other orthodontists is there really orthopedic growth of the lower jaw? And, you know, I haven't done enough research, but nobody wants to believe there's orthopedic growth of the lower jaw. Do you have any comments?
Yeah.
Yeah.
The growth comes. In that case, I don't know if it was 80% of that change, and there's a very small overjet. 80% of it was orthopedic. Very little was tooth movement.
Yeah. I mean, that's what you know what, I didn't have the luxury of having a Ceph, and I really need a Ceph, and I really want to buy one, but they're just like, no one wants to believe me, and I don't have Cephs to say, well, here's the before and after, so it would be pretty good to get a Ceph, I think. So this is just the combination, how it works, crowding, overjet, and overbite. So the best time to treat is early, between 5 and 11 in time with tooth eruption. The best time to treat later is during the pubertal spurts. And you have them sleep in it every night because you just don't know when a kid's going to have their pubertal spurt. And sometimes if you see them like every 2 or 3 months, it doesn't look like anything happens, and then all of a sudden you see them and you're like, whoa, like everything just happened. So this is a case with crowding, overjet, and overbite. There's not that many cases that are just crowding or just overjet or just overbite. So he had his first stage treatment for 10 months at another orthodontist. This is one of Dr. Ferguson's cases. And the only progress was to close some spaces and decalcify some teeth. And I think we've all seen decalcified teeth. And the G series was used for 6 to 8 months. And here's an appropriate case with crowding, overbite, overjet. And I don't know, this is in Dr. Ferguson's video, but sometimes patients just can't believe you and they just want braces. Like, I just don't understand that either. But they just don't believe their child is going to wear the appliance and they just want braces. So if we could avoid all of this hardware, wouldn't that just be lovely? I mean, this is just a mess. And for a 12-year-old, it's just worse. I mean, who's brushing this 12-year-old's teeth? So this was this was after the orthodontic case. And look at the gingiva. I mean, we've all seen it. And here's a similar case wearing the occlusal guide. And this patient was only seen for 4 months with the same result. So, and just a lot more cases. I thought I had one of my cases in here. I don't see it. Anyway, just over and over again, to be able to correct crowding, overjet, overbite, all with one appliance, it's pretty amazing. And here's some more cases. Oh, so this is one of my patients. And Dr. Ferguson is right. We really, I'd say one of my big issues, and as a provider, that you're really going to face is that 3-month mark of not seeing progress, because you just want it to work so bad. And personally, I have a really hard emotional time letting go of patients. So this young girl, like it probably took me a while to see any progress with her. And she'd come in with a broken arm, and like I didn't really wear it. And the second month was like, oh, there was some other reason why she wasn't really wearing it. And this was one of my first cases. It was in 2012, and I just was like, God, maybe the ortho-tape doesn't really work. I don't really know. I'm really frustrated. And by March, she just wouldn't take the thing out of her mouth. I mean, she wore it all the time. And her grandmother, I think that this was one of my first cases that I probably charged her grandmother like $1,000 because I was just really not sure. And she just, the grandmother was like, she's never getting braces. We know we can't afford braces. So maybe it was $1,500 I charged them. And this girl was so cute, and I wish didn't have permission to use her full face, so I didn't have it. But you should see how she matured as well. But she definitely, everything straightened out, and that was, did I start August till March? I did give her a little bit longer than 3 months. I gave her a long time, and I was like, I know you can do it. And that's part of the whole compliance issue, is really having someone in the office that can be the cheerleader. It's really what you need. So the indications for the Healthy Start preteen is crowding up to 4 millimeters, overbite of any severity, overjet with any severity, spaces up to 5 millimeters, and TMJ dysfunction. You could treat 80% of 8 to 12-year-olds and 40% of the population. And the ideal time to start is really at, it's 6, 7 years old, or as the lower permanent canine or first bicuspid begins eruption. When all this stuff is happening at once, you see a lot of the biggest changes, like all at once. So what to look for at the first exam: crowding, lower arch 4 millimeters or less, crowding upper arch 4 millimeters or less. And I think that Dr. Ferguson will always say this every time I see him lecture. He has these parameters, but then somebody always has greater parameters of correcting things that he would never say you could correct. So it's always worth just trying it on certain patients. So, overjets of 3 millimeters or more, and the TMJ problems, clicking. deviated opening. We talked about that. So here's just a few more cases. And then you really need to ask parents what their major reason for the appointment is. And I really do have to say, you have to really select your cases, because one of my biggest frustrations as a provider is just having families fight with each other, like the child and the mother wants it for the child, but the child doesn't want to wear it. So you really have to be choosy and just make sure everyone's on board. Like I have those situations a handful of times, and you just get a couple of those cases, and then you realize, okay, I don't want to go through this again, and you get more firm about what cases you select. I'd say, and it's not across the board, but like if you have divorced parents and the child's in one place and not in another place, boy, that is super difficult, because most of the time the father has no idea what's going on and doesn't want to believe the mom because they're going through a divorce, and so she's really into it, but then there's no consistency there. So you really have to be, if the mother really wants to do it, then you really have to have both parents come in and have a really big conversation about it. Because if you don't get belief from one parent, it's just really probably not going to happen if the kid's not with that one person all the time. So if just ask the parent what they want. If it's a sleep issue, you can start with the sleep description, and if it's a straightening teeth, start out with the other description in advance of the preteen appliance. It's really interesting, and it just depends kind of like on the high school or the middle school that the patients are at. Like I have some patients that do not ever want to be in braces, and I have some patients that are so peer pressured into getting braces because their friends have braces. So you don't want to start with those kids either, because they just are dying to have wires for some reason, and then they fight with their moms, and I have specific cases like that, so you have to really pick and choose. So, but this whole relapse thing, like I said, I think this is just kind of the icing on the cake for the ortho team. I mean, there's just no arguing. I don't even care, like I said, what the reason for the relapse is. And God knows that like all these orthodontic residents are writing papers on why there's relapse and what are the causes and what we can do. Like who cares if we can get you to not ever have that problem. So less relapse. All I could say is, when was this, Dr. Burgers, in 91? Yeah, so. And then faster treatment than braces, 5 times faster than braces. I have to say, one of the confusions for me was like, how long is this kid in, like we say it's a year treatment time, but I really have, like if I started them at 7, right off the bat I tell the family they're just going to sleep in the appliance. I have them sleep in it till they are, if everything's straight, and I just have them sleep in it till all their permanent teeth come in. So that way they don't not sleep in it, or maybe they're not sleeping in it every night. So anyway, early treatment, less relapse, more erupting teeth, less relapse. Start ideally with 16 erupting teeth. So orthodontic insurance is really horrible. So for my area, most patients have about $1,000 to $2,000 of lifetime max on orthodontic insurance. My fee is $3,000 right now, but you can charge whatever you want. My fee is about 1/3 of the average fee in Anchorage. So people charge, I think in your clinic, they're going to charge $37.50. Is that correct? So that means I have to raise my fee? No, I don't know. I just kind of really want to make it affordable so I can get as many people as in this appliance as I can.
How much is the cost for us to order the appliance?
You know what? I think with the whole set, it's about $600 or $700. Yeah.
If it's 2 appliances, it's 600. If it's 700.
Is that right?
That's what
yeah.
unless it's changed. I think that's correct.
Yeah, you know what, with that, because I started before they packaged the thing, So, but that comes with all your diagnostics, and that comes with if they're going to do anything like put in bumpers or any of that stuff, it includes all of that.
Unless they have to put in some.
Yeah, it includes all that,
Oh,
right?
actually, it doesn't
It
actually.
does not?
Yeah.
Oh, but at least they'll do it for you and
Yes.
tell you how to do it.
Yeah.
So anyway, ortho insurance, if you guys don't have to really deal with that because you're not, are you in private practice? You know what, it's really a big pain. So I'll tell you, there's no consistency. I take down 1/3 of my fee, which to get started, which is I take photos and study miles, and I just take 1/3 of the fee. And then I deliver the appliance, and then I want the $1,000. And then usually insurance will cover $2,000. And then every company's different. So if you have questions, you know what, you just have to keep on it. So anyway, that's what I do. Anyone can do it differently. So the problems with Healthy Start is you have to be cooperative. If you're not wearing it, if it's sitting on the counter, it's not working. And you have to really wear it. But I have to say, like if you ever, I sleep in one because I have some jaw issues and I clench. Oh yeah. So I clench and I just love sleeping in mine. And you get like sort of this pacification. And little kids, even when you start with 3-year-olds, and what's the difference between that and a pacifier? Nothing really, so they really adapt to it. But even 7-year-olds and 8-year-olds and hyperactive kids, it almost gives them something to focus on, and they could just have this thing in their mouth. And it's sort of nurturing and soothing, I think, for some of the kids. So it really does require a lot of cooperation. And I think this cheerleading thing, this will work in some practices and it won't work in other practices depending on how patient the staff, or if you can find someone that's patient. And the more I know, now that I have some more, like I've had cases that I didn't know were ADD, ADHD type cases, and I just did their ortho, and then I look back and go, gosh, you know, that kid was really crazy hyper, and then I'll go back and talk to their parents and they'll be like, yeah, they're a lot more calm. I never knew to attribute it to some of this, whereas now it's just super exciting that you can do that. And what I do in my office is I have a bunch of Beanie Babies, and if they fill out their chart and it's really good, you get to pick a Beanie Baby. So, and then you want to measure the overbite, and you can do that however you want to do it. I just take a periodic probe and I kind of write that down every time. And I always have the patient's cast, and so you can bring it out every appointment and then show it to the patient. They get excited about seeing their own teeth anyway. And when there's a lot of movement, they get really excited about seeing their old cast. And you know, just like ortho, they're like, wow, I used to look like that. So you just really want to write down your progress. And just ways to measure overjet. That's the little appliances. You get this at an art store to measure. And you get about, 0.75 millimeters a month of overjet correction. And this is really hard to terminate in 3 months. I haven't figured that out really well yet, truthfully, because I just wanted to work so bad. And sometimes, it's very unsuccessful, and sometimes, it takes the 6-month come to Jesus moment for this family, to get past the hurdle of actually doing it. That's another reason why I think I've kept my fee where I have, because if it doesn't work, you just don't feel good. But when it works, you should have charged twice as much. So, and then just prepare the parent for the habit corrector. It's the first appliance used. It's a lot softer, so it does a lot of good just having the habit corrector. And when you take a good look at it, there's a little shelf for even a 7, 8-year-old to practice putting their tongue in that position. And I think that was when I started using the appliance 4 or 5 years ago. I wasn't that well versed in the habit corrector, but I see where its use is just immense at this point. So, and the G series it's really rubbery and hard, and a lot of people that have ADHD, they also have sensory issues, and that G series appliance is just so hard for some people to transition from the habit corrector to, there's also an IG series that's softer, and then into the G series. it helps a lot of these kids. And then as far as talking to the patient, no stress, no braces, no one knows they're getting their teeth straightened, shorter treatment time, little pain, discomfort lasts only for about 3 days if they're wearing it. So you know if they're not wearing it because they say it always hurts. Well, that means they didn't give it a good 3 days. So I always have them ride through the first 3 days and and once again, stop treatment and say that you're probably going to go into braces. And it is really, Leslie was talking about it, when you're talking to little kids, and I do this with my patients, we mentioned it at lunch, like you want to either get to their level or below their level, and just let them know that you're not someone trying to make them do something, that you're on their team. And I like to separate from the family, like separate the child from the family and talk to them separately, at least at a certain point, because they just kind of say things differently in front of their parents. And then it's just the same. These are the records that you need to take. And once again, cooperation. And then when you first put them in the appliance, they might just wear it for a half hour in the beginning and just slowly transition. But it's really important to have them fill out that chart. And you can tell in that chart when they're cheating and lied about it. And I just tell them, like, don't lie on your chart, because I can tell and it's not helping anybody. And you just make a really big deal about how they filled out that chart if it was filled out really well. See, I don't know if anyone lied on this chart, but these all look super good. I would rather the chart look like honest and they weren't really wearing it than, you know, they kind of lie sometimes. Kids are really good at that. So. And then once again, when you're inserting it, sometimes there's just gingival impingement, and you could just take it out with a burr. But there's a special kind of burr you have to use. I mean, you can buy it. I can't remember. What is the burr, Dr. Berger said?
Acrylic.
Yeah.
Flame shape.
So.
Sharp.
Really sharp. And I don't really get that much. Usually I don't really have to adjust too many appliances, every now and then. And it's really nice to have casts. Well, Dr. Bergerson's just going to go ahead and size it for you. But if you're trying to figure out sizes, if you have the models, you can put on the model, and it's pretty accurate. Yeah, and you can see some blanching. You could just relieve that if there's some blanching on tissues. But once they have been wearing the habit corrector for a while, you kind of don't see that too much. And I just, when they're wearing the appliance, there's an upside and a downside. There's a little guidebook that comes with the appliance that has a chart on it. I sit there and read that with my patients so they know exactly. You just don't want to leave anything out. Or I have my assistant read it with them. But you want to go through it really clearly with them and their parents. This just kind of says the same thing. So once again, you can wear it for like a half hour the first day, an hour the second day. But some people, they just take to it right away. Anyway, keep it away from your dog, and all of this is in that little brochure. So I always kind of, before they leave, make sure that they keep it in one place consistently. Some patients won't, it'll just fall out of their mouth every day for 2 or 3 weeks, and then you just tell them as your teeth get straighter, it will stay in better. But that's what's really great about the habit corrector is there's less problems when you start out with the habit corrector than when you go straight into the appliance. So. And then I have my appointment schedule just a little bit different. I see them in a month, but it really depends on the patient. Sometimes you can tell you want to check up in 1 week, and just depends on what the kid's personality is like, is when I'm going to see them. So, and I always call them I usually reschedule in a month, but I call them in about a week or 2 and see how it's going. And now with texting, I text kids all the time, and I say, are you wearing your appliance? And they'll just like text me back, and they're like, oh no, sorry, I'm doing it. And one of the really cool things is also you get texts from parents. Like I had a patient who was in crossbite, and I just kept promising them that 8 or 9 was going to cross, and they were on vacation when it happened. And then you get a text from the mom, like, always so excited, his tooth crossed over, and then she sends you a picture. And it's just really rewarding and fun when you have that kind of relationship with your patients. So anyway, this is just a good thing to follow. And obviously it doesn't always work with your schedule. And you can have your assistant do a lot of this. So it's really, really important to get your assistant on board so you don't have to do most of this. But then you come in there at the last second and go, oh, it's amazing. Or your assistant will be like, hey, you got to see Oli. Look at the progress he made. And you just go in there and get super happy. That's kind of what happens. I always see all my patients at every visit, but just for a little bit of encouragement. And if there's good changes and you get all excited and you take your camera out and you're like, oh, I got to record this. It's so good. And the chair time, it's just, these are just averages. But compared to maybe even Invisalign, I don't do Invisalign, but I know that's pretty time consuming. Is it?
Yeah, it's not. I mean, compliance is one thing, and then they send us the trays. I always have to order extra trays. So
Yeah.
I've been learning my experience to tell them for extra trays, you might have to charge a little bit more towards the end. Because
Yeah.
every case is like, always towards the end, we have to order extra trays. It doesn't go by their
Their
clin
guide,
check,
yeah.
the clin check, and the results do not match most of the time.
Huh.
So
And
they do work towards the end, the results are good, but because there is always a difference bias between the compliance and the scheduling
Right.
and their cooperation.
well, I still do a lot of band and bracket ortho, and it's good that you have Invisalign, because I have to say there's just going to be times it doesn't work and the families put down $1,000 or $1,500 by that point. And since I do ortho, I just say, okay, and I roll that fee into my ortho fee, which is nice. And it's nice to say, well, if it's not, I don't really like to tell them that I can roll it over, but I just, but I end up rolling it over if I just have zero compliance and I want to do the ortho. But there's a lot of cases where the ortho team is just so much better than ortho that I'm just like, really, like, just use this thing. Because to correct your overbite is not going to be easy. So, but it's going to be really easy if you sleep in this thing for like 6 months. So. And then here's the chair time. And I still do like a lot of band and bracket ortho. If someone has like a lingualized 7 this is not going to work on because it's just blocked out. But I end almost, and I do 6-month smiles, and I almost try to end all of my cases with the ortho team. I didn't used to at first, but I'm like, you know what, if we're going to do this, and you never get perfection with short-term ortho, you just aren't going to get perfection. But you can almost really get it doing 6-9 month ortho and then putting it in the ortho team. And really, they say they don't want braces, but they really, they don't want it for like 2-year orthodontics. But most people really want it to be perfect. But chair time, you can't do short-term ortho and have it be perfect. And I would imagine that's probably your problem with Invisalign, is you want it to be better than the results that you're getting. Because I think women are like that. We just are like, oh, it could just be better. So, at every appointment you want to check their TMJ, check if incisor crowding is correcting, measure overbite and overjet. And what I found is lower incisor, like they're wearing it if their lower incisors are corrected. Almost all the time. And I think this is just some of the same. And once the crowding is and everything's corrected, they can just wear this thing as the retainer. Although some kids, I just make them an Essex because they don't want to wear it. And or they just, I have kids with certain issues and they're just like, you know what, I just want a retainer. And sometimes I'll bond a retainer on, or I'll just give them an Essex, because some kids just don't like the big appliance in their mouth, but some kids are just fine with it. And what I've learned to do is get them all psyched up about liking it, so I don't have to give them another kind of retainer. But there's just kind of like, you just gotta talk people into it, and there's just different ways to have that conversation. Because I don't really want to make them an Essex. I just want to be done and have them in this thing for the rest of their life. So anyway, there's just more treatment examples. That's pretty much all I have. There's just more cases, and I think you guys are seeing probably enough now. So, are there any questions?
Yeah, can you walk us through, like, so right now, I mean, we got through all those materials until we actually see them Saturday clinic, but just to, can you also walk us through, okay, we saw some appliances over there, so should I, like, say for example, if a kid starts at age of 2 years, and so will this be appliance be used until the age of teens? Are they going to keep wearing different stage appliances?
You know what, that's where I'm at with it. I mean, I pretty much, and you could do it however differently you want to. I have not started anyone as young as 2. The youngest I've ever started is 5. And I just tell them I'm going through this. I mean, I think the fee structuring is different for every office, because you can't, like, lots of times you have to put them in some kind of expander if this isn't working. So I charge $3,000, but I say if I'm having some kind of other expander that I need another lab to use, I'll charge them for that lab fee. But you can't always tell, but you have to be pretty upfront with all that stuff. So I haven't started a 2-year-old yet, which I think I'm probably going to, but I haven't figured out how I'm going to structure that as far as the fee and then following them till they're 13 years old. Honestly, I'm not really sure how to deal with that. So, but with a 5, 6, 7-year-old, I do. Right now, I've said I'm just following you till you're 12, and I'll put them in the second appliance. I don't know how you dealt with that, Dr. Burst. And if you start someone with the night guide, like, and you put them on the occlusive guide, is that basically been a flat fee for you, or?
I usually would treat about a half of an orthodontic fee, something of that order. If it involves some kind of brackets at the end, I would charge close more for that. I could predict that.
Yeah. Well, I'm not as great at predicting it, but I think as far as being in private practice, one thing is I've learned is to keep things open-ended and super under-promise. So I mean, it's pretty critical, because
I think if you started at 2, you would have to anticipate that they would probably wear that night guide appliance at some point. And maybe you'd charge that total fee, but you're going to see that child maybe at least once every 6 months to a few years. So you can incorporate that.
Yeah, but it really isn't a lot of time. I mean, what's crazy is it's not a lot of chair time at all, unless you talk too much. Like, I usually end up just catching up with the family, and then all of a sudden it's 30 minutes. So, but there's just a lot of that involved with it. So, yeah, you know what, you're going to have to, and I know that Grant is just trying to figure out how to structure your pay thing too. So it just, I can't really answer that for you, and every practice is different. But if you're just talking clinically, you know what, clinically, I just start them, every case.
Can you walk us through, like, say for example, so when a patient of mine comes, say, because you did 5 years, so say I'm seeing a 5-year-old, because I'm still trying to understand, and it's a little bit not completely the process, the clinical process. So 5-year-old, if I see, and say for example, if they have a habit, say for tongue thrust, so I start with the habit corrector first.
Yeah, and sometimes that's just fine. So I really think that sometimes you just use the habit corrector and you don't have to do anything else.
How long
in
should I use?
our practice, we give them the habit corrector that same day, and then it gives us time to gather all the materials to send for the complete evaluation. So they're in that habit corrector 1 month, 2 months, and then we get the evaluation back, and then they go to their second appliance. And that's the whole process.
And she said it precisely correct, and I think we don't want to confuse ourselves, or maybe kind of, sort of, any of that stuff.
Yeah.
We want to be very specific, and what we did with our 30 patients and the subsequent ones is that day they got to have it corrected.
Yeah.
So they
because they can get them started, and then we send the information off, and then we get the
second appliance.
Right.
And how long do they wear the second appliance?
They wear it, if they wear it actively, if they're 7 or 8, they're going to have to probably, because we're catching up, probably have to wear it 1 to 2 hours a day actively and while they sleep. and they wear it to the age of about 12. When all the
Yeah.
patients come in, the
They
same
are
appliance.
wearing it.
So the same appliance they keep wearing.
So at the most, there's only
Oh.
every 3 appliances from the time they're 2 to they're 12. But usually it's just 2 appliances because you don't get them to their 5 rate. Does that make sense?
Yeah, now I understand because it
Yeah,
was
it's
like
a little, yeah.
there's a lot of appliances
There
over
is.
there, so it's confusing.
Yeah,
It
that's
is
what I'm
really
saying, we
confusing.
gotta be very precise, there's all this confusion, that you'll confuse the patient and nothing will get done.
Yeah,
You
and
put
I
them in a
don't.
habit corrector that day,
Uh-huh.
and we have a fee, okay, the fee we've established is $37.50.
Mm-hmm.
That may change, okay, right now that's the fee we've established, and we can always adjust and whatever else. But if you don't talk specifics, you're not gonna get started. And the habit corrector from day one of the peer committee is,
It gets them used to wearing an appliance, and then it's.
Well,
My own daughter, I put her in a habit corrector, and I was just telling Dr. Bergen, it's amazing that she had really flared 7 and 10 were coming in like this, and I can tell the pattern because my older child had the same pattern. I'm literally spending $8,000 in ortho now. She's 12 to correct the same thing, and I started the habit corrector September 1st. And by October 15th, the both laterals are coming down straight. And I know
Just with a habit corrector?
Just the I'm like,
Yeah.
that shouldn't work. That's not even an active appliance, it's a passive appliance. But if you catch them when you're young and they're plastic, they're looking for guidance, like where is this tube supposed to go, and you give it to them, and it's
Yeah.
amazing, I think.
yeah.
That was a great statement. They're looking for guidance.
Yeah.
So from age 5 to 12, patient is in one or the other kind of appliance, right?
They're
After the eruption of the second molar.
they're in the
that's
G.
end.
Yeah, pretty
Because
much.
at some time premolar is coming, at some time second molar is
Yeah.
coming, because then they have to be in appliances to guide them into the correct position.
Right. So.
And you should note that the appliance you get is the ideal position for those teeth even before they're there. So you're not changing the appliance at all, it's the same appliance.
Yeah.
Which is weird to me. I think, oh, it should be more customized.
Well,
than
because
that,
people
but-
are used to Invisalign, and
Oh,
they're
yeah.
like, "Oh, don't I?" And you
Change-
know
yeah,
what?
no.
And you're gonna hear that too. Like I talk to pediatricians about it, and they're like, "Oh yeah, I know. It's like Invisalign." And I'm like,
So it's fairly long-term treatment.
What's that?
It's long-term treatment, like you're
It
seeing
is, but
patient
you
from-
really don't see them like. So in the beginning, like you see them for a month, and then you maybe see them and depending on their compliance, you see them in another month. But then you can go like 2 or 3 months. Like for me, being rural, like I see people that live 3 or 4 hour drive away from me, or a plane ride away from me, and I won't see them for a long time. So this is just really ideal because, or even if they're 2 hours from me, I just have them. And once again, like the whole ortho issue, I have to bill some insurances every month. Well, I go ahead and just have the patient FaceTime me or send me photos of their child, and I just count that as like, okay, we know that there's progress being made. So when you were talking about like when you get like a 5-year-old, what you're looking for, and you really, if you don't see overjet, sometimes it's just like a slight overbite. I mean, there's a lot of things that you're like, oh, I need to put this kid in, just start them in something at this point. So.
And then they wear that until like 7 to 12 years.
Yeah, yeah.
Do we again have to change it or no?
We will change it to the G if they're started in the night guide. So if they were 5 and they were in the night guide, or depending on the eruption of their teeth, but we'll let you know. But now we're just starting everything in the habit corrector, so just give them the habit corrector.
And then, and they were talking about like 13 different sizes of the appliance.
So that only means the different sizes of your teeth.
So.
So.
Is a G appliance fit for you?
Yeah, so
And
they.
do I have to pre-wind or molds? We have to take molds, right? It's not pre-made.
Wait, say that again?
It's we have to take molds or impressions, right? It's
Well,
not
to
pre-made
size
or
it.
something.
Yeah, well, you just take them and then you can measure. Well, they're going to measure it for you. So you send them the copy of the mold. However, you send it to them. Like I have a scanner now, so I can just scan them things. But I actually take my own measurements. So, but then there's 13 sizes because there's different sizes of teeth.
And they ship us the correct size.
The correct size, right. So you don't have to worry about measuring.
And
Yeah.
say, for example, if the patient happens to, and that really happened. My brother, I actually gave him a retainer after his ortho, and that really happened. My dog, Juna, he actually chewed the place.
Right.
So, but because I was, it was free of charge for me, but I was a dentist, but then like, But so if it happens to a patient, so do we, if they lose their appliance, do we have to charge them again? How does it?
I do. Well, it just really depends on how the appliance is. If it's, sometimes they chew it and I just give them a new one depending on how it was destroyed. Sometimes they're wearing it so actively it gets destroyed, and it's just kind of a gut thing. If they lose it, then I charge them for it. But if they chew on it, just because some kids chew on it, then I'll charge them for it. But sometimes they're wearing it so much it gets destroyed, I'll just give them another one because I feel like they're wearing it correctly. And you'll kind of just get a gauge for that.
For the doctor, is it extra cost to order an extra one for them, or?
I think, is it? It must be. I always.
Well, I think we have had, our experience has been that you replace and the patient chews through their habit.
Oh yeah, no, we're guaranteed against breakage.
You replace it at no charge.
If used properly.
So because they're wearing it for a long time, and if they probably, I don't know, because I'm not used to it.
They don't chew for the active appliances, right? Just the habit corrector or something.
No, they'll chew through an actual.
I haven't seen it for the yeah.
They'll chew through that appliance because it's so soft. But the only bite through they get is from bruxism. They can bite 7 hours a day, and they won't bite through that appliance.
So to answer your question, if it's guaranteed like that and there's no cost to us, we would provide it. But of course, if they lose it, we're going to have to pay more money. Of course, we're going to have to charge them for it.
So they actually chew for the active appliance too.
Oh, I've seen them destroy it pretty good.
Really?
I mean, it just depends on the child.
Well, my kids, they chew for the habit corrector. They're good chompers, but I just given them their permanent one. I'm like, this is harder. You probably won't chew for this.
We have a family with 3 kids, and one of them chews through his habit correctors like crazy.
You shouldn't be chewing on the habit corrector.
We're expecting them not to, but they sometimes do.
They do. Or they brux at night.
Yeah.
Especially if they got sleep problems. I was going to ask you one question. How successful are you? What percentage of cases do you get a good result out of?
I'm going to honestly say it's probably about, well, through the whole time I've been doing it, I'd say 75% of my cases. But I have to say, in the last 2 years, like 95%, I've learned to choose patients a lot more carefully.
And when you didn't get success, was it compliance or was it anything else?
You know what? Like I just really like it. Like I said, like divorced families, I have to have them both come in. I'm just not even going to start. I mean, and then there's always like this emotional thing. And then if the child is not on board, I'll just tell the parent, look, we can't do this because your child's. I've sat in the room while like a daughter cries in front of me because their mom's so mad at them, and I'm just, they just need to be on board, and honestly, it's probably going to take a couple of times of really like failing and just saying, no, I'm sure this is going to work, and you can't always tell because like I said, I have some families where I'm sure it's not going to work, and we've literally gone not the 3 months and we're done, but the 8 months, and we're like all pulling our hair out, and then the kid will turn over and do it, and I'm like, oh my gosh, see, like, or I just have, and a lot of times I tell you the best and the worst are like preteen girls. I mean, they just, want to fight with their moms about this. But sometimes they're also the best patients because they really don't want braces and they really want their teeth straight. But when they're not agreeing with their parent, it's just like you're in this mini hell in your office for like 5 minutes because the girl's just in tears and she's just sad because she and her mom are fighting. I mean, these are like real life things that you just kind of have to deal with. So
that's what any failure you've had is pretty much a compliance issue.
Oh, it's always a compliance issue. No, it's not. It's all a compliance issue. It's all compliance.
And where we see impacted canines, and that's a short case for the braces, like.
Impacted canines?
Yeah.
It's not coming down with the ortho team.
Yeah.
And I just think this whole like process for me doing ortho and even the healthy start and the sleep issues, it's been pretty amazing for me because when I left Nome and I did a lot of impacted wisdoms and I did a lot of ortho, so I did a lot of surgeries, and when I left Nome, there were 3 cases I had with impacted canines. And I had little kids. Right now my kids are 10 and 12. But my kids were 3 and 5 when I left Nome. And I just remember thinking, why, like Nome is a population of 3,500 people. And I had 3, 10-year-olds, 11-year-olds with impacted canines that we had to surgically like pull it down. And I actually enjoy that. It's really fun to do that. but like why? Like why is that happening? So this whole like process of sleep, and I liken malocclusion these days to, it's not any different from heart disease, diabetes. Like the incidence of malocclusion is just like a social disease. It's like we've changed our diet, we've changed our habits. 200 years ago, we didn't have heart disease, we didn't have diabetes, we didn't have things. We were just different, doing different things to our bodies. And malocclusion to me is just right in line with all these diseases that we've just done to ourselves. So it's just been really interesting. And I think that's what we've done with impacted canines. I mean, I have this feeling there were not impacted canines 200 years ago, or even impacted wisdoms. So
I think some of the states that you're probably more familiar with, like the Inuits and stuff, where they haven't been socialized and done these things to themselves. They still don't have malocclusions.
No, you know what?
Jerky diets from breastfeeding. And
well, I'll tell you, because I was the prevention person in Nome, because it wasn't until, I don't know if you guys know what pilot bread is, but everyone eats this cracker that's tasteless. But it's really like in the 50s and 60s, westernized food was introduced to the population, and everyone just started getting cavities. Once soda came in, I literally fly to villages next to cases of soda, and me and all my dental equipment. So it's just, it's just stuff we've done to ourselves. And that really, there's not really many indigenous societies left that have not been touched by Western civilization, honestly. They don't exist anymore. So.
Okay, we brought the rest of the gang
All
back.
right.
Thank you so much, and I think we're going to hear about the different types of appliances. Yes. Right. So thank you, Dr. Hyde. What's next?
Good job.
Thank you. Has everybody gotten a survey, by the way?
Yeah, thanks.
Okay. Remember, this is what you have to turn in to get your CE credits.
That color looked so good on that camera.
Oh, really? Okay, that's good.
That looked gorgeous. It was beautiful skin tones and everything.
Do you need Michelle?
I don't know where she put this. I'm trying to figure out. It's the first time I've looked at all these new. I'll wait for Michelle, but I can see. Oh, here she
There
comes.
you go.
Where is she? Continuum of treatment. I'll have to get used to your.
It's on there.
Oh.
It's a
here, I should
7.
be
It
looking
was
here.
at the
It's
top.
easier.
Sorry. There you go.
Overview of treatment.
Oh yeah, she
That's
changed
continuum?
the name.
Change the name on me.
We have that little detail. I didn't change it there though.
All
Yeah,
right.
sorry.
Okay,
We'll
thank
blame
you.
Leslie on this.
Yeah, we'll blame her.
It's
Okay. See the mic. Oh, there you go. Is it on?
No, I turned it on. Yeah, we can turn it on.
Okay. Thank you. that okay?
Yeah.
Okay. Well, I think that presentation gives you an idea how somebody very similar to you is able to make it a success. Hearing it from me, sometimes you think, oh, he's an orthodontist, you know, he knows how to use it in a different way. But in a way, it is a very simple appliance, and it probably is the easiest of all functional appliances because you simply put it in, and if the child wears it the way you direct, it will give you a result. Very rarely do I not get a result if the child wears it the way I want them to wear it. And it will only correct what's wrong. When it's finished correcting that, it'll automatically stop. It won't go further. It won't go over. It won't overcorrect something. And if something doesn't need correction, it won't touch it. So it's really kind of an automatic thing. I'm going to talk about just kind of a review of all the appliances that we have, and just go through from one to the other. It's important that all of the appliances are FDA approved. All of the materials we use in the packaging and the boxes and everything else are FDA approved. All of our boxes have antibacterial elements in the injection molding that prevent them from getting mold. I don't know if you've ever seen a child that doesn't wash the inside of their box out for like a year, and there's mold growing in it and so forth. So anyway, that's, you know, everything we do is it is properly registered with the FDA, and they do come and inspect periodically, so we have to be on our toes. We also, I might mention to you one other thing, that the manufacturing, we run what they call an ISO manufacturing facility, which most big companies do, because they come in and inspect all of our records to make sure that we're treating every, we call them customers, properly in the way we promised to do it. So if somebody is not doing that, we can't continue with it that way. So it's very important that we do have that. And Procter & Gamble, Colgate, the different larger companies that are in business usually follow that very carefully, because we have to keep track. Anytime somebody sends an appliance back that's not working, we have to register exactly why it's not working and give them an answer why it is. So anyway, I'm going to go through and I'm going to talk about the different appliances that we have. We have a lot of appliances, and I keep doing things differently, you know. And the earliest appliance that we're developing right now is a toddler habit corrector for 2 to 4 years of age, and it's almost finished. It's being made right at the present time, but it's a small appliance, has a little handle on it, so it can be tied to their pajamas so that they don't lose it at night. And it also has a little handle that they can close their lips, and they can pull it against their lips and strengthen the lips, particularly for children that mouth breathe. Anyway, that's one appliance. It's a one-size-fits-all appliance. We have a habit corrector also for 5 to 7-year-olds. That is a similar appliance, but it's a little bit larger to accommodate all of the teeth, since the mouth is slightly larger. And that is a one-size-fits-all. We do have a youth snore cure, which isn't used very much. I'm kind of sad I ever developed it, maybe, but it can be used for children that have a snoring problem, that don't have any other problems present, sleep problems other than snoring, and that can be used to correct snoring. The thing is that it allows for a normal growth. It will not overgrow the mandible and so forth. So it's a little bit more difficult to correct snoring if you don't have other problems around. The C-Series is a night guide technique that's been around for quite a few years, and that comes in 11 various sizes, and they're sized, of course, to the size of the teeth of the patient. This appliance is intended to be used only for children that do not have first permanent molars in their mouth. If they have first permanent molars in their mouth, then we use what we call a G-Series. But there is something called an interim G, which is a softer G-Series appliance. It's not intended to straighten teeth, but it's intended to be worn at night to guide teeth into place. And so these two appliances, the C and the G, are softer appliances. We do make a harder C, but generally we usually recommend that you wear the softer one. It's sometimes called the softy appliance. We have a preteen habit corrector for 8 to 12, and that one includes the second permanent molars as well, but it is a one-size-fits-all again. There's an N series appliance. Somebody was asking me about straightening cases in the adult dentition, and this is the same as our original positioner that I was telling you about earlier in the day. So this appliance comes in 13 sizes as the G series as well. There are more sizes in these because there are greater numbers of teeth present, for example, and we do need larger appliances for some of the children. We do have an adult snore cure. This is for 20-year-older patients. We can advance the mandible 4 millimeters, and we have another one that advances at 7 millimeters beyond end to end for severe snorers. And these appliances work quite well in the place of a CPAP, for example. And if somebody goes on a trip and they can't take a CPAP, which is kind of a big bulky thing, they can wear one of these appliances. In fact, sometimes we have them wear that appliance in combination with a CPAP to prevent dry mouth, because if you get too much air in the mouth, you can get dry mouth, increases back decay and so forth. So it's a serious problem with CPAP sometimes, although most of the CPAPs give moisturized air, but sometimes that is not enough to prevent the dry mouth situation. There's another snore cure that advances it even more, 7 millimeters beyond end to end. This is for severe snorers and people that have almost a perfect occlusion. So it brings the mandible even further forward. It's almost impossible to correct all snoring in adults, but we can correct most of it. And snoring per se is not the important element. It's everything that goes along with snoring that's important. Because just to correct snoring eliminates the irritation of listening to a person snore, but they have a lot of other problems besides high blood pressure and hypertension, for example, cardiovascular problems, stroke, heart attacks, atrial fibrillation, and diabetes. So it's interesting and important that we correct some of those things. And then there's an oral shield. I have mentioned this before. We're making 2 sizes of that to fit for younger children that are in first phase orthodontics. And another one, it's just a shield that goes across the front of the mouth. It can correct the mouth breathing in children that are in orthodontic treatment. The disadvantage of it is it does not prevent the mandible from slipping back. So it is primarily used for cases in braces that have a mouth breathing problem. And then the other adult oral shield that's used for 12 years and older. So that's the gamut of these appliances. We have other appliances also. We make bumpers in 8 various sizes. We make little cleats that go into appliances and so forth. So that's the story on that. So the toddler habit corrector, this one has a handle out here, as I said, and they can pull on that handle. They pull their lips down over that appliance to try to strengthen the lips, so it makes it easier for somebody with a short upper lip to mouth breathe. I have never been tremendously successful at lengthening the lip on children, but we still try anyway. This is used usually between 2 and 4 years of age. It's a little appliance, but it still has a shelf to move that tongue in the maxilla. It has little prongs to prevent the tongue from thrusting. It has little tabs down below to keep the mandible from distalizing during sleep. It also can enlarge the upper arch. The child can push their tongue against the sides. There are many 2-year-olds, for example. My youngest patient that I've treated was a 2.5-year-old. He was in diapers, but he did a very good job. He wore the appliance very nicely. And so it is possible at these young ages. It depends on the child, really. Girls are a little bit better than boys, I'm sure. By 4 years of age, it's easy to get a child to wear an appliance. So get tremendous changes before they start school. So you can enlarge the upper arch. You can correct the thumb sucking. You promote nasal breathing You eliminate the mouth breathing, which is a terrible habit to have. It's one of the most serious things that a child can have as a young person. And it corrects swallowing problems and tongue thrusts, open bite, improves speech, and prevents posterior mandibular drift, which is what I call when you sleep on your back and the mandible drifts back and it closes up the airway. And it corrects snoring, and it is available, obviously, for different ages and different occlusions. It is a one-size-fits-all appliance as well. I mentioned to you earlier that we start out a child with a habit corrector, and there's not always a reason for doing that, but it does give the child an immediate response to what you're looking at, particularly if they have sleep problems. If they only have one symptom, I might wear that appliance only 1 month. But if they have mouth breathing during the days or nights, I will have them wear that appliance indefinitely until they can correct that problem. That problem may take several months, maybe a year even, to correct in serious cases. So they would wear that indefinitely at night. Now the problem is that we maybe are at the point where we want to start straightening the teeth with one of these appliances, and that appliance is supposed to be worn at night also. So instead of wearing that one at night, we wear the habit corrector at night, and we wear that one maybe an hour or two passively during the day. And that's enough to guide these teeth into place. So we can work with both appliances, and it's important that the child particularly wear that one, because to me the sleep problems are more important really than the problem with the occlusion. So this is very important. So we start then straightening the teeth, and we start this when the lower incisor first breaks tissue. And we size the appliance according to the size of that tooth. Now, if you want to really size the appliance yourself, you can take the width of that tooth and multiply it by 4, add a millimeter, and that's the size of the appliance that child will need after the teeth are fully straight. You can take about half that size and start them out with that, and then the other size would be beyond. But you don't have to worry about that, because we can figure that out on our own, and we'll supply you the appliances. We find it easier if we just supply you with the appliance and let us measure it, and we do it by computer, so it makes it a little bit more accurate. Now this child wears this appliance while the centrals are coming in. And the centrals are going to widen that arch about 3 millimeters. And once the laterals start coming in, now we need a bigger appliance. And that appliance might be 2 half sizes bigger than this one, or it might be 3 to 4 to 5 to 6 to 7 half sizes bigger. Now, if it was 6 half sizes bigger, that's 3 millimeters bigger in the anterior arch. Now, if you anticipate that you're going to be stripping deciduous molars, for example, to gain the room for teeth, we might go up several sizes in order to make sure that the appliance is going to fit after the teeth are straight. The object is that this last appliance is going to fit the case almost perfectly when the teeth are perfectly straight. Okay? So we're gradually getting up to that point. The reason we don't go directly to this bigger size is that children have a hard time adapting to that, and they won't wear that bigger size. So they wear a size halfway in between, and then they get used to it. Then you can skip several sizes, 6, 7 half sizes. You can skip, and the child will be okay with that. Okay, so that's the system that we use. We don't ever use more than 3 appliances. That's basically what we use. This appliance then would be used up until 12 years of age as a retainer. So they're never going to outgrow that appliance. Even if they're 50 years old and they want to straighten their teeth, they still could use that appliance. Okay? So these are the 3 appliances. The Kids Habit Corrector is one size fits all. This we send the appropriate size to you. You don't have to worry about sizing them. And this is used as the lower centrals are up, and this is used as the lower laterals are up, as well as all the upper permanent incisors. And then it's used also as the canines and bicuspids and second molars are up as well. Once the second molars come down, if you're still wearing that appliance, it doesn't cover the second molars, so your second molars might super erupt. Now there are some times when we have a very deep overbite, and I want to make sure I hold on to that. I might have them wear this appliance even after the second molars are fully erupted to allow them to super erupt, and we can open the bite. Now, a little boy came in one day to me, and his mother complained. She said he's developing an open bite, and we're very concerned. His teeth are opening instead of being held nicely closed together. And so I asked the boy, I said, do you have your appliance? And he said, no, I don't think so. I said, I bet your mother has it. Why don't you go out and bring it from your mother? So he comes in, he's very slowly walking, and he has his hand kind of in back of him. He's hiding the appliance from me. And I know what he's done. And I tell him, can I see your appliance? And he very quick, very slowly brings it up. He doesn't want to take his hand off. Finally, he takes his hand off, and he's cut the back ends of that appliance, about a ½ inch off, because it was bothering him, because his second molars were erupting. Well, now the second molars super erupted, and they drive the bite open. So because of that kid's mistake, I learned something. I learned that we can open the bite tremendously if we use an appliance that's too short for the child. So sometimes we take this appliance and we use that in an adult to open a deep overbite. Works very well. In fact, we developed, because of that little boy, we developed what we call a softy appliance, which precedes orthodontic treatment by about 3 or 4 months. And we could advance the mandible and open the bite. And by the time they start orthodontics, it takes half as much time to correct the case, because overbite is so difficult to correct. So, you know, the simple use of that appliance, if you know how the appliances work, sometimes you realize that something's happening very nicely. One time, a patient many, many years ago came in, and the appliance was all white, and I thought, what's going on here? So I decided to get a patent on that, and we combined 2 different plastics, one that absorbs moisture and one that doesn't, put them together at the right percentage, and we could then determine how much time the kid was wearing the appliance. In fact, they used plastics years ago in milk bottles that the milk would turn the bottle white, you know, so they developed plastics that would not do that. So we have a very hard time getting plastics that will actually turn white, because I want them combined with the other, and we can determine. So if a child wears the appliance only at night, it's kind of translucent. But if they wear it 2 hours a day and at night, it turns it perfectly white, and within 48 hours it goes back transparent again. So we can tell that if a child comes in and puts the appliance down, it's perfectly clear. I don't even look at them. I say, I see you haven't worn the appliance at all. Oh, yes, I have. I said, no, I can tell you haven't worn that appliance. So if, you know, children are very devious. Sorry to say that. W.C. Fields was a comedian a long time ago, and they said, how do you like children? He said, medium rare. Anyway, they did a lie detector test at Loyola University in Chicago. A student put about 25 orthodontic cases on lie detector tests. He asked, did you wear your elastics yesterday? Oh, yes, I did. You know that 75% of the kids flunked their lie detector test because they were asked something like that? So you can't always believe kids, and they'll fill out in this little form that we have them fill out, and the lines are marked all the way across, 1 month. Same color pencil all the way across. They filled that out 5 minutes before they came in the office. So you look at the individual way they mark them. If they use a different color crayon periodically, and they do it vertically, you know that they're keeping track of that every day. And if they're proud of what they've done, they will bring that in. If they don't bring that in, they're not too proud of what they've done. So you can tell a lot about how a kid is cooperating by just the reaction of that kid. If a child walks in the office, they dump themselves in the chair, and they tell their parents to get out, they don't want to have them around us, you know, I stop right there and I say, you know, if you don't work with me, we're not going to do this. And there are cases that we refuse to correct because I just don't think that the child is going to cooperate. But sometimes they do fool you. And sometimes a child that looks like it's never going to cooperate ends up being a wonderful patient. So we found that girls cooperate 80% of the time, boys cooperate 60% of the time. I don't know if you remember in grammar school, boys would throw spitballs and pull girls' hair and all different things like that, little immature things. And as they get older, they get more mature. There are some men that never mature, however. But that's why girls are much better students in grammar school, and they're more advanced. They're much more adult-like acting. So boys are the ones that suffer mostly from sleep apnea and sleep problems. Girls do not react quite as much. Anyway, this is a night guide appliance in, and we make sure if there's going to be potential crowding that it's too big for the dentition. We want it at least 2 sizes bigger than what we would normally measure. So we know how far over to measure for that appliance. And then we put it in. This child has a very deep overbite, if you notice, and how beautiful the overbite is corrected. It's a perfect class 1 occlusion. Now sometimes when you're done, the occlusion isn't perfectly coordinated, but you wait 6 months, maybe a year, and the teeth are usually perfectly intercuspated. So it does take time for teeth to settle into place. 93%, as I told you before, are candidates. So it is a almost uniform type of an appliance. Almost every child is a candidate. And over 95% of them will correct. And it will correct crossbites, TMJ, gummy smiles, overjet, overbite, and crowding rotation. So these are almost the gamut of most popular. The 3 most popular things in orthodontics are these 3. And then you have all sorts of other things. There are about 15 other items. But the appliance will correct almost all of them. And what its advantage is that it does everything at once. There was one patient that you showed up here that had braces on, and I had to go through 5 stages to get that stage corrected. We had to level the teeth first, and then we have to start distalizing bicuspids into the leeway space to get room for the crowding in front. Then we had to start correcting the overbite before we corrected the overjet. Then we corrected the overjet. And if you skip any one of these, steps, you lose track and it doesn't work right. And then the 5th step is to artistically position the teeth. So each step takes anywhere from 3 to 6 months. And by the time 2 years is done, you should be done with that patient. That patient took me 30 months to correct with about 12 hours of my time. And when I took a look at the end result, I was disgusted. It was a beautiful result. But when I realized that she could wear that positioner 2 hours a day, I realized I could have straightened that case in 4 to 6 months. And so this is one of the problems. When I see children with a mouthful of braces and a headgear and rubber bands and everything else, I think, oh my gosh, I could straighten that case in 4 months. And it's kind of interesting how complicated sometimes we make orthodontics. I had about 8 orthodontic friends of mine come to my office when I was first developing this. And they were all good friends of mine. And I showed them a case, and I said, how long would it take for you to correct that case? And they all said, well, about 2 years. They told me what they would do. Then I showed the result to them that took me 4 months to correct that case. They couldn't believe it. And one of my good friends came up to me and he said, Earl, I can't use your appliance. And I said, why? He said, it doesn't make me look like an orthodontist. It's too simple. And maybe it's justification of fee, maybe not. I don't know what it is, but sometimes it's a matter of being too simple. And I can tell you another interesting story. In just south of Cincinnati, there's a dentist down there by the name of Woody Oakes. I don't know if you've ever heard of him, but he publishes a magazine on the profitable dentist. Very clever fellow, but he used my appliance for many years, and then he became disabled that he couldn't do that, so he publishes this journal. And he had a patient that went to the orthodontist, and the orthodontist said it would take 2 years and so forth. And the patient said they would think about it. The parents said they would think about it. So they came to him. And Woody Oakes put our appliance in and straightened it out in 4 months. And the orthodontist secretary called and she said, we saw you about 4 months ago and we were wondering if you were still interested in having orthodontics. And the mother said, it's already been done. We're all done. We're done with orthodontics. She said, would you hold the phone a second? She got the orthodontist on the phone. He said, I think you misunderstood. You said that the orthodontics is done. She said, yeah, the teeth are perfect. He said, would you mind bringing that patient over to the office? Which she did. And he looked at this case, and he looked at his original records. He couldn't believe what he was seeing. He never used the appliance. He never used that appliance because he thought it was a little bit too dramatic from what he was normally used to doing. So sometimes we have a problem that way. But this is a perfect case. I couldn't make that case any more perfect if I put 2 years of braces on that case. Can't do it.
I think another important thing about what you're doing with these appliances is that the class 1 is not a class 1 is not a class 1. A lot of the orthodontically corrected class 1s are pushing that mandible back to get their class 1 and they're compromising the airway, whereas with your appliances you're encouraging that down and forward growth to keep a nice airway.
Well, yeah, to tell you the truth, when I was in Brazil, the orthodontists were always looking at the molar relation in a mixed dentition. I said, forget the molar relation in a mixed dentition, because as the deciduous molars are lost, those molars will come forward and adjust to a class 1 occlusion. I said, the molar relation doesn't make any difference at that young age. I said, check it when it's 14, 12. Then you can see what that molar relation is. So we don't worry about that. If the molar relation is way off, if it's class 2 on one side, class 1 on the other, it'll correct both sides to class 1. I'm not sure how that works, but it does. And so regardless of the molar relation, class 3 is the only one that we have a difficult time with. But it can be class 2, it can be end-to-end, it can be class 1. Class 1 is the way the molars relate perfectly. The lower molar is a half cusp beyond the upper arch. End-to-end is this way, and a class 2 is further back, where the mandible is too far back and the maxilla is maybe too far forward. So it can correct both ones, but we correct class 2s by advancing the mandible, as you were saying. Treats lower crowding and rotations. I showed you this case before. This case only wore, as long as the rotation isn't beyond 90 degrees, it could rotate it the other way. So it has no brains to rotate that in the right direction, but if it's not quite 90, it'll rotate it around. As long as there are no fibers around it, it'll rotate that tooth very nicely and bring it into position. So, sometimes the more complicated the case, the easier it is for this appliance to wear it, to correct it. And why I say that is if you have just one little rotation on a front tooth, and you correct that, if there's a relapse, it's 100% relapse. I think sometimes it's easier just to, do it with a Hawley retainer or something else. But if you have a complicated case with a deep overbite, a severe overjet, telescoping bite where the lower fits entirely within the upper arch, I could spend 3 years correcting a case like that with braces. 6 months with this, it would correct it. So the more difficult it is orthodontically, is the easier it is to correct. So anytime you have an overbite or overjet, it's going to complicate an orthodontic problem for the orthodontist. But with this appliance, it eats that up like crazy because it will adjust that all at once. And it does all these steps at once. It does everything. I was explaining the one case that we had to put light wires in to level the teeth. We had to then rotate them. Then we had to bring the bicuspids back into the leeway space with a bumper. Then we had to correct overbite and overjet and artistically position the tooth. This appliance does it all at once. So it combines all these steps at the same time. You're doing everything at the same time. That's why you can correct a case in 6 months rather than 2 years. But the other factor is probably the blood circulation, because when they exercise, they increase blood circulation. That increases the speed of tooth movement. So here's an upper lateral that's severely rotated, and you can see how it's bringing into place. I mean, you wouldn't think, how can you do that without a brace? Putting a bracket or something on it, but it did correct it very nicely. Overbite. This is an extremely deep overbite. You have to get in the habit of looking at a deciduous overbite and realizing that it's going to be 2 millimeters more in the permanent dentition. So this is going to be an extremely deep overbite down here, and the whole incisors on the lower are going to be covered. That would take me at least 2.5 years to correct with braces at about 1/10 of a millimeter per month. This case will correct 1.25 millimeters, 10 times as fast sometimes, to get that corrected as you see over here. Another one with overjet, correct. Now I don't care where the deciduous teeth go. I'm not worried about that. Sometimes they're this way, that way, and as they get loose, they're all over the place. It's the permanent teeth that I want to look at. So when we look at a patient in an appointment, We look at what's changing in the permanent dentition, not the baby dentition. And I showed you this case before. This is interesting. We analyzed a series of cases with the joint problem for young children, and we also analyzed the joint problem in cases that were not treated. And you can see the increase in joint problems, tremendous increase at around puberty. And this happens mostly in girls. Now, women have an extra hormone that allows the expansion of joints so that they can have birth of babies. And it's called something like expansion. It's a funny name for a hormone, but it allows the joints to be more flexible. Well, it also allows the temperament of the joint to be more flexible, so they have more joint problems. And this is the result of orthodontic treatment for 2 years for children that had joint problems. You see that it never got it down to this level or this level. Orthodontic treatment, according to Perry many years ago, indicated that it does not correct joint problems. You can't say that orthodontic treatment, because it's used, will correct your orthodontic problem or your TMJ problem. It simply doesn't. Now, if you put splints in, you could correct it more readily. But just because you have orthodontic treatment doesn't mean that your joint's going to be corrected, and usually it is not. So, on the other hand, when we put one of these appliances in at any age, we can predict basically if their joint problem is going to correct, particularly if they're going to have eruption of back teeth. So in an adult, we might tell them, we might not get that eruption of the back teeth for maybe a year or two. Or we may never get it, and then we have to put brackets on to extrude the teeth into place. But usually that eruption will come, but it's very much slower. In a younger child at 10 years of age, it's really no problem at all. And so the C-series is used for, is used for crowding and rotations, overbite, overjet, gummy smile, crossbite, TMJ, and so forth, all down the line. You do not have any decalcification. No root resorption. There was a study done in Brazil on potential root resorption. There was no root resorption. The minute the braces were put on, there was root resorption because of the uncontrolled forces. So I have asked people if they get root resorption or decalcified tooth, if they notify me. I have never been notified in the 45 years that we've been in business, ever having a report of non-vital tooth as a result of this. So you don't have to worry. As a matter of fact, root resorption, you cannot resorb a root of an embryonic root. So even if a tooth is undeveloped, you do not get resorption of that root. But if you're biting on an undeveloped root with biting forces, these are uncontrolled forces. So we tell you, if you have an undeveloped root and you're wearing this thing very actively, you have to be very careful. I think it's worth an intraoral x-ray every maybe 6 months to make sure that the tooth is going to be okay. If they get hit in the mouth, say with a baseball, and it damages the tooth, we send them off to an endodontist and let them, or the dentist if he wants to do it, but as long as we can get permission from him that we can continue, then we'll start treatment again. I had a boy that was hit in the mouth with a baseball, and he had terrible pain in his teeth. We discontinued his treatment. He saw an endodontist. At about 4 to 6 months later, the endodontist said, you can start, okay, it seems to be all right. We started treatment again, and he started to get pain in that tooth again, so he stopped again for another few months, and until the endodontist told us again we could presume. Then we ended treatment, and it was fine, no problems. Now, one of the things you can do, if a child has a damage to a tooth and it's not fractured off, they can get internal fractures of that tooth, and they might move that tooth, and the root end moves, and it can create damage to the blood circulation, and they form scar tissue at the root end. So now the amount of blood coming into that tooth is reduced considerably. So that tooth is more sensitive to being devitalized during treatment than a tooth that's been fractured off. So we take our dental light, we can focus it on the tooth, put a mirror behind the tooth and put our finger to shade the tooth. You can look right straight through that tooth. You can see internal cracks in the dentin. And if there are internal cracks, we will tell the patient that they probably had damage to that tooth. They've broken some of the internal parts of that tooth, and we would watch that tooth very carefully. If they fractured the tooth off, you don't have to be so careful because that tooth now is still healthy, but it didn't sustain the blow. It fractured instead. So you can use that as a guide. Now they close the guide, G series, and we heard Owen talking about this, and she related a lot of her own cases, which I thought were very interesting. I thought your presentation was tremendous because it showed you what her experiences have been over the past several years. Here's a boy that he wore this appliance, and you can see if the bicuspid is coming distally or buccally or lingually, as long as the tip of that cusp is within the confines of that socket, it'll guide that tooth in. So we're going to guide the teeth into the perfect spot. These teeth are arranged according to a perfect intercuspation of teeth, mesiodistally, buccolingually, and so that those teeth erupt exactly where they belong. No other place for them to erupt. If a tooth's erupting in the wrong spot, for example, if a canine is coming between the central and lateral, you can't do that case. You forget that case. If the canine is going to be impacted, you forget that case. Now maybe, if you have a good relations with an orthodontist, maybe you could correct the overbite and overjet and the sleep problems for that child and then send it to the orthodontist, or have an orthodontist bring the tooth down, or if you can do it, you would bring the tooth down. But generally, I don't recommend that you do it. But she's up in Alaska. There's nobody around her. She has no other choice, you know. But she's experienced at braces. She's been using them. If you feel experienced at that, do it. But you have to know your own limitations. So you don't do things that are beyond what your capabilities are. And as a general dentist, you have to be a little bit more aware of what you're doing. A case walks into my office, I cannot refuse them. I don't care what it is. I'm supposed to be capable of treating any child that walks in. You have the wonderful ability to refuse a case. If that case is not the right case, or not going to give you success, you can say, I'm sorry, but this exceeds the limits of our appliance. And if it does, I will notify you. And that's done to keep you out of trouble, so that you don't get into a case and get halfway through it and you can't do anything with the case. Anyway, this boy had a 13 millimeter overjet. What a beautiful occlusion he has at the end. I'm not showing you failures. I have some failures in here, but these are all kids that wore the appliance properly. If they don't wear the appliance, they don't get any correction. If he didn't wear the appliance, he would not have gotten that result, obviously. And then we have the ortho T. This is from 13 years to adult. Now we're more limited in what we can do because we don't have growth. And a child that has a deep overbite, we need as much millimetric growth between the base of the nose and the bottom of the chin as the overbite we're correcting. If we want 5 millimeters of correcting, I need 5 millimeters of growth between these areas. And that's not true with the night guide, because the night guide, all we have to do is stop the teeth from erupting, so we don't need that extra growth. So we have limitations. We limit it to 4 millimeters of overbite and overjet correction, because beyond that, all you're going to be doing is tipping teeth, and that's not satisfactory. So this is used after the permanent second molars have erupted. And we use it actively, 2 hours a day. The speed of correction is exactly the same as a mixed dentition case. 8/10 millimeter a month for overjet and 7/10 millimeter a month for overbite. It works the same way. Very misleading, because you'll get good correction, but you'll get tipping of teeth. So our orthopedic bone change is very low. It might be 10%. So our tooth movement might be 90%. So we have a 90% risk of relapse in such a case. Yeah, but frequently we use other things with it because we're out of space. There's no space. They're more difficult, so we have to use bumpers and headgears and different things. So anyway, that's the story on that. So we have them in different ways. They come in N, X, and U. X is for 4 bicuspid extractions. U is for upper bicuspid extractions. If you have a case that's been treated orthodontically where they took 4 bicuspids out and it's relapsed, you could put an X series in, and it works the same way, except it's missing 4 teeth in the appliance. And there's 13 sizes of that as well. We also have a class 3 corrector. This is an interesting appliance because it has no margin above. It has 3 little tabs up here that the patient pushes their tongue, and it pushes the whole premaxilla forward and pushes the whole front of the dentition, the maxilla forward. And then it has what we call a bumper area down here. It's a thickened area which limits the forward movement of the lower teeth and actually can distalize the dentition. And this can correct a pseudo class 3. This boy was corrected over a weekend, but he wore the appliance full time. Now, I tried different ways, and this was several years ago, but he corrected that over 1 weekend. He wore it all day long, Saturday and Sunday, and corrected the case. So it can be done very quickly. One size fits all, but this is a fairly recent appliance, but it's a very successful appliance. You won't find too many class 3s in your population here, but Asians have 3 times the number of class 3s as the Caucasians do. So up here, again, it's an appliance with a very large amount of plastic in front. So it covers the mouth. I don't care how far they open their mouth, they cannot breathe through their mouth. And if they don't breathe through their mouth, they breathe through their nose, they don't snore. You don't snore without nose breathing. So anyway, it's used for children that are adults, really 20 years of age and older. And if they don't have any overjet, we usually use a more severe one that advances at 7 millimeters. If it's got an overjet and a minor snore, we use this one, Snorcure 1 or Snorcure 2. Oral shields, we also make these, prevent mouth breathing at night for children that have braces on their teeth. And bumpers, we use bumpers. These bumpers are amazing because they can distalize the teeth with lip pressure, and we can pick up spaces, particularly in the adult dentition from this. And they have several features, and you know, they're customized from customized bumpers that I used many years ago. And if you get enough distalization, you start trimming off this shield. This is polypropylene. You can heat it and bend it with your fingers to mold it to the mouth. It doesn't gather up food and so forth. It has little hooks. We tie it in on one side. If they're right-handed, we usually tie the left side. And then we have a little nut that goes on there. You can advance this bumper every month. The disadvantage is you have to see the patient every month. But we will supply you everything that you need for that. The bands, we can estimate the size of the bands from their models that you send us. And we send you the bumper, the little, we call them Gurren locks and so forth. So it's a very handy appliance. Orthodontically, it's one of the most amazing things I've ever used in my life. Anyway, hey, I ended a minute early. Is that okay? Any questions that you might have? How come you got all the questions? You got all the questions, I get no questions. They're all questioned out, I guess. Anyway, I want to thank you, Grant, for having us come and speaking to you. And
we're so pleased that you were here to do the presentation.
We're looking forward to Saturday.
And Saturday, we're looking forward to a good day. Okay, which is a reminder, Saturday we have the clinic. You're bringing your child. You're going to come early if you can. Bring your friend. Let's see. And we have some other folks coming. Remember, Saturday, if April's going to work with one of her family members with you, this will be Saturday. Anybody else bringing anybody Saturday?
Please join us tomorrow morning from 8 to 5.
If you know of any family members